First, I would like to welcome Dr. Rajiv, the professor and head of neurosurgery at Kozhikode and the organizing chairman of Malabar Neurocon 2023. Welcome, sir.
A very good morning to all of you, and warm welcome to this Malabar Neurocon. Malabar Neurocon, the annual state conference of Kairali Neuroscience Society. On behalf of the organizing committee, I welcome all the delegates, all the speakers, and all the participants to this event. Thank you.
Thank you, sir. We will be commencing with a free paper session. I would like to invite our chairpersons, Professor Paritosh Pandey from Manipal, Bangalore, Professor Girish Menon from KMC Manipal, and Dr. Jyotish LS, Professor GMC Kotte.
Sorry, I think we are already late, so let's get the ball rolling.
So we'll...
Shall we start?
Yes. Our first presentation is by Dr. Naveen Haridas V.
Just before we commence, Rajiv and Murli, do you want to just reinforce the rules again? The time and the Murli, Dr. Murli. I think this includes awards also, no? Murli. Yeah, this Murli, you want to just tell the delegates the rules?
Basically, all the free papers will be judged. Our papers from the consultants will not be judged, and the time allotted for presentation is 8 minutes. There will be 2 minutes for discussion with the panel, and this will be independently judged by another judging panel. And it should be noted that all the presenters should be registered with Kairali Neurosciences Society, ideally to present here, at least for award selection. Thank you.
You had sent us send the rules, no, that about the time and
yeah, that's so 8 minutes.
Yeah, that is an auto just for all the speakers.
Yeah,
it's automatic disqualification.
Yeah.
If you exceed the time, you just won't be considered. Am I right, Mulli? Yeah. If you exceed the time, you won't be considered for the prizes at all. So that's an for the prize for the paper. Is it? Because that's what I just wanted to clarify, because Murli had sent her this thing that if you exceed your negative, some negatives for that they will decide. No, because you had sent her this thing, so. Okay, let us just start.
Good morning, respected professors, dear delegates, a warm good morning to all. I'll come to my paper presentation. Box technique or wide laminophyseectomy decompression with instrumentation, and initial results and review of literature. Coming basic to the anatomy of ligamentum flavum. The ligamentum flavum is a paired ligament that runs from the lamina of the adjacent vertebrae starting from C1, C2 to the L5, S1 level. Each ligament passes from the anterior and inferior aspect of the lamina on the cephalite vertebrae to the posterior and superior aspect of the lamina on the chordoid vertebrae. Its lateral margins usually extend up to the articular processes, and both the ligamentum flava on either side, they join at the interspinous ligament, and they blend with the interspinous ligament in the middle. Now coming to the ossified ligamentum flavum, it's an endochondral ossification of the ligamentum flavum, and it's part of the degenerative process. Predominantly, the elastic fibers within the ligamentum flavum loses its orientation and they gets replaced by collagen fibers, most commonly seen in the lower thoracic levels and presenting with usually with a case myelopathy. And the initial presenting symptom is usually a sensory symptom and followed by motor weakness and then imbalance while walking. What are the challenges in this? It usually gets diagnosed very late. At the presentation itself, there is a significant cord compression, dorsal cord compression, and even myelomyelitic changes. And while doing the surgery also, there are high risk for a neurological deterioration. And because the laminectomy is inadequate, just doing a laminectomy is inadequate, there is a high chance for recurrence also. And every surgeon knows reoperation is always difficult. Now coming to the usual surgical approaches that has been employed. The first one is a decompressive laminectomy, then laminoplasty or laminectomy with lateral fusion, and total laminectomy in addition to resection of the ossified ligamentum flavum. The basic problem while facing these classical surgical approaches were that there is a high chance for dural injury because there is always adherence with the dura in case of ossified ligamentum flavum. So we are putting forward a box technique. Box technique initially means that surgery using wide laminofascectomy with instrumentation. Here in the small box we can see the drilling of the lamina and the facets lateral to the ossification is being done, and the instrumentation is also done at the end, which also compensates for the loss of the facets that is happening, and this this prevents the immobilization of the micro movement post surgery, which are responsible for the recurrence at these levels. Now, why it is called a box? Because the area that has been drilled out, the attachments of the flavum, so that you can see starting from the pedicle to pedicle and extending into the lower pedicles also. So the entire that area within the box has been removed, and this provides an easier access and a good way to approach the ligamentum and safely dissect it away from the dura if there is an attachment. So I'll play a short video here. You can see the drilling going on. The lamina has been removed up to the level of the pedicles after instrumentation has already been done. And same, we are taking it as an in block. Now the ligamentum, the thickened ligamentum is being maneuvered out. And then the hemostasis has been achieved. So the short video just to explain what exactly is meant. And now coming to the present study, the material we have all the cases, consecutive cases in the last 1 year which has come to us with case of ossified ligamentum flavum has been involved. There have been 7 patients in total, 4 were males and 3 were females. All were above the age of 50 years. MRI was the usual investigation of the choice, and all the cases were followed up for a minimum period of 3 to 6 months. And now the distribution, the 3 major presenting clinical features were there. One was most of them, all of the 7 patients had sensory symptoms involving the dorsal column. 6 of them had motor symptoms with weakness, and 5 of them had bowel and bladder involvement. Now the levels involved predominantly in our study was D9 to D10, followed by D10, D11 and D11, D12 in the ascending order. There was a contiguous segment involving the L1, L2 also. Now coming to the case samples, the 74-year-old male with presenting with history of walking difficulty of 3 months duration and myelopathy and sensory level at D10. So this was the axial and the sagittal images showing the ossified ligamentum flavum causing a cord compression. Now the CT images showing the thickened and ossified ligamentum flavum again. Now one among the cases was a recurrence. Again a 68-year-old male presenting with thoracic myelopathy at D10, D11 levels, and he had underwent an already excision at laminectomy and excision in 2011. Again presenting with weakness and paresthesia and myelopathy, and the same was done. This is the image here again. So the surgery was laminectomy and discectomy, and transpelvicular instrumentation and stabilization was done. Postoperatively, he was walking independently immediate post-op, and he was independent on all activities, and he was self-voiding also. Now coming to discussion, there are Sato's classification to classify the ossified ligamentum flavum based upon the extent of involvement. So the first one is lateral type, only at the lateral end, then the extended type, the enlarged type, the fused in the middle, and the tuberous type. So when considering the cases where there is recurrence at the same surgical site, the most common reason for the recurrence was that the micro movements that was happening post decompression. So that causes there will be an increased intervertebral range of movement at the level of the laminectomy, and this causes for further re-extension of the ossified ligamentum flavum. And why it is recurring at the level of the thoracic level? So mainly because the rigid thoracic vertebra transits into a more mobile lumbar vertebra. So at the thoracolumbar junction, the stress will be maximum, and this is one of the cause for recurrence at the same level. And high tensile strength in stress over the posterior column is the main reason why it presents with a dorsal column sensations initially. Now, with cases with multi-level ossified ligamentum flavum, the post-surgery, post-laminectomy alone, there is high chances for a late onset thoracic kyphotic deformity. So, we have the instrumentation has been advocated to avoid this focal mechanical stress, and reports have suggested that the JOA recovery rate at the at 1 year of end, in cases where fusion was done, is better than where no fusion was done. And in cases with high BMI, there can be severe ossification due to increased mechanical stress, and so in that specifically instrumentation is also advocated. Now, in cases where we have done the laminectomy, the mobility of the spinal cord and spinal column as well as the nerves are still there. So the small vibration, mechanical motions will be there, and this can hamper the recovery of the spinal cord, that segment. So fusion surgery can promote the spinal cord recovery, and it is very reasonable to perform fusion surgery for patients with more severe ossified ligamentum flavum. So coming to the conclusion, the box technique is safer and effective surgical approach for flavum, and all patients in our case have improved after surgery, but still further long-term prospective studies are made to come to a final conclusion. Thank you.
Thanks. Just wanted to, what was the added advantage of taking out the facets over just doing a laminectomy?
So we go beyond the attachments of flavum so that it is
More
easier to
space.
mobilize and move.
And this micromobility which you are talking about, is there some way of assessing this micromobility? That's a common term which is being used now. How do you objectively say that there is micromobility? Is there any technique, mechanism? Because that is proposed as a reason for instrumentation in almost all cases now. Is there some way to assess and quantify micromobility?
So note that down.
There are different types of ligamentum flavum hypertrophy I will describe. Do you do the same technique in all cases, or box technique in all cases?
So, all the 7 cases we are having lateral or diffuse ones.
Because the dural involvement is more common in the fused and tuberous type. So is it necessary to do the facetectomy in other cases?
So being a safer technique now, we are following that. So otherwise, only advantage of this is a better exposure and better delineation, and we can dissect off the flavum from its attachment itself. So it becomes easier further progression. So the dural attachment of the ossified ligamentum flavum can be prior identified while doing such a maneuver. So that is the one advantage. So that's
So most of the Japanese studies show they do only laminectomy. So if you avoid this thing, can you, if you avoid taking out the facets, is it possible to avoid? Is it not possible to avoid the fixation?
Sir, the studies that simple laminectomy alone, there are chances of recurrence, and the fact that we need a space for the spinal cord to recovery also, avoiding the micro. These two have been proposed to use the fusions.
Yeah, one question basically, how do you quantify? Basically, you have not scored. You have all these numeric scoring and Japanese Orthopedic Association scores. So how did you score pre-op and post-op? I didn't see that in your study.
Sir, MJOS scores were used, sir. Modified JOS scores were used. So so because of the shot, there was a master shot there, but because there is a lack of time, so I didn't.
I mean, it was a very good presentation. And other thing is that you are proposing a new kind of approach to the OLF. Why? Because when you go through the facet, you have a definitive dura there, and you have a definitive good plane without attachment, and you are seeing the dura and coming back.
Yes.
And then there is a concept of micro instability where fusion helps. So these two are the new things you are proposing, which I could make out from your paper.
Yes.
But you could have analyzed more, like you should have given the pre-op and post-op scores of patients, images, complication rate, all those things. That will make a better paper when you write the paper.
Yes.
This is a suggestion.
Yes.
You may go.
That's why, sir, we have concluded also like that. We need
Yeah.
further prospective studies.
Thank you, Haridas.
Thanks, sir. Thanks.
We call Dr. Mohammad Mansoor, and he will be speaking on posterior ligamentous complex integrity determined using ultrasound and severe thoracolumbar fractures. Okay, Mansoor, your time starts now.
Good morning, teachers and delegates. So today, myself is Dr. Mansoor. Today, the topic which I am going to present is predictive value of ultrasonography in determining posterior ligamentous complex integrity in thoracolumbar fractures. So, integrity of the posterior ligamentous complex is a crucial determinant factor for operative treatment in thoracolumbar fractures. So, identification of this posterior ligamentous complex integrity can be done by MRI and USG. So, here we have a multiple classification system, especially TLIC score, which will give whether the patient has to be treated surgically or non-surgically, and that includes the clinical feature of the patient and the morphology of the fracture and the posterior ligamentous complex integrity. That is the main thing which is determining whether the patient go for a surgical or non-surgical treatment. So primary objective of this study was detecting the posterior ligamentous complex integrity using ultrasonography and compare it with MRI and intraoperative findings. Secondary objective was finding out the sensitivity and specificity of this ultrasonography by determination of PLC integrity. So severe thoracolumbar fractures admitted in the Department of Neurosurgery were included in this study, and it was a 2-year duration study from July 2019 to 2021. So all the patients, which any age group which is diagnosed to have a severe traumatic thoracolumbar fractures on X-rays or CT scan has been included in this study, and special emphasis was given to those patients having a polytrauma or a patient with hemodynamic instability or patients on mechanical ventilation where getting an MR is contraindicated on those patients, and also patients having ferromagnetic implants or claustrophobic patients. So these patients are going to benefit from this study. So they are given a special interest on this. And osteoporotic fractures, pathological fractures, and fractures older than 2 weeks were excluded from this study. And because we are doing an acute setting study, so we need fractures. Immediately patient admitted with all these findings, we will be carrying out the study. And it was a prospective control study. And pre-operatively, patients undergo an ultrasound scan of the thoracolumbar region, which we are interested, and in addition to the clinical and standard diagnostic examination using conventional X-rays, CT and MRI of the injured region. And with those results from ultrasonographic, MRI and intraoperative findings, those are operated according to TLIC score, were compared and we found out with the conclusions. So this is the ultrasonography Phillips affinity which was used, and we have 2 planes with linear probe in a sagittal plane and in a transverse plane. And so this is the ultrasonic image which we got here. So this is a normal ultrasonic image which you'll be getting from that. So A is the subcutaneous layer, and B is the supraspinous ligament, which is a continuous layer, and we have this hypoacute zone of spinous process and both the side, and this is the demarcation area of the spinous process both the side. In between we will be getting interspinous ligament. So this is the schematic diagram for the same, and any discontinuity in this layer, especially from ultrasound, we will be getting a supraspinous and interspinous. Superficial success only will be able to identify. So any discontinuity discontinuity in that region will be interested. So this shows the ruptured interspinous ligament between the two interspinous process, and MRI, which is the gold standard, which is showing the still hyperintensity between the supraspinous, interspinous, even posterior longitudinal ligament is also ruptured. And this is the supraspinous ligament which is ruptured here. There is a discontinuity in between, discontinuity of the hypoechoic zone, that is the supraspinous ligament. And intraoperatively, which we are demonstrated the rupture of the supraspinous ligament. So with these results, we are going to analyze the data. So the total number of the patient was 40 patients, and in that 39 patient underwent MRI. One patient, because of the metal implant X-fix was in situ was there, and that is not an MRI, that is done with the USG examination. So all the patients, 40 patients underwent ultrasound examination. In that 29 got the PLC rupture, 11 was normal. In that, so compared to the MRI, the 3 patients with the PLC ruptured in MRI, but it was not in USG. That is, USG was overlooked, the 3 patients, and it was ruptured, but USG showed it was not ruptured. So there is a negative predictive value in that. So we'll discuss that. And intraoperative finding, 32 patients were ruptured and 8 was normal. And the results were mean age was 42.7 years, and all these patients will be coming with a high velocity trauma, will be having a motor and sensory deficits, and polytrauma. Of course, 67 patients had a polytrauma, and all the class AO type classification from the incomplete fractures onwards will fall into the surgical category. And so here we will be able to see that the conclusion of the study, actually intraoperatively 32 patients got ruptured PLC, and 8 was intact. So these were the standard which are comparing other 2 investigations with this intraoperative findings. So ultrasound here, intact patient was, PLC was intact in 11 patients. So 3 patients actually it was ruptured, but ultrasound showed it was not ruptured. So that means we got a negative predictive value, which was less in my study. So here analysis goes to, so sensitivity of detecting PLC is 90.6 and specificity was 72%, positive predictive value 79%, and a negative predictive value was 28%. So PLC rupture detected using ultrasonography highly confirmatory, and PLC intactness demonstrated using ultrasonography needs confirmation with the MRI because of the low negative predictive value. So MRI is a gold standard. We know we do additional information about the disc and the spinal cord and ligaments and all, and 100% sensitivity specificity is there. So ultrasound always it gives an additional tool, and it is portable, it is easily available, cheap, and we can use those patients having MRI is contraindicated. So literature also showed the same, which ultrasound giving extra edge, and it's having a good sensitivity or specificity of finding out patients having posterior ligaments complex is injured or not. So here Moon et al. Showed sensitivity 83%, specificity 93%, and another study showed again sensitivity, good sensitivity, and again here another study 29 patients with the meaning et al. Which showed 100% specificity because of less number of subjects. We got a 40 patients, here there is less number studies are there with less number of patients, and the machine which you are using, if it's a good resolution and good expertise, of course we will get a good result. So our study sensitivity specificity is good only, it's 90% and 72% specificity with 79 positive predictive value and 28.1% of negative predictive value. So it's why the negative predictive value is less, it can be because of the poor ultrasonic wave and the technology which we are using, and patients having obese patients will be difficult. So here, so concluding the acceptable usefulness of ultrasonography in detecting PLC injury when compared with MRI because of good sensitivity and specificity. USG has sensitivity and high sensitivity and positive predictive value, and can help in surgical decision making when PLC injury is diagnosed even in the absence of MRI. Despite of the inherent weakness in penetrating bony structures, ultrasound is highly useful in patients with hemodynamic instability, ferromagnetic implants, claustrophobic patients, and poor resource settings. So here we recommend ultrasound is an imaging additional tool for visualizing relatively superficial structures of the PLC, including supraspinous and interspinous ligament. Despite of several disadvantages, ultrasonography with experienced techniques is a time-efficient, economical, and safe imaging tool for the assessment of PLC injury of the fractured thoracolumbar spine, and helps for surgical decision making. Thank you.
What were the factors which led to negative ultrasound as compared to MRI? That is question number 1. Question number 2, you operated all the 40 patients, if I'm not wrong.
Because all the
So even in patients who had normal MRI of the spinous ligament, they were operated.
operated normal MRI in the sense of PLC status. So the patient had a morphology of a severe morphology fracture having a neurological deficits also. T-leaks include those two also. So can more than 4 will go into the surgical category. So,
And the ultrasound factors where you had negative values, did you analyze what happened?
yeah, what happened especially because I learned from the radiologist, so I only done all these ultrasound, so that is who is examining, so I just cross-checked with him also, so there's a disparity in between, and then the obese patients, so female patients, those are obese patients with difficult to access the waves into that, so I had a facing difficulty in those patients also, and patients with the fractures with severe pain and not able to mobilize, those also compromised my ultrasound examination. So mostly those things has been done.
You had 3 cases of false positive.
False
negative.
Negative.
False negative.
Really, it was positive, but it was negative by ultrasound.
Was there any case of false positivity in USG?
No, sir. I just got this.
So that's what, I mean, all your patients had MRI positive in ligament
One
injury.
patient didn't done MRI because of the can't mobilize to the gantry to get an MR.
No. Yeah, that's what, if you had done, you had some patients where MRI was intact, then that would have been a better comparison. Where ligaments were intact on MRI and then studied it, that would have been also, that would have added more weightage to your study. Other thing is, usually when there is a fracture, there will be a lot of tenderness there.
Yes,
and
sir.
doing an ultrasound at that point, was it quite discomforting for the patient?
give a
So
good,
that will also result in false interpretations,
Yes,
right?
sir, of course. Yes. Giving a-
Initially, they won't allow you to touch that
After giving good parental analgesia, I just comfort them, then we'll proceed with the procedure.
Just one question. Can this, in your study, can you say that ultrasound can be used as a standalone modality for deciding whether you have to operate on these patients, or you need to have MRI on all these patients? Can it be as a standalone?
Only those patients having the MRI is contraindicated. In those terms, it will help definitely. But provided the code status we don't know, and then the disc status we don't know. Any traumatic dysplasia has happened, or the code what's there. So we have to assume those kind of patients clinically. If deficits there, of course, there will be some neurological injury, and then intraoperatively we have to see. So this is like an additional tool, and the resource poor settings in periphery, MRI is not able to do, and patient need fixation, we can go ahead with MRI, provided the neurological status has to be taken care of.
This is just analyzing one parameter of the TLS score.
One parameter of the TLS score, yes.
All the other parameters are also required to decide on surgery.
Yes, sir, of course.
With the new legal system trying to catch on the doctor, I don't think it's a safe recommendation, even in periphery, to operate a patient without an MRI. But the advantage of your modality of ultrasound is in a patient who have, for example, an iliac fixator or a metallic implant, and you cannot do an MRI, or even having a hemodynamically unstable patient, there probably you can take a decision with a X-ray along with an ultrasound. But I don't think you can recommend it for any poor resource or anything.
Not recommended as a standard thing, but it's an additional tool to help for the clinician to decide.
No, you say the additional tool. See, when you already have an MRI, possibly, then why should you have this particular tool?
So here I'm highlighting that those special inclusion.
Does it add any sort of information apart from MRI?
Apart
That
from
way,
that-
possibly the study would have been good.
Presently,
but,
apart
yeah.
from MRI, will not those patients not able to do MR, we'll get a standalone.
Yeah, obviously,
Those patients.
hemodynamically unstable patients you usually don't operate. So operative decision goes away over there. So ultimately, this study alone, how does it help in the management of patients?
Like those patients hemodynamically unstable, at that time they will be getting stabilized, and then we have to go with the, by the time the patients will be having lots of implants by the way, so that also will help. Basically, it's not replacing, it's given extra edge in a resource poor setting, or those patients having a ferromagnetic implants in situ.
Yeah, possibly you can put it this way that comparing all these, both these modalities, possibly you will learn more, and future, possibly you can have more information. That's possibly the only take, I suppose.
Fine, sir.
Thank you, Dr. Mansoor.
Thanks.
I'm sorry, I mean, it's over, the time is up, I guess, yeah. Yeah. Can we move on to the next speaker? Thank you, Dr. Mansoor. And Dr. Manoj Kumar HP on large sacral tumors, the experience, institute experience.
Good morning, everybody. Today's paper regarding the large sacral tumors, our experience, approaches, and challenges. Sacral tumors are the rare lesions which is governed by the interplay of the complex factors, and decision making is crucial as to achieve the best outcome to maximize the disease control and minimize the neurological dysfunction. And coming to the objectives, it is like to present our experiences of patients with large sacral tumor operated surgically with a multidisciplinary team over 5 years. And it's a retrospective review of a prospectively maintained data. And large sacral tumors are relatively uncommon with mean diameter of more than 10.5 centimeter, and mostly they are metastatic. It might be primary tumors might be of bony or congenital or neurogenic origin, and early diagnosis is not possible because of clinical and radiological characteristics are indefinite. And most of these tumors are the radio-resistant and chemo-resistant, except for the metastatic tumors. And wide local excision and with or without reconstruction is the procedure of choice. And approach depends on the size and tumor extent. It might be a anterior or posterior or the single stage or the two stage. And my study comprised of 9 patients who underwent sacral tumor resection over the period of from 2017 till 2022, out of which 6 were females and 3 were males, between the age of 17 to 69 years, at a mean age of 51.4 years and with a mean follow-up period of 3.2 years. And 5 cases were below S2 involvement, and 4 cases were partial S1 and varying SI joint involvement, and 3 recurrent cases with extensive iliac involvement. Coming to the statistics, and most of our pre-op biopsy report was, most of it was chordoma, and one was schwannoma, and one was a malignant peripheral nerve sheath tumor. And most of the cases we have done a near total, only 2 cases we have done a subtotal, and maximum mean duration was around 8 hours, and mean blood loss was around 2 liters, and mean follow period of around 3 years. And all of the patients have done bilateral ureteric stenting, except for 1 case we have done unilateral. And we have found that 3 recurrences, one had a recurrence twice, and only 1 patient had a wound infection. And except for 1 schwannoma patient, the rest of the patient we have irradiated post-operatively. And except for 2 patients, we have done pre-op angio, and embolization was done in 2 patients. And this is the representative first case with the T1 post-contrast imaging showing the extensive sacral tumor with the lateral extension. And this is the 3D reconstruction showing the extensive bony destruction of the sacrum. And this is the abdominal stage where mobilize the retrosigmoid, and we isolate and ligate the lateral and middle sacral vessels, and intercapsular excision was done, and diversion colostomy was done for this patient. And this is the intercapsular resection of the tumor, and posterior we have kept the mesh over there. And posterior approach includes the S1 laminectomy with high sacrectomy, and followed by iliolumbar fixation like L3, L4, L5, and transpedicular screws was done, and iliac screw fixation was done. And this is the posterior approach images. You can see the final construct. And these are the post-operative images showing the satisfactory construct. And this is the second representative case with the malignant peripheral nerve sheath tumor with extensive lateral one extending into the anterior. And this is the 3D images showing the extensive destruction of this sacrum. And this is the post-operative images showing the satisfactory construct. And this is the post-operative patient with abdominal wound and the Mercedes-Benz posterior wound. And coming to the results, 7 patients required spinophallic fixation in our cases, and 5 were below S2 and partial S1, and 3 cases were extensive iliac involvement cases, and 3 recurrent cases required augmentation of the iliolumbar fixation, and 3 cases were transperitoneal approach, and 2 cases were anterior retroperitoneal approach, and we have done 1 case posterior en bloc resection in low sacral lesion, And most of our pathology was chordomas in 7 cases, and malignant peripheral nerve sheath tumor in 1, and schwannoma is 1. And post-op radiotherapy was received by 8 patients, and recurrence were 3, and mortality was 2. Out of 1, mortality was not related to the sacral tumor. Coming to the discussion, mean large sacral tumors are more than 10.5 centimeter, which is the sacrum, whether it might be involvement of S1 or not, or SI joint involvement or not, or whether there is any stability issues. In these kind of cases, we don't face any kind of challenges. And when you face the challenges, it depends on the whether where is the epicenter of the lesion, whether there is anterior extension and visceral involvement, and extraosseous extension and stability of the spine. And this epicenter decides the surgical approach and whether stabilization is required or not. And these challenges are dealt with the multidisciplinary team with and complication and recurrence. And complication, usually we encounter massive bleeding and infection, and CSF leak and severe neurological deficits with bowel bladder dysfunction and instability. And strategies are with multidisciplinary team. And then we usually take the preoperative 3D reconstruction image of the spine, so you can extension of the bone involvement. And to rule out the primary, to find out the primary, you do the PET CT or CCT chest. And preoperatively, biopsy was taken either CD guided or USG guided to know the histological status. And DSA was done for most of the patients to know the vessels, whether you can see the tumor blush. And preoperative embolization was done in 2 cases where you can see embolization done with the polyvinyl alcohol, and usually you get the feeders in sacral tumors usually from the lateral sacrals. And degestenting was done to relieve the ureteric obstruction. You can see the stent placement. And instability depend on the S1 involvement or SI joint involvement or iliac bone involvement. And the instability determine the SIN scoring system. 13 to 14 points is regarded as unstable spine. If more than 50% of sacroiliac joint is resected, then definitely you should think of stabilization. And tumors grew above S1, no need of fixation, and expanded higher than S1 level, need stabilization. And between, like, if S1 is intact and L3 to S1 pedicle screw fixation with graft can stabilize the pelvis, and long segment fixation for stability is required. And to conclude, the large sacral tumors, these are complex and need good preoperative planning, and we require multidisciplinary team with preoperative biopsy and staging and embolization of feeders if you get any feeders in the angio. And ureteric stenting is advisable, and depending on the extent and epicenter, you can decide the resection and approach. And usually wide en-bloc or wide local excision is the treatment of choice, with reduced recurrence and survival advantage, and post-operative management equally important. Thank you.
Definitely complex tumors. As we saw that in some cases you did stenting, some cases colostomy, some cases embolization, some you went transperitoneal, some lateral, some posterior. So what is the criteria to decide your approach?
Criteria depends on the whether it is involvement of the rectum is there, and whether the lateral extension you have to see, and whether extensive extra-iliac
so which
extension.
cases do you do transperitoneal? When do you go lateral? When do you go posterior?
Transperitoneal, usually we go if extensive, there is a iliac vessel involvement is there. So we need to explore the iliac vessels, and either we go like retroperitoneal or transperitoneal, and whether rectum is
When
involved.
do you decide to embolize?
We decide to embolize if there is we find a tumor blush in the DSA, which we take preoperatively. Extensive.
But you did DSA for all cases?
Yeah, we have done DSA for most of the cases. Only embolization was done in only for 2 cases. To reduce the intraoperative bleeding, sir.
When do you decide on stenting, ureteric stenting, all cases?
Ureteric stenting is done for all patients to relieve the obstruction, post-operatively also. Colostomy we have done for 1 case, sir, where extensive involvement of the rectum. Tumor was involving the rectum, so we have done a colostomy for the patient.
Did you do any myocutaneous flap in any of the cases?
For 2 cases, we have done a myocutaneous flap, sir. ARM flap we have done, sir. RAM flap, post it. Yeah, follow-up on recurrence is there, sir. 3 patients we have found recurrence, and 1 patient had 2 recurrence. And this was dealt by, we have taken a post-operative MRI, and then again we have resected the tumor. So the patient is under follow-up right now for 3 years, sir.
You said most of these cases are radio assisted.
Yes, sir.
And in your series, how many had undergone radiation?
We had 7 patients has undergone radiation, sir. Was chordoma. Only, 8 patients are there. Except for schwannoma, most of the patients were irradiated, sir.
Knowing well that they are radio assisted.
Yes, sir.
Why did you do that?
To limit the lateral extent.
And they had gone.
Radiation necrosis, no, sir.
Yeah, you have mentioned one of the complications, radiation.
One of the complications was mentioned, but that is strategy, not in our study, sir.
Okay, thank you. Thanks. I may now call upon Dr. Vineet.
Dr. Vineet will be presenting tomorrow.
Okay.
So
alright.
we'll be moving on to our next speaker, Dr. Mithun.
Okay, can I call Dr. Mithun K. Prakash, who is speaking about association of preoperative MRI features of meningiomas with intraoperative physiological characters in patients undergoing craniotomy. Thank you.
Good morning, respected teachers, dear colleagues. My studies on the association of preoperative MRI features of meningiomas and with the intraoperative physical characteristics. So, meningiomas are one of the most common intracranial primary tumors. So physical characteristics like consistency, then vascularity, and also adherence to surrounding structures and fibrostructure, etc., affect the completeness of resection, and the recurrence of lesion is mainly influenced by the completeness of resection. So aim is to find the association between preoperative MRI features and intraoperative physical characteristics of meningiomas. So objective is to find the relation between signal intensity ratio in preoperative MRI with the consistency and vascularity of meningiomas assessed intraoperatively. Inclusion criteria. So we included all patients who underwent craniotomy and excision for meningiomas at our institution. Study period was from October to 2022 December, and it's an observational study with a sample size of 49. So all these patients underwent routine preoperative MRI at our institution, and signal intensity ratio in MRI T2 sequence was calculated. The tumor signal intensity ratio of the tumor versus the signal intensity ratio of the cerebellar peduncle was calculated. For tumors, multiple regions of interest was noted, and the average of signal intensity was taken from the MRI console. Then intraoperatively, these radiological features was calculated preoperatively, and intraoperatively consistency of the tumor was noted along with its vascularity. Consistency was graded according to the QSA, amplitude of QSA being used for resection of the tumor. And for those tumors which we didn't use QSA intraoperatively, we used QSA postoperatively on the specimen. So then T2 intensity was plotted against the QSA values and against the intraoperative physical characteristics. And T2, this MRI T2 signal ratio was plotted against the vascularity of the tumor. Vascularity was assessed by the surgeon subjectively according to the bleeding observed. The tumor was classified as soft, firm, and hard according to QSA values. Less than 40 was classified as soft. Then firm was classified as 40 to 70, requiring 40 to 70 QSA. And then hard was QSA requiring more than 80. And data analysis was done using Pearson correlation coefficient, and ANOVA. Then these are our data. And we had a total of number of 49 patients with a mean age of 52, and the minimum youngest age was 16 and maximum age was 80. And then sex distribution, we had 29 female patients and 20 male patients. And the mean signal density ratio was 1.6, and minimum was 0.8 and maximum was 2.31. And by our classification, firm was 16, then hard was 10, and then 23 was soft meningiomas. And vascularity, 10 tumors was highly vascular, then 22 were minimally vascular, and some 17 tumors were in between those two. So coming to scatter plot, according to T2 signal ratio, the T2 signal ratio versus the value of the QSA being used. QSA maximum value is 100 and least use was 20. Then consistency, this was a T2 ratio against the consistency of the meningiomas. So we had grouped them into 3 categories. One is soft, then second one is intermediate firm, and third is hard. Then T2 signal ratio versus vascularity. There is a good correlation between T2 signal density versus vascularity, but it was not highly statistically significant, but requires further assessment. And the p-value was 0.15. Then we correlated the T2 signal density ratio with the QSA value. So it was statistically significant with a minus 0.89 Pearson correlation coefficient. That is, it is negatively correlated. The higher the MR signal density ratio, the lesser is the consistency, and meningiomas become soft. Coming to discussion, tumor consistency was strongly negatively correlated with the MRI T2 signal density ratio, and low signal ratio implies fibrous and hard tumors. So in this study, we attempt to grade the tumors consistency based on QSA instead of subjectively grading them into soft, firm, and hard. We try to make an objective scale based on the QSA, based on an objective measurement. And also, this tumor vascularity also shows good correlation between the signal density, but requires further studies. So it may be possible to predict the consistency and vascularity of tumor based on the preoperative MRI, and can also predict the blood loss and then adaptive structures, especially in skull-based tumors, and chance of residual tumor and recurrence. Thank you.
Relaxed, look very tense. How did you decide on choosing the middle cerebral peduncle, cerebral or cerebellar? Is there any studies? How was that chosen as the ratio for the?
Sir, previously I saw one study, sir. Previously,
there are some studies.
Outside one international study was there, but number was very less. Number was 20. So,
what is the rationale of all the structures in the brain? Why is the middle cerebellar peduncle chosen as
relatively consistent and devoid of CSF spaces, sir. So doesn't affect the signal density. So also to make uniformity to the study.
So could you arrive at any cutoff value that below this T2 ratio it is going to be soft? Any absolute values there, or it is just lower it is softer? You mentioned the lower the T2 ratio, the higher the T2 ratio, the softer the tumor is, right?
Higher the T2 ratio.
Yeah. So is there any particular value, cutoff value, that above this value it will be softer?
It was around 1.5 to 1.6. It was firm on the firmer side, sir.
Thank you so much.
What is the general location of these tumors?
Sir?
General locations of these tumors?
Sir, all locations. We took all locations, sir. Convexities, then CP angle, skull base, mainly convexity meningiomas, sir. And parasital, convexity and parasital meningiomas mainly.
Any difference in the ratio between skull base and convexity?
We had a lesser number of skull base locations, sir, but skull base locations was predominantly less than 5, sir, but it was predominantly fibrous. And CP angle meningiomas, we had 4 cases, it was soft, relatively soft.
Can I ask a question?
Yes.
It's a very nice study, but you know,
Did you study the proliferative indices of all this like Ka67, P53, TOPO2, all these markers have you studied? Or mitotic index and all? Then only this has some significance, you know, because everything boils down to the chances of recurrence with these lesions. So did you study that proliferative indices all? Of all, because you have pathology specimen where you have studied even using Q, so you can study all these proliferative indices, chromosomal aberrations. I will tell you TOPO2, EGFR, Ka67, P53 are the ones to be done. And mitotic index below or above 8, which has a significant prognostic value. Otherwise, what is the ultimate thing of your study? Difficulty in removal, or?
Yes, sir.
Difficulty in always we know fibrous tumors are difficult to remove. No? But what we are bothered is recurrence only after so-called subtotal, total excision, depending upon your study. Okay, doctor. Good study.
Thanks.
Okay, thank you very much. Very nice study. Yeah, it's very, very, especially in skull-based meningiomas where it will be difficult. The next one, next person to present is Dr. Vishnu Karthik is here.
Dr. Vishnu will not be presenting today.
Okay. So
Our
next is
presenter-
Dr. Akhil Sunil. You're here? Yeah. Hey, Akhil.
Yes, Dr. Akhil Sunil is our next presenter, consultant neurosurgeon at Bishop Benziger Hospital, Kollam.
Good morning to all. I was previously associated with SHIMS Bangalore, and now I'm working in Kollam as a consultant neurosurgeon. I'll be talking today about opticochiasmatic distortions in pituitary adenomas and their relevance in visual recovery. Prediction of visual recovery after pituitary adenoma surgery remains challenging. Many predictors have identified so far, but they have been inconsistent. Among all these variables checked, opticochiasmatic distortions or the OCDs remain underexplored, and these has been evaluated in other cellular and supracellular pathologies, but lesser in pituitary adenomas. So previous study have looked at OCDs in relation to only the preoperative or the immediate postoperative period visual function, and implications of these OCDs is in long-term visual improvement are still unknown. This study analyzes the relevance of all the previously described OCDs with respect to visual recovery at midterm follow-up after surgery for pituitary adenomas. The aims of our study was to record and analyze various OCDs in pituitary adenomas and their relationship with preoperative visual function, to evaluate the correlation of OCDs with visual recovery at midterm follow-up after endoscopic resection of pituitary adenomas. It's a retrospective study, and we assess the ophthalmological and MRI assessment in the preoperative at 3 to 6 months follow-up and 12 to 16 months follow-up after surgery. And all patients underwent the standard endoscopic TNDS resection, and 2 independent observers performed all the measurements. The inclusion criteria included presence of visual impairment due to pituitary adenoma compressing the optic pathway, and availability of MRI and formal ophthalmological assessment during the preoperative and the follow-up periods, and a gross total or near total resection of tumor with no residual tumor in contact with the optic pathway was considered. We excluded all the patients in whom the preoperative radiological identification of the optic nerve or the chiasm was difficult, and patients with concomitant visual disorders like glaucoma or diabetic retinopathy, and history of any previous surgeries or radiotherapy in the cellular supracellular area. During our study period of 2 years, it included 72 patients, and after excluding the cases, there were 35 patients which we considered as 70 eyes, and they were assessed. The visual acuity scores are we initially calculated using the Snellen's chart, and these were converted to visual acuity scores, which ranged from 0 to 100, and improvement in visual acuity was considered when the follow-up score of 100, which corresponds to 6/6 or 20/20 vision. And similarly, the visual field scores were also calculated, and the visual field was divided into 10 meridians with a radius of 60 degrees, and the points were assigned in each meridian, and improvement was considered when the score was 100. The opticochiasmatic distortions. There are 5 opticochiasmatic distortions previously described in studies. This included the optic nerve canal bending angle or simply the bending angle, optic nerve kinking angle or the kinking angle. These are the optic nerve distortions, and the chiasmatic distortions included chiasmatic area, chiasmatic mid-chiasm height, and chiasm sag at follow-up. So the optic nerve bending angle is the external angle between the fixed axis of the optic nerve in the optic nerve canal and that of the intracranial segment of the optic nerve stretched over the tumor at the entrance of the optic nerve in a T1 sequence. This has been previously described in a study by Yamaguchi. So another Japanese study also described this kinking angle, which the angle between the planum sphenoidal and the intracranial portion of the optic nerve in a T1 sequence. These studies have been done in a preoperative pituitary tumors, and they have been found to have a significance in the preoperative visual fields. The optic chiasm area and the mid chiasm heights are calculated in the preoperative chiasm in the T2 coronal sequences, where the tumor is maximally stretching the chiasm, and these are calculated using the ROI tool in the synapse. And in cases where the entire chiasm could not be clearly delineated, the same was interpolated. The mid-chiasm height is measured in the same cut in the midline, designated by the blue line. And the chiasm sag at follow-up was defined as any degree of downward displacement of the chiasm below the horizontal line, joining the upper borders of the cavernous carotids at a cut where the complete cross-section of the vessels are seen. So all these are previously described in multiple studies, and we used SPSS 16, and our study had a power of our study was 90%, and bivariate analysis was used to check the correlations between the OCDs and the visual acuities and field scores. Multivariate logistic regression analysis were also used on the variables with significance on bivariate analysis. Coming to the results, the preoperative clinical radiological characteristics showed all the craniocaudal dimensions, the chiasm, all the opticochiasmatic distortions were all statistically significant to the preoperative visual acuity and scores and field. These were the preoperative, postoperative, and the follow-up scores. And any change in the bending angle, these are the representative images showing the recovery of the bending angle after tumor resections. Decrease in the bending angle is suggestive of reduced bend on the optic nerve at the optic canal postoperatively. And similarly, an increase in the kinking angle suggestive of reduced kink on the optic nerve in postoperative period. So similarly, the chiasm, these are the representative images showing the chiasm area and the mid chiasm height. And our study showed the mean value of the bending angle was 30 degrees, which reduced to almost 0. And the kinking angle was 140, which increased to 160. And the mean chiasm area remained same in the preoperative and the postoperative periods. And the chiasm height was 1.72 in the preoperative period, which increased to 2.86. And there were 10 patients who had, out of 35, who had chiasm sag. So in a bivariate analysis, this showed the correlation between the visual acuity scores and visual fields. This had statistical significance with the most of the opticochiasmatic distortions, but on multivariate logistic regression, only the preoperative visual acuity and visual field had any significance. None of the scores, none of the optical distortions had any significance. So to summarize, the preoperative OCD is correlated with postoperative visual field defects, and most of postoperative visual impairments improvement occurred within the initial 3 to 6 months period. Only the preoperative visual field and visual acuity scores correlated with the visual improvement at the second follow-up, and none of the 5 OCDs correlated with improvement in the follow-up period. So this to bending angle and kinking angle have been found to correlate with visual improvement in preoperative period and postoperative period in previous studies. It is postulated that it is because of the kinking of the optic nerve causes irreversible ischemic damage. And the chiasmatic distortions correlate with the preoperative visual field loss, but this does not have any significance in the postoperative period. The chiasm sag, one of the previous studies showed a 54% incidence of chiasm sag. In our study, it was 29%, but it did not have any influence on the visual field status. And the unique aspect of this study is the first comparative study to describe all the previously described OCDs in pituitary adenomas before and after surgery, and the preoperative, it correlates only with the preoperative visual fields, and it did not correlate with the postoperative fields. So what is the implication of our study? So our study indicated a disconnect between the morphology and functional recovery of the optic pathway, and this may be because of the irreversible factors like microcirculatory changes, optic pathway ischemia, which predict the visual field improvement. So there has been evidence for and against this. So the retinal nerve fiber layer thickness has been correlated with visual field improvement, but our study, there has been multiple studies showing that it doesn't matter whether the thickness of RNFL has improved or not, and our study also is suggestive of this mismatch. So what are the future directions? We need to look beyond the morphology of the chiasm to predicting the visual improvement, especially for retina and optic nerve changes. We should look for multifocal visual field, VEPs, pattern electroretinogram, and hyperintensities in optic nerve. And for the perfusion and microvascular changes, we should look for OCT angiography, and optic nerve pathway changes, we should look for DTI. These are the future directions which predict visual field outcomes. As the limitation, it is a retrospective study with inherent limitations and lack of longer term follow-ups. So to conclude, MRI-based opticochiasmatic distortions correlate well with preoperative visual acuity and field dysfunction in pituitary adenomas, and these OCDs do not influence the postoperative recovery of visual field acuity and fields at midterm follow-up, indicating a morphology versus function disconnect in the optic nerve pathway, and the need for future studies to analyze this. These are my references. Thank you.
Thank you, Akhil. Painstakingly done study,
Yeah.
and a lot of geometry and physics involved. One of the reasons why we all took medicine to avoid all that, and you're asking us to do that again. This one of the, one problem limitation I found is one of the exclusion criteria in your study was it's patients in whom the chiasm and optic nerve cannot be delineated well.
Yes, sir. That
Unfortunately,
delineated.
many of these large tumors, that is the one where vision is affected also. It becomes very difficult to differentiate the chiasm and the optic nerve separate from the tumor.
In lesions where we cannot comment on it at all, where the optic nerve can be seen in the canal, and after that when it comes out, when the intracranial part we are not able to see at all, then we have excluded. But in cases where it is seen in the anterior part, and when it is overly stretched by the tumor where we are not able to delineate it, there is a process called interpolation of that. So that has been described in previous studies where we can interpolate and find the area of that. So that will be a thinner area which we think that the chiasm is already there. Chiasm has to be there. So it's not seen in our MRI basically. So that is described. Yes. Yes, sir. No, sir. The initial thing, visual acuity, our ophthalmological assessment included all patients undergoing a proper visual acuity test and perimetry analysis by an in-house ophthalmologist. All the perimetry fields will be documented. So those we have in our systems and those we have in our, with us. So that we have used. Sir. So all the perimetry scores were there. So that we have converted using the standardized procedure which is described. Yeah, we have taken from Vision 99 the standardized guideline for American Ophthalmological Association. So there they have standardized all the scores, and those scores have been, those are the normal Snellen-Start scores. That has been given a numerical value. We can't use a patient with 6/6 or 6/12 in an analysis. So they have converted that into a scoring system where a numerical value is given to each for the visual acuity and visual fields. So that means.
What I intended was we have to do all these studies.
Yes, I understand. Our population and yes.
Thank you.
Thanks.
The last speaker of this session is Dr. George. and it'll speak about hemispheric disconnections in epilepsy.
Dr. George is a professor of neurosurgery at Sri Chitra Tirunal Institute of Medical Science, Trivandrum.
Good morning, respected chairpersons, dear teachers and friends. Why I chose this topic is because there are a lot of myths about this topic. Hemispherotomy sounds like a very humongous term, and perhaps also there is a misconception that it is extremely deficit producing and it is palliative. But everything is just a myth. It's one of the most exciting procedures, and it teaches us how a surgical thought has evolved over many decades to reach its level now, and both in terms of technique and in terms of philosophy. So all of you who have been to Wayanad would be excited to and would have already experienced some of the zip lines that are seen around here. So hemispherotomy perhaps is like a zip line journey right across the intrinsic anatomy of the brain, right from the frontal pole to the occipital pole, and laterally from the insula medially to the ventricle. So it's a fascinating zipline journey. Only thing, the longest zipline here is still less than 2 minutes. My zipline journey perhaps will be a little up to 8 minutes. And all of us who are already familiar with concepts in epilepsy surgery understand that epilepsy surgery is little different from other neurosurgery, because here it is not structure based. So we know that everything lies not just at the MRI abnormality, it lies a little beyond the MRI abnormality, and all of us are trying to find the epileptogenic zone, and there is no ideal investigation to find it. It's only when we finish the surgical resection and give good results that we know that we have hit bullseye, that is the epileptogenic zone. So the big question that comes up is that can this epileptogenic zone be the entire hemisphere? The answer is yes. In a few subsets of pathologies, it can be the entire hemisphere which is actually responsible for seizures and for also damaging the other normal hemisphere. So these are those typical hemispheric epilepsy syndromes: Rasmussen's encephalitis, hemimegalencephaly, porencephalic cyst, Sturge-Weber syndrome. So by now you would have already understood that the pathology the spectrum is so wide, and the volume of the brain involved is also so different. So you have hemimegalencephaly where the volume of brain involved is actually bigger than the normal hemisphere, while you have a porencephalic cyst where you have atrophic brains, and both of these have their own unique challenges. So the question is that in the current era you have newer options: ablation, disconnection. So sometimes you have lesions which are very aggressively resected but not seizure free, at the same time partially resected but seizure free. That is where the concept of epileptic network comes into the picture. And as far as hemispherotomy is concerned, we are almost certain that the entire epileptic network is in the whole hemisphere, and when we are disconnecting the whole hemisphere, perhaps the whole thing should be taken care of. So this is the captain of the ship Titanic who underestimated the tip of the iceberg. This is what happens to epilepsy surgeons also often, where we go by the structural abnormality, often failing to realize that the bigger network is the culprit. So the larger volume of resection in hemispherotomy is the largest if you go by this volume of resection concentric circles. Smallest lesionectomy, hemispherotomy, involves the entire hemisphere which we resect. So these are the common epileptic syndromes associated with hemispheric epilepsy, and in our scenario in India, the commonest is a porencephalic cyst, usually a post-infarct porencephalic cyst. So the prerequisites for a hemispherotomy are that we should have entire hemispheric dysfunction, hemiplegia, hemianesthesia, hemianopia, and a structurally normal other hemisphere which is actually bearing the insult of these repeated seizures. So the question comes up is that what if some function is preserved? I'll answer that as we go further in the talk. So to assess how much function is in the hemisphere, we have a very fascinating test which has been described by this now 90-year-old gentleman, Vada, where we can actually stun the whole hemisphere and assess how much of function, both motor, cognitive, language-wise, is present. And even today in the fMRI era, this has got an unparalleled role in evaluating a structurally abnormal hemisphere to evaluate its function. So this is a typical example wherein you have an entire hemisphere which has been disconnected by hemispherotomy, but still a lot of function is retained, showing that function has, because of neural plasticity, already shifted in a long-standing pathology. So the fascinating procedure of hemispherotomy has evolved from the earliest, from the 1930s. Initially it was described for hemispheric gliomas. Over a period of time it evolved, and we realized that we don't need to take out the whole hemisphere because dead spaces have their own problem. Nature abhors a vacuum. And that is why now we just disconnect the entire hemisphere. For those of you who find it difficult to conceptualize this three-dimensionally, hemispherotomy is essentially just doing 5 lobectomies: frontal, temporal, parietal, occipital, and insular lobectomy, disconnecting the cortex from the thalamo-basal ganglionic system. So this is the classical original anatomical hemispherotomy, which is almost done away with in the current era unless you're doing it for failed functional hemispherotomy, because it has its own unique set of complications, the most dreaded of which is superficial cerebral hemosiderosis. So the concept has evolved over time, less resection and more disconnection now. So the common goal is disconnecting all these white matter fibers and also doing a callosotomy, disconnecting the cortex from the thalamo-basal ganglionic system. So just is putting it in a little more schematic manner. So these are the white matter tracts which are disconnected, the subcortical white matter, a lateral view of this disconnection, a medial view, and a three-dimensional view, all these lobes which are disconnected from the thalamo-basal ganglionic system. There are 2 essential ways of in which this can be done. One is a horizontal technique wherein you open the frontal horn through a horizontal suprasilvial and an infrasilvial approach and disconnect the thalamo-basal ganglionic system, or the vertical way of doing it through the frontal lobe. So we usually commonly do the frontal disconnection. I'll show you the quick steps. So these are the different variations of doing it, and this is how the disconnections look after surgery. So I'll quickly go through the steps. Epileptic encephalopathy also is a state wherein there is complete dysfunction of the hemisphere and individual areas which could be individually epileptogenic, but even then a late hemispherotomy also has its role. Emergency epilepsy surgery, as in a child like this who had been on a ventilator due to status seizures, helped him to come out of status seizures and come out of a tracheostomy and recurrent aspirations. This is a classic case where I will describe the steps. A 11-year-old male with a large porencephalic cyst. This is the incision, just a inverted U-shaped flap, a pericoronal flap, just like probably you do it for colloid cyst. A small incision. I'll quickly go through the first step, that is access to the temporal horn. And here you open the temporal horn. In the interest of time, I'll just fast forward the video. Once you are in the frontal horn, you can identify the structures, essentially the thalamo-basal ganglionic complex, the foramen of Monro, and the choroid plexus. The next step is the transventricular callosotomy and a septostomy. Here you can see the callosotomy, which is already partially done through the ventricle. You can see the callosal cistern with the ACA running in the callosal cistern. This is a complete callosotomy extending from the anterior commissure, genu, rostrum, going right up to the splenium. And it ends with doing a septostomy here. You can see a small septostomy to avoid any collection in the ipsilateral ventricle. So the next step is a frontobasal disconnection around the caudate bulge. And the next step is an insular disconnection, which can be very difficult. This is a bulky hemisphere, and this is an insular disconnection in a less bulky hemisphere. And so the last step is a parieto-occipital disconnection and placing of an external ventricular drain, because any small collection in this is a risk for a delayed hydrocephalus. So I'll quickly go to, this is a post-op scan showing you the cortex disconnected from the thalamo-basal ganglionic system. A bulky hemisphere offers its own challenges. In the interest of time, I'll just skip that. So this is a large hemimegalencephaly, wherein the same procedure can get very complicated sometimes, wherein you have to rely on these intrinsic surgical landmarks for safety of the procedure. And this is how it looks post-operatively. And the most commonest dreaded complication, 3 to 10%, is a post-operative delayed hydrocephalus. So this can have a lot of varied presentations. Patients are seizure free, so their parents are happy, and sometimes they don't really report to you early with hydrocephalus. So this is a child who came with a not so common presentation of hydrocephalus with a large tense pseudomeningocele. We put in a shunt and he did extremely well because he was seizure free. His parents had a long tolerance to these symptoms. So subhemispherotomies, wherein you might have to do something less than a classical hemispherotomies, are also in vogue in special situations. So this is like the map which Shivkumar sir used to send us. How do you go to Tolpeti Wildlife Sanctuary? So the journey from refractory seizures to seizure freedom could be through any of these techniques of hemispherotomy, but as long as you achieve these essential disconnections, it should be fine. So the seizure outcome, depending on the type of surgery, the technique that you use doesn't really matter much. Across pathologies, the best outcomes are for Porenkephalexis and Rasmussen's. And let me end by this very important message that we learn from this technique, that by relying on surgical landmarks in the intrinsic brain anatomy, we can increase the safety of this technique. And this philosophy has evolved over ages, and as time goes by, seizure outcomes and adverse events are standing the test of time and getting better over time. Thank you very much.
Thank you, George. In fact, I wish I had listened to this talk a few months back, because recently I took a couple of my hemispherotomy patients had relapse of seizures, and then I requested George to send some of his recent operative videos, and I had to relearn the procedure. Thank you once again. And
thank you,
in fact,
sir.
we did that. We did reoperate that patient thanks to you.
So I'll offer you a quick tip. So whenever anything goes wrong, blame the neurologist. So whenever anything goes good, so you take all credit for it.
Unfortunately, the neurologist was, you can call Professor Radhakrishnan. they can't.
So, do the motor symptoms get better after seizure control? Is that literature for it?
There is most of these patients, especially the children whom we intervene in the ideal period of plasticity, their motor symptoms definitely have already perhaps shifted before you do a hemispherotomy, so that shouldn't deter you from doing a hemispherotomy. When you do VADA, you often realize that function has already shifted, so that gives you a more leeway for a very liberal hemispheric resection. Rasmussen's encephalitis, yes, coming to your question, Rasmussen's encephalitis is one of the conditions wherein the motor symptoms evolve over a period of time. Patients continuously have epilepsia partialis continua and status seizures. So you are in a dilemma whether you should wait for hemiplegia to set in or intervene early. So our experience has shown it's better to intervene early, because over a period of time, the motor dysfunction that is immediately seen after surgery comes down over a period of time, and what you see at deficits are not full and final. What you see on the first postoperative day is not the picture usually at 1 year. 1 year things get much better, and most of these hemiplegias that you see are probably because of what is known as a Todd's paralysis, continuous seizures. So even that gets better over a period of time. Usually, anti-epileptics, our neurology friends are very much attached to it. So our experience is that we look for three reasons to reduce the anticonvulsants. One is clinical improvement, patients being seizure free. Second is an electrographic improvement, that is EEG showing no background seizures, which in hemispherotomy has no significance because already you have a dysfunctional hemisphere. So you can have false localizing EEGs to the opposite side. And third is when you have got a good MRI. So again, for lesions, structural lesions, if you have MRI shows a good resection. In this case, say a post-operative MRI showing good structural disconnections. When these three criteria are met, we can be more aggressive with tapering anticonvulsants. So we have even seen patients who become so confident that they themselves taper their anticonvulsants even if we advise them to continue anticonvulsants. So these are the three criteria which we look for: clinical, electrographic and imaging before stopping anticonvulsant. Most patients with hemispherotomy are usually anticonvulsant free by at least 1 year after surgery. Yes, Jai. Thank you so much. In the disconnection, we can do the classical callosotomies, which are described as standalone callosotomies, are done interhemispheric. So if we do a whole hemispherotomy interhemispheric through the interhemispheric corridor, it might be possible in a porencephalix cyst where you don't have much volume. But in a large volume hemisphere like in a hemimegalencephaly, you might not be able to do it because you don't get too much of leeway for manipulation. So once you are in the ventricle through the frontal horn or through the lateral approach, you have got, you can see you are trying to, as I just put in the example of a zip line journey, you need to see right from the frontal pole to the occipital, plus you need to reach the middle cranial fossa floor, temporal base, and you also need to see across laterally, across from the insular cortex to the midline to the septum. So this sort of access, it might be possible to do it interhemispheric in a porencephalic cyst or in a
Can I
less
just add to
volume
that
hemisphere.
and interhemispheric approach? In fact, that's what Dr. Biji's anatomic cadaveric study and that's what Sharat Chandra proposes through the endoscopic approach. Because I was not familiar with the endoscopic, so I've tried it microscopic interhemispheric, but as George, and that was one of my failures which I was telling. As George told, unless it is a porencephalic cyst, you at times tend to struggle in the interhemispheric corridor to get that panoramic view which you get through a parasagittal approach.
So I must inform you that interventionalists are coming for you in this case also, because there was two case reports of internal carotid artery occlusion in patients who were probably not fit for surgery and stuff like that with decent control. That's what they said. So they will come for you as well.
That'll be very wonderful news, because then we can stay away from work and attend more conferences. Thank you so much. Thank you.
Thank you. With this, we come to the end of our free paper presentations. Once again, we would like to thank our chairpersons, Professor Paritosh Pandey, Professor Girish Menon, and Dr. Jyotish L.S. We will be moving on to our first session. A few announcements. The general body will be held at 4:30 to 5:30 p.m. at Chambra Hall, that is Hall B. The inauguration function will be held from 5:30 to 6:30 p.m. at Oriental Hall, that is Hall A. And for spouses and accompanying persons, a traveler has been arranged for tour purposes. For details, please contact the reception. For our first session, I would like to invite our chairpersons, Dr. Mohanlal D., Dr. N.I. Kurian, and Dr. Sudesh Kesar.
There is a small announcement to make to the PGs who are presenting the neurosurgery posters today. The first part of the judgment will be happening at around 11:15 a.m. in the exhibition hall. Kindly upload your posters for the same. And the first 6 persons to be judges will be Dr. Nitin Das PR, Dr. Anandu S., Dr. Muhammad Mansoor T., Manoj Kumar HP, Dr. Prafulla, and Dr. Amrita Subramaniam. Kindly reach the examination hall by around 11:15 a.m. today. Thank you.
Shall we start?
I would like to invite our first speaker of the day, Dr. Suresh Kumar KL. One of our most flamboyant heads of departments of neurosurgery in the state. KL sir, as he is popularly known, has a great circle of friends and admirers. He is a great surgeon and has been the head of neurosurgery in Kozhikode, Alappuzha, and now serves in GMC Trivandrum. An accomplished spine surgeon, he enjoys en masse resection of lesions, and as is shown in the picture, nothing is impossible for him. We welcome you, sir.
Respected seniors, my colleagues, junior neurosurgeons, budding neurosurgeons, my students. Good morning to everybody. See, why I am presenting this is, see, before I finish my endings in the government setup, I like to present this presentation as an opening batsman in this conference CNS. For inviting me to this conference, I first of all giving my thanks to the organizers of CNS. So why I selected this topic for the presentation is just the smiling face of a patient of mine. That is a great achievement for our department. I will start the presentation with a case scenario. It's an 11-year-old girl brought to my OP because she is not able to go to school. She presented, her complaint started as pain and restricted movement of the neck of 6 months duration, for which she was taken to the hospital and investigated, but she never turned back. Then 3 weeks before our presentation, she developed weakness on the left side of the body, which gradually progressed within a week and make her not able to walk. So on examination, she was not able to walk. She is able to walk with support, but it is wheelchair bound. She had only grade 3 power in all the 4 limbs. This is the MRI picture, which showed, as you all know, is an atlantoaxial dislocation with that tip has gone up. And this is the CT picture. There is atlantoaxial dislocation, and that if you inspect that each joint, the left C1 C2 joint. Can you give me? Yeah. See the joint. See the C2, the C1 has gone back on the left side, and if you go to the next slide, you can see that here the C1 has gone anteriorly. So this is rotary subluxation there. There is a total rotation of the C1 over C2. This is the 3D image. Here you can see, if you see the posterior, this is the spinous process of C2, and see where the spinous process of C1 has gone. And in the anterior view, you can see that this is the C2 body anteriorly, and what happened to the C1. So what we did was, we did a posterior C1 C2 fixation. The traction, distraction, compression and fixation was done. This is the postoperative picture. You can see how much reduction has been achieved, the vertical migration. See, it's a small video. You just see this is immediately after the operation, how she's walking. She was bound in a wheelchair bound condition. See, this is the one after 1 month later when she comes to the OP for that. The smiling face, that is the one I try to convey you. How much is the patient getting satisfaction from our surgery? So coming to the another case, the second case I just want to tell you is that a 20-year-old male, he met with a road traffic accident. Initially he had a minor head trauma. 1 week later he developed neck pain. He was neurologically intact. This is a initial CT scan which showed, as you know, this is the odontoid fracture. The type you can decide whether it is 2A or 2B or 3. See, initially, since we are in the medical college setup, we tried conservative management to cervical immobilization, as Philadelphia collar. He was on regular follow-up. 6 months later, we repeated the CT. You see what happened here. There is a non-unit. The gap is still persisting. So we did an anterior approach, that anterior transcervical plate and screw fixation. This is the post-operative picture. You can see that that C1 and C2 is in alignment. So my presentation is not meant for the senior faculty. This is just meant for the juniors who are trying to do this C1 C2 fixation. So what are the dilemmas you are come across when you do a case like this? See which approach you would like to select, anterior approach or posterior approach. How to reduce an irreducible joint, and addressing the chiari, especially complex chiari associated with the C1 C2 subluxation or dislocation. Addressing the vertebral artery, aberrant vertebral artery or high riding vertebral artery, what to do for that, and whether to do an odontodectomy or not, and whether to include the occiput in the construct. These are the problems that we have to address while doing this procedure. See, there's a little bit about the anatomy of the C1-C2 joint. It's the most mobile portion of the entire spine. It's the trade-off between stability and motion. Two lateral and one median joint. The movements depends upon the concretivity of the articular surfaces, and that is smoothened by the cartilages. The stability depends upon the ligaments and joint capsules and the bony architecture. See, example, the C1 arch prevents the anterior translation of the dents, and also the transverse ligament that prevents the posterior dislocation in the normal condition. This is a picture showing that the important things here is the transverse ligament and the LR ligament. This is a normal X-ray picture, normal alignment of the C1-C2 joint. See, this is C1 and this is C2. This the alignment that normally that will be parallel. The joint space will be that space is parallel, and also is a congruent. This 1, 2, 3. It's a congruent. All the 3 points are congruent. What are the main movements in that C1-C2 areas? So out of the 90-degree rotation of the cervical region, 50 degrees is at the C1-C2 junction. And lateral flexion is only 10 degrees, and the flexion extension is only 5 to 10 degrees. Coming to the AAD classification, there is a reducible, irreducible. Reducibility on flexion, extension, or on traction. Depending upon the pathology, you can classify it into developmental or acquired one. And depending upon the direction of subluxation, it may be anterior, posterior, vertical, or lateral rotary, or mixed. See, there is little bit of congenital problems may be there in the alignment of the C1-C2 joint that aggravates the slippage of this thing. See, this usually it is parallel. If there is slight obliquity of the facet, C1-C2 facet, there will be increased chance of slippage. And also, if you look at the coronal plane, if the angulation goes, there will be slippage of the C2 into the C1 ring. And likely that lateral subluxation also there, that C1 slip laterally to the C1, C2 over C2 and C3. A rotary subluxation, there are different types, type 1, 2, 3 and 4. That depends upon the pivot along which it occurs. If it is on the dents, it will be type 1. If it is on the facet joint, as a pivot, it will be anterior displacement, 3 to 5 millimeters for anterior displacement will be there. In type 3, both sides subluxated, anterior displacement more than 5 millimeters. And like that, type 4, posterior displacement with a rotation. What about reducible and irreducibility? See, all the reducible things starts as reducible one. The angulation of C1-C2 joint leads to the slippage of C1 over C2. Compensatory mechanism, usually when there is a slight slippage of C1 over C2, there will be hyperlordosis, increased lordosis so that the vision can be horizontal vision. That increases the slippage. And there will be associated soft tissue. As it becomes irreducible, there will be soft tissue changes in the capsule or in the ligaments that will become fibrotic. And there will be pseudo-facet joint formation between C1 and C2. It may be C0, C1 or C2. See, this hinders if there is pseudo-facet, the problem is while attempting to drill that C1, C2 space, this comes first. We have to this hinders the access to the C1, C2 joint. So we have to do extensive drilling. But this gives increased surface area helpful for fusion after drilling. So how will you assess the irreducibility? How will you predict this irreducibility? That depends upon C1 inferior sagittal angle. See that there are two lines. One is through the hard palate to the opisthion. And second one is along the lower border of C1, that is anterior inferior part and posterior inferior part. Usually these two almost parallel. If there is more than increase in the degree, in 50 degree increase, it will become reducible. That means if that first line comes or goes vertical, there is the chance of reduction is less. So this is an X-ray CT lateral film showing this is normal alignment. both the lines are parallel. See, in this, there you see, this is the first line going along the heart palate, and this is the line going along the C1 inferior margin. See, this almost becomes 90 degrees. So it becomes irreducible. A word about basilar invagination AID. It's a developmental anomaly of the CV junction. A duodental process abnormally prolapses upwards and backwards into the foramen magnum. Many type of classifications there, primary, secondary. According to Goyle, Dr. Atul Goyle, the type A and type B. Type A is associated with instability. Type B, the basilar invagination with the maintained relation between C1 and C2. So the type 1, see that Chamberlain and the McLean lines, the tip will be below that, above that, it's gone up. There will be instability. In type 2, the dense anterior arch of atlas and clivus migrate superiorly, but tip violates the Chamberlain's line. Where is it? Okay. The treatment of basilar invagination, type A is due to vertical atlantoaxial dislocation. Treatment is posterior reduction, joint distraction and fusion. For type B, if there is associated platybasia and Chiari, including the Chiari, complex Chiari, foramen magnum decompression is the primary thing, followed by posterior fusion or anterior decompression and posterior fusion. The bony anomaly is associated with basilar invagination. This comes to the complicated Chiari. Basio-occipital or clivus hypoplasia, occipital condyle hypoplasia, atlas hypoplasia, an incomplete ring of C1 with the spreading of lateral masses and achondroplasia. Atlanto-occipital assimilation is also an anomaly. And Chiari and basilar invagination, incidence of basilar invagination in patients with the Chiari is 12 to 35%. There is a coexistence of basilar invagination and Chiari. Two theories. It may be due to embryonal degenesis of occipital sclerotomes, or it may be a protective mechanism for basilar invagination. So here comes that Dr. Atul Goyal's statement that fusion for Chiari instead of a foramen magnum, that improvement of the patient occurs in 96% of the patients. Surgical correction of AAD objectives are to achieve the reduction of the dislocation in all planes by opening the capsule. Whether it's to achieve reduction or comprehensive drilling of the facet joints to make the surface flat, reducing the dislocation, joint spacers, vertical AAD, you can use that, tightening the screws while extending head manually. Distraction and joint manipulation with the osteotomes in C1, C2 joint using C2 isthmus as a fulcrum. This is the method described by Dr. Goyle, or manipulation using constructs. So this is the drilling of the irreducible joint. So this pointer is not working. See what happened to the cursor, it's not working. So it helps to remodel the joints at normal to a near normal one. Till the anterior, you have to drill till the anterior capsule is visible from the medial to lateral extent of the joint. And then it will become easy to manipulate the C1 and C2, and that prevents dislocation. And extensive surface enhanced the area you will get that enhanced fusion. The role of distraction again, it's achieved using spaces or bone graft. Reduction of the vertical AAD, that is in basilar invasion, reduction of basilar invasion is roughly equal to the height of the spaces what we are using in that area. It compensates the loss of height due to drilling. It acts as a fulcrum during compression and tightening of the construction, the extension. C1, C2 instrumentation, different methods are there. Sublaminar wiring there, clamps and hooks, there is Halifax clamps and other clamps. But these are all nowadays not used nowadays. That screw fixation becomes the technique now. There may be transarticular screws, Goyle and Lacry's techniques, plate and screws, and Harm's modification with the rods and screws. See, interarticular screws are the standard now we are using it. This Goyle and Lacry's technique in 1994, he used C1 lateral mass and C2 pedicles, fixed using plates of 2.5 to 2.9 millimeter size, and screws used are 18 to 24 millimeter long screws. See, the entry point for the C1 lateral mass is center of the C1 lateral mass in the medial lateral plane. That's here, and it is slightly inferior to joining of the arch of atlas and lateral mass. That is junction of the atlas and laterally down. Then medial angulation is 10 to 15 degrees and lateral angulation is also 10 to 15 degrees. Entry point for the C2 screws is superior medial quadrant of the C2, and also the angulation is 20 to 30 degrees medially and cranially 20 to 30 degrees. We can safeguard that the spinal cord using a Penfield dissector. Excellent fusion. The disadvantage is vertebral artery injury, C2 dermatomal sensory loss. We have to reduce the subluxation prior to fusion. The Ham's technique, it's almost the same. Only thing is we use the rod and screws concept. It's a manipulation for reduction after screw insertion is reducing the AP translation by caudal rotation. For lateral translation, you can use clockwise or counterclockwise rotation. See, coming to the vertebral artery, the anomalies, there are different anomalies that are there. So its incidence is 5%, it's bilateral in 10% of the cases. There's increased frequency in bony anomalies along in this region. The persistent first intersegmental vertebral artery passes below the arch of the atlas. It passes over the C1 C2 joint posteriorly. Then another is extracranial origin of pica or fenestrated arteries like this one. How do you safeguard the vertebral artery injuries? Pre-op CT angiography to identify the anomalous loop or high riding vertebral artery. Instrument the non-dominant or normal side first. The trajectory of the artery will be over the C1 C2 joint. Identify the artery by cutting the C2 ganglion. Artery identified at its exit from the C2 foramen. Dissect away the artery from the screw trajectory. Alternate options like sublaminar wiring or occiput can be included in the construct if you find difficulty in identifying the vertebral artery. Avoid using monopolars and use suboriental resection. And you can use Dopplers for identifying the vertebral artery while doing surgery. See, what is the role of transoral orundectomy? Majority of the irreducible atlanto-axial joint dislocations or basilar invasion can be successfully treated with the posterior approach. Only present indication for the orundectomy is persistent myelopathy due to ventral compression after posterior surgery. Routes either transoral or transnasal. For transnasal, the extent of vision will be less compared to transoral diet. A word about anterior C1 C2 fixation. Two types: transarticular screws fixation by Dr. Baba and C1 C2 screw and plate technique by Dr. Watkar. This is the screw and plate technique. That C1 screws entry is 5 mm above the midpoint of C1 C2 joint line. Trajectory is 20 degree upwards and outwards. 18 to 20 mm long 4 mm screws are used. Likewise, C2 screws, after adjusting the plate over the C2 body above the C2 C3 disc base, trajectory is 20 degree medially and 18 to 20 mm 4 mm screws are used. The anterior C1 C2 transarticular screws, entry point is infero-medial quadrant of the C2, lateral mass, and trajectory is 25 degree upwards and outwards and confirmed by intraoperative fluoroscopy to engage the C1. 20 mm screw, 4 mm diameter. Advantages, you are keeping the head in an extended position, so it's a position of reduction, no violation of posterior musculocutaneous ligaments, no risk for injury to vertebral artery or C2, especially in plate and screw fixation. Disadvantages, injury to the hypoglossal nerve, lateral screw placement, sometimes screw cut out and a risk of injury to vertebral artery, especially in transarticular screw fixation. Medial screws can violate the occipito-atlantal joints. So solving the dilemmas that I came across is posterior and anterior, whether posterior approach or anterior approach. I think a posterior approach is better for us. How to reduce the reducible comprehensive drilling of the joint. Addressing the GRD, complex GRD subset need fusion in addition to foramen magnum decompression. Addressing the aberrant vertebral artery, dissect and delineate it. Inclusion of occipit in the construct is used as a last resort. So, coming to the conclusion, posterior approach to the open reduction and fixation has made orundectomy a redundant procedure. Comprehensive drilling of C1 C2 joint surface to make it flat is essential step for air fusion. Posterior approach is better than anterior approach. Thank you.
Thank you, Suresh. Do we have time for questions? A little late. But 43 years ago, when I was introduced to neurosurgery, my professor then told me, who himself had a spine surgery as his lady love. He told me, Mohanlal, if you get a cervical spine, whichever area of it that is, more so with the atlantoaxial junction, you refer to your enemy. So that used to be the state of the art then, and I find things have advanced so much. Any comments, please?
Excellent presentation, Dr. Suresh. One of the most difficult in neurosurgical area. My question regarding practical issues in this area when we come across cases. All cases you have you C2 in your construct have come. Any situation where you cannot include C2 in your construct. Any situation that C2 cannot be involved in.
That's why it's a high riding vertebral artery. It will be difficult, no? You can put screws. In that case, if they are not, it's not possible, you can go to C1, C3 lateral mass also can be included in the construct.
So I told this in certain road traffic accident cases. Recently, 3 days back, I operated a case where there is axis is totally destroyed, posterior aspect, spine and lamina and also fracture going to the pars area, where we cannot neither put sublaminar wiring or nor put the screws. Such situation we have to go to. In that case, you can
go for anterior approach.
We can go to C3.
Yeah, that also
C3 sublaminar wiring done in this particular case.
The construct should be stable.
Because patient is very stable, only problem is grade 0 of the left upper limb. And other limbs are 4+. So patient is very conscious. So we have, and also patient is having a type 1 Jefferson including anterior arch of atlas. And also mild subluxation at the occipito-atlanto joint also. That case, occipito is also involved to use occipital fixation also done.
That can be done
but
as a
in this particular case, the occipital, that area was very thick, almost 1 centimeter. In this case, such situations, you cannot take wire through for magnet through the hole. In that situation, we can make a little widening of the occipital hole and make a tangential hole from the edge of the foramen magnum into the hole without touching dura, where you can get a very good construct.
What sort of construct?
And bone graft, iliac crust wiring and titanium wires are used as it's a small titanium wire available, but we have to do double layer, not single layer is very thin. And iliac crust graft we have to take around 7 centimeters length to include in this area bilaterally. On both sides of lamina we can put and make a construct.
See, you can use plate and screw. One part is plate. You can fix it with screws in the occipital region. No need to put
this
wires
is better
there.
fusion. Bone graft is used to get a better fusion.
Yeah,
so that and also if we can bone powders you can put in the holes and all. So I have done this case 3 days back. And patient post separately is recovering. Even with the traction with that is this reduction achieved. There was 4 millimeter anterior displacement of the axis from the joint. So it is a dislocation at T3 Langman fracture. The 4 millimeter displacement anteriorly. And the reduction came with 4 kg weight in 4 days time. And the 5th day we operated.
That's for Hangman fracture, no?
Hangman fracture was the picture. The clinically, that C2-3 area, where there is subluxation and also Jefferson type 1 also there.
Right. Vinu.
Yeah. You attempt the fixation of the conduit also.
Conduit we tried, but we couldn't, because the problem is there is a limitation of the jaw. You know that if there is if the angle of the mandible is down, it will be difficult for us to see that C1. That is the difficulty. So we came across.
If the LR ligament is also injured, should have also fixed the conduit.
Yeah, right.
Can I just ask one thing?
Why not, sir?
What is your comment on one of the prominent neurosurgeons of India? He is doing away with decompression for Chiari. He says decompression is not that.
See, nowadays, when I started my neurosurgery career, I thought it may be difficult for us to do these procedures. But now I think it is a good procedure.
No, what one surgeon says that decompression, foramen magnum decompression is not the answer for Chiari.
Yeah, that's what I mentioned in that, sir.
You told
I told.
decompression.
Yeah. It's not an absolute necessary to do foramen magnum decompression. You can go ahead with that C1C to distraction fixation. Yeah.
So,
Ajit. Yeah, Ajit.
If you are not able to put a pars pedicle screw because of high riding vertebral, translaminar is a very
Translaminar is
very good purchase.
I think it's a very complicated topic and there will be a lot of questions. So, because of lack of time, we have to stop this. I just give a comment regarding one of my friends who was doing my postgraduate with me, that 2 cases he assisted, both landed in ventilator for about 3 months. So he had no dilemmas at all. He said he will never operate AAD because they are so complicated things. So thank you, Dr. Suresh. For the
So that is why I selected the topic for the presentation, because previously I am also scared of doing this surgery. So for the beginners, I think it may be an eye opener for the beginners. Thank you. Thank you once again for the organizers of the CNS for wonderfully arranging this program. Thank you.
Thank you. I would like to invite a chairperson to please present a memento and certificate to Professor Suresh.
I will call upon next speaker, Dr. Ishwar, for his talk on middle fossa approach. Neurosurgeons are always fascinated by going to different approaches. And an approach usually used by the ENT surgeons earlier now is being used by neurosurgeons a lot. And I invite Ishwar to give his ideas about this.
Shall I? Okay. Respected chairpersons and the esteemed members of this audience. As always, I begin with a confession. And the confession is that I had struggled through all the years of trying to become a neurosurgeon by hearting the triangles of the cavernous sinus. And when I had to make this presentation, when I started doing these surgeries, I had to struggle again. The struggle just continues. Now, why is it that the middle fossa is important? The middle fossa is important because not because it is located below the temporal lobe, also not because critical neurovascular structures are located there, but it is the gateway to the cavernous sinus, the anterolateral pons, the internal auditory meatus, the tentorium, the sphenoid sinus, the petrous carotid artery, infratemporal fossa. Not many approaches can claim to have an excess of this kind of magnitude. Now, when you look at the history of middle fossa approaches, it was popularized for the cavernous sinus by Parkinson and Dolenk, then Parry and later William House. This was basically a preserve of the ENT surgeons for several years when they tried to treat vestibular nerve sections for vertigo and autosclerosis, etc. But then the man who made a paradigm shift was a neurosurgeon called Kawase, who modified the extended middle fossa approach. These people were doing a total petrosectomy for it when Kawase came up with the modified petrosectomy, which helped him to clip a low neck basilar tip aneurysm. The Kawase's approach has been very popular with the neurosurgeons for several years. Now let me come back to the dreaded triangles about which I've been talking when I went to the beginning. The most key triangles when you go in for a middle fossa approach are the anteromedial and the anterolateral triangle. The anteromedial triangle, also known as the Mullen's triangle, between the first and second divisions of the trigeminal nerve, and the anterolateral triangle located between the second and the third division, the maxillary and the mandibular divisions of the trigeminal nerve. Okay, these are the key triangles when you go in there. And then you have the Parkinson's, the posterolateral triangle known as the Glass-Cook's triangle, which gives you access to the petrous carotid artery, separated by the GSPN from the posteromedial triangle known as the Kawase's triangle. I'll be referring to the Kawase's triangle again in my lecture. This is again a diagrammatic representation of all the triangles in the cavernous sinus. This is what I said, very difficult to mug up. But the key triangles that we are concerned about is anterolateral, the posterolateral, or the Glasgow's triangle, which is located between the V2 and V3, and the posteromedial triangle located in front of the GSPN, lateral to the third division of the fifth nerve, and the paraclival triangles, which are not accessible through the middle fossa, difficult to access from the middle fossa. Now, for the middle fossa approach, we usually go in for a question mark incision. Some people prefer, we also do the square incision centered around the ear. The 2/3 of this craniotomy will be in front of the external auditory meatus and 1/3 behind it. This is about 4x4 or 5x5 centimeters. Again, I'm coming by referring to the triangles again. The Mullen's triangle between V1 and V2, the ophthalmic and the maxillary divisions of the trigeminal nerve is a key access to the cavernous sinus, especially the medial cavernous sinus. And also it can go down into the sphenoid sinus. This is a diagrammatic view of what you get to see when you push the dura back on the floor of the middle cranial fossa. You have the V3 on the the mandibular division of the trigeminal nerve, the middle meningeal artery, which is kind of identified and cut, the GSPN, which forms the boundary between the posteromedial and posterolateral triangles, and the arcuate eminence on the lateral aspect. This is between the 120 degrees that lines, or between the lines of the GSPN and the arcuate eminence, lies the lie of the internal auditory meatus, internal auditory canal. Now, the first step, of course, is when you are doing a middle fossa approach, is to identify the superior orbital fissure. So when you identify the superior orbital fissure, you start pushing back the dura, and then you get to see the foramen rotundum. This is the next step. The third step, of course, is once you have delineated the foramen rotundum, go further laterally to the foramen ovale. Okay, the foramen ovale. And the last step, of course, in the first series of steps is, of course, the identification of the middle meningeal artery. Once you've done that, then you strip the dura over the second and third divisions of the trigeminal nerve to get into what is called as the interdural approach. Most of the trigeminal schwannomas that are located in this area can be accessed through this interdural approach. Let me again go into the middle cranial fossa floor. You can see this is the first division of the ophthalmic division of the trigeminal nerve going into the superior orbital fissure, and this is the second division, that is the maxillary division going into the foramen rotundum. You can see the tumor is peeking out between the V1 and V2, the second and third, the first and the second divisions of the mandibular. This is again a zoomed up view. You have the maxillary nerve going here, you have the ophthalmic division going here, and the tumor can be seen very well in between the two. So this is a safe corridor for accessing the tumor. And once you do that, you enter into the capsule here, and when you open into the capsule and start decompressing until the tumor is completely removed, and we always use the oxidized regenerated cellulose to get hemostasis at the end of it. So you can see the maxillary division going in, the ophthalmic division going in, and the tumor removed, the cavity of the tumor paracellular. This was a trigeminal schwannoma which was removed through this route. The second case which we did was a chondrosarcoma, where we had to open both the anteromedial triangle as well as the anterolateral triangle to remove the tumor completely. Fortunately, the patient came out without any new neurological deficits at the end of the surgery. This was an interesting case which was actually not suitable for a conventional middle fossa approach. This is actually a clinoidal meningioma. But the interesting thing about the clinoidal meningioma was it was wrapping around the carotid artery in the paracellular location. So it was paracellular, paracavernous, extending into the middle fossa. So here we had to start by drilling we had to flatten out, we had to remove a lot of dura here and coagulate the blood supply to it. This tumor had supply from the ethmoidal arteries too, because it was going in here, the post-ethmoidal artery also. And then we went inside the superior orbital fissure. Unfortunately, we lost the third nerve in spite of constant nerve monitoring. We could remove the tumor out, but the patient came out with a complete third nerve palsy at the end of it. The good thing was that she was alive and well at the end of surgery. Let's go to the modification of the middle fossa approach, of course, the extended middle fossa approach. As I said, it was Kawase who modified this by limiting the petrous bone drilling to the apical area, or what is called as the Kawase's anterior petrosal approach. Okay, I'm not going into the history of it. This is the classical tumor that is suited for a Kawase's approach. When do we go for a Kawase's approach? When the tumor is hiding behind the petrous bone, here, and the temporal lobe is in front of it. So here, this is where you can go from the through the middle floor of the middle clin fossa to the posterior fossa and remove this. This tumor is pressing on the anterolateral aspect of the pons as well. So this is a classical case which can be used for removed using the Kawase's approach. Let's go to the positioning and incision. I prefer the lateral position when the mid-sagittal suture is parallel to the floor of the operating room. You can go for a C-shaped flap centered around the ear, or you can go in for a question mark incision. Both incisions are favored. And then you do a craniotomy. The skin flap is reflected down and the temporalis flap is reflected anteriorly. And then the next thing is to flatten out the middle cranial fossa floor base up to the mandibular joint and the external auditory meatus. And then when we come to the Kawase's triangle again, this is for the sake of residents and strugglers like me. What you can see is the Vythiri, the lateral aspect of the mandibular division of the trigeminal nerve. And then you can see the horizontally placed greater superficial petrosal nerve, which runs from the geniculate ganglion to below the Vythiri, or the third division of the trigeminal nerve. And you have the petrous ridge on the posterior aspect. The arcuate eminence will come here, and this is the internal auditory meatus. So this is the safe area of the Kawase's quadrangle through which you can access the posterior fossa. So the GSPN forms the medial boundary. The anterolateral boundary is formed by the Vythiri forms the third division of the trigeminal nerve, forms the medial boundary. The GSPN forms the anterolateral boundary, and the posterolateral boundary is formed by the petrous ridge. Now, here when you go in, the first steps are same as before. You identify the middle meningeal artery and the foramen ovale. You coagulate the middle meningeal artery and start stripping the dura back. I prefer still photographs because they convey more than a video which is understood only by the person who presents. And then we get to see the Kawase's quadrangle. So here you can see, this is on the right side. Earlier one, the photographs I showed was on the left side because the video was not very good in this case. So you can see that middle meningeal artery which is coagulated, the foramen ovale here, through which the mandibular division exits. And this is on the right side. You can see the mandibular division of the trigeminal nerve going anteriorly. You can see the GSPN running in the front and the petrous ridge here. The arcuate eminence will be on the right side. This is again a zoomed up view. You can see more of the mandibular division. It's a lateral wall forming the medial boundary of the Kawase's quadrangle. The GSPN running anterior to it, and the petrous ridge on its posterolateral aspect, and the arcuate eminence hidden by this gauze piece here. Again, I'm showing this because this is a key thing which helps you to prevent complications. You have the mandibular division, the GSPN, the arcuate eminence, and the petrous ridge. Now, the next step, of course, is to drill the Kawase's quadrangle. Now, one of the things which we do when we peel off, one of the key steps when we peel off the dura from over the GSPN is to come from medial to lateral. Many people advocate doing it from the geniculate ganglion anteriorly, so posterior to anteriorly. But this maneuver is fraught with the risk of injury to the seventh nerve. So we always go from anterior to posterior. Now the next step, of course, is to drill the Kawase's quadrangle. How do you know that you're drilling the right place? The bone is extremely cancellous, and if you are encountering a thick, dense bone, you have to stop because you're maybe entering into the middle ear structures, labyrinthine structures. Now the next step, of course, is to identify the superior petrosal sinus, ligate the superior petrosal sinus and make a T cut. The T cut, the transverse cut of the T will come on the superior petrosal sinus, and the vertical cut will come on the dura of the temporal lobe. So this will give you access to the posterior fossa, dura, as well as the 10th. This is the dimension. Neurosurgeons are people who do big things through small openings, no pun intended. You have a 1.23 centimeter size opening through which we enter into the posterior fossa from the middle cranial fossa. The classic indication for a Kawase approach was for a low neck basal or tip aneurysm, but it's also used for upper and mid-clival lesion, petrous apex lesion, as well as intrinsic pontine lesions. Now, what are the advantages of the Kawase's approach? We don't hurt any neurovascular structures when you go in through the Kawase's quadrangle. And the most important thing is you find the tumor blood supply initially itself as we dissect out, so that the bleeding is well under control. Now, the limitations of the Kawase's approach is, of course, tumors extending lateral to the internal auditory meatus and inferior to the auditory meatus or the mid-clivus level. So, when you have a tumor that goes below that, the mid-clivus or below the internal auditory meatus, it is not accessible by the Kawase's approach. Tumors of the lower clivus and deep posterior fossa also are not accessible by the Kawase's approach. Now, complication, every procedure comes up with its own set of complications. You can open the semicircular canal, you can injure the internal carotid artery, which is located anteroinferior. You can have temporal lobe contusion and dry eyes, seventh nerve palsy, and cerebrospinal fluid leak. This is a classic one which we operated, petroclival meningioma, which we operated through the Kawase's approach. Unfortunately, we could not remove a bit of tumor which was located lateral to the internal auditory meatus. So this requires a separate approach from the posterior aspect. But we are just following up this patient. This is one case where you don't have to do a petrosectomy because the tumor has already beheaded the clivus, the petrous bone. But again, you see this posterior part of the tumor had to be left behind. We are planning to go in through a retromastoid approach later. What are useful? Where did we find this useful? We used it for our trigeminal schwannomas. We used it for our chondrosarcomas, meningiomas, invasive pituitary adenomas, and the classical ones which has been described by mid-basilar aneurysm. So we don't have any experience with that. And also it has been used for facial and intracanaliculaar vestibular schwannomas. So conclusion, middle fossa offers multiple surgical corridors in the skull base, including access to the cavernous sinus, to the posterior fossa, the internal auditory meatus, etc. So the good thing about the Kawase's approach is that most of it is based on absolutely certain landmarks, like the middle meningeal artery, like the foramen ovale, foramen rotundum, and then the arcuate eminence, etc. So you are less likely to go astray when you are accessing the Kawase's quadrangle and therefore into the posterior fossa. Now, I wouldn't say that technology is not useful. Image guidance and nerve monitors are very, very useful adjuncts when we remove these tumors. Cranial nerve injuries potentially can happen to the third, sixth, and seventh nerve, and these are very real. I attribute all these procedures, success of these procedures, to my team at Sri Chitra, and I also welcome you all on February 4th to our Trivandrum for the first Dr. Damodar Raut oration being held for the first time in Sri Chitra. Thank you very much for your patience, and thank you organizers for a spectacular place that you have chosen for us.
Thank you, Dr. Ishwar. Very lucid presentation, excellent operative pictures. Kawase's approach is not as difficult as it seems once you start doing it. Any comments from the...
One is, Kawase approach was not described by Kawase. Kawase got the name for that. You showed that picture.
Shiobara and Kawase classically described it.
No, it's Bushnak and Kukuwa, 1975. You showed that their name. They described it in 1975.
The classic Kawase's approach was later popularized by Kawase. The name never went to the initial thing.
Bushnak and Kukuwa, they never got the name. But it was described by them. The ordinary middle fossa approach was described by House. Then
that includes a complete petrosectomy. Labyrinth is exposed entire.
No, not petrous apexectomy.
Not apexectomy, labyrinth.
Internal auditory canal for middle fossa canalicular tumors were described by William House. Later, Bushnak and Kukuwa described this petrous modified middle fossa approach. Kawase took credit and he described it as Kawase approach for mid-basilar aneurysm. My question, that is different. How will you protect technical steps, preserve this greater superficial petrocell nerve? It's a periosteal structure. How will you preserve that during surgery?
One third of most of what we first have to do is, as soon as we get to see that, you leave a layer of duro on top of that. And
that
sometimes
is
one third of it will have a bony covering over it.
How will you
And
preserve
what
that?
else you can do is, you use the nerve monitor to identify it.
Very
Because
difficult
the
to
seventh nerve definitely gets stimulated when you trigger the GSPN. So that's one way of identifying and preserving. We have preserved the GSPN in almost all our surgeries.
Okay.
We never had a problem in identifying and protecting the nerve.
It's difficult sometimes. My question to you is, do you do angiogram for all these cases?
Not all of them, except for the clinoidal meningioma which was going into the paracellular lesion. We did an angiogram.
So venous anatomy, do you study for middle fossa?
We do not require it per se as such.
It is required. It is required. Sometimes superficial middle cerebral vein. Normally it drains through the cavernous sinus or pterygoid plexus like that. Sometimes it drains through sphenopetrocell, spheno-basal sinus or sphenopetrocell sinus. In that case, you cannot do this stripping of the middle fossa dura. So it becomes mandatory. So you have to do that venous study before you plan a middle fossa.
Yeah, we have done about 26 cases with using this middle
we have
fossa
done
approach in
before
this
there
thing.
also.
Fortunately for us, we have not encountered any venous complications
And one more
attributable
thing
to
which
this.
I want to tell on your thing is, how you told you opened the middle fossa dura.
Towards the end.
No. Say when you open the middle fossa, ultimately for all these meningiomas and all, you have to open the dura. So you have to open the middle fossa dura parallel to the and above the superior petrocell sinus.
Yes.
Then you have to come below.
That is where the T-cut comes. The T-cut comes.
And below this petrosapexectomy, there also you have to do a parallel cut. Then cut the superior petrocell sinus. Last question is, how do you open the Meckel's cave?
So we don't reach up to the Meckel's cave for a classic Kawase approach. What we do is, we strip the dura around the fifth nerve and then reach up to that. We don't have to do that.
I agree that for
We don't have to do that.
trigeminal schwannoma it is okay.
For
a petroclavial meningioma you have to open the Meckel's
No, we just reach up to the strip the dura over the Vythiri, third division of the mandibular division. That's all that's required. That gives us access to it. We may not have to go up to the Yasserin ganglion for it.
No, for petroclavial meningioma, you have to open the Meckel's cave.
No, we never went into the Meckel's cave during the surgeries.
Sir,
And last thing, one more thing is the lie of the internal auditory canal may not be 60 degrees to GSPN and archway. It can vary also. Okay.
Yeah, it can vary, sir. There are 3 methods of finding that out.
I think that's the last question.
Ishwar, excellent presentation.
Thank you,
This is a very, very important neurosurgical approach, a lesion which is medial to the fifth nerve. The only way we can go and save the patient only through this route. Because even with all this technical advancement, any case you have temporal lobe damage. Any case?
We did not encounter any temporal lobe damage. The reason is, we always release some CSF from the temporal base itself, so that it became lax. The other alternative is to use a lumbar drain before surgery, so that the CSF is drained out and the temporal lobe is easily amenable for a retraction. And always retract over the dura.
Another thing is 10% of the cases, the vein of Labe can drain into the superior petrocell sinus. In that case, ligation can result in again damage to the temporal lobe.
Yeah. Fortunately, we have not encountered that in our series.
Thank you very much, Dr. Ishwar. Fantastic talk. I think that comes to the end of this session.
Yes, we would like to request Dr. Kurian, please present Professor Ishwar with a certificate and memento for his excellent talk. Thank you once again to our chairpersons, Dr. Mohanlal, Dr. Kurian and Dr. Sudesh. With this, we come to the end of our first session. One more announcement for spouses and accompanying persons. A traveler has been arranged And we would request you to please ask them to assemble at the reception at 11 a.m. We will now be having a short tea break and commencing with our second session at 11:05 a.m. Thank you. Is Dr. Paritosh Pandey, currently working in Manipal Hospital, Bangalore. He was professor of neurosurgery at NIMHANS, Bangalore. He is one of the very few neurosurgeons in India who is trained both in microvascular surgeries and endovascular neurosurgery, a very new breed of hybrid neurosurgeons. Also noted for his wisdom and views in social media, Dr. Paritosh is a mentor to the Young Neurosurgeon Education Forums of the Neurological Society of India. We welcome you, sir.
Okay, let me tell little more about dear friend Paritosh Pandey. Say he had his MBBS, his MCH at All India, prestigious All India Institute of Medical Sciences, Delhi. He was one of the brightest students who have passed out from AIIMS. Then was a faculty as units there. And after that he moved to Manipal hospitals in Bangalore. He is one of the brightest stars of Indian neurosurgery, highly technical, good surgeon, interested in vascular surgery. He is a chairman of the Educational Committee of Neurological Society of India presently. And he was an executive committee member of the Neurological Society of India, and he is the vascular surgeon. His interest is in aneurysm, AVM, carotid endarterectomy, not to mention about other complex brain surgeries. Paritosh, stage is yours.
Thank you for these very kind words, sir. I always get tongue-tied in front of you because you are the ocean of knowledge. You'll ask some questions which I will not be able to answer for sure. But this is a topic which is interventional thing, so that's why I am a little more confident here. Okay, sorry. Right. So, dural fistulas are abnormal low resistance, high flow arteriovenous shunts in the dural leaflet, and it's very important to note that these are in dural leaflets and not in the pile or in the brain, and they are often located in the dural wall of the dural sinus. The nidus is inside the dura, so you can actually, unlike a arteriovenous malformation where early ligation of a vein is disastrous, the aim in this treatment is the early ligation of vein and not the treatment of the nidus itself. Even if you ligate the vein, nothing will happen because the nidus is inside the leaflets of the dura and they will not have any hemorrhage here. These are rarer lesions than the AVMs. They are 5 to 20% of all vascular malformations, and most commonly seen in transverse sigmoid junction, sigmoid, deep venous and superior sagittal sinus. Two hypotheses are there. One is that there are pre-existing microscopic vascular channels, or there are new vascular channels which come after because of angiogenic factors. But the precipitating factor always seems to be something or the other, like venous sinus thrombosis of previous region, trauma, any kind of any trauma, or all these other precipitating factors are present here. If there is one thing that dural venous malformations which have a CVR need to be treated, dural sinus malformations which do not have CVR can be left alone. CVR is basically when there is a very high pressure in the dural sinuses there, then it starts refluxing into the brain, venous things, and that is the main cause of all the symptoms here. So dural AV malformation with CVR has annual mortality of almost 10%, but without CVR is a fairly benign lesion, and they can only present with some symptoms like tinnitus or sometimes very rarely as ophthalmoparesis. These are the two classifications that this will tell you the importance of CVR. So benign is in the drainage is in dural sinus, and it is antegrade drainage. So there is some dural arteries, there is fistula here, but it drains here. Now when you have a fistula here and the vein is also starts filling, or only the vein starts filling and no dural sinus, then these are aggressive lesions. So this is a Borden classification which has been expanded into by Cognard, but that is the same way. You have CVR, you don't have CVR. These are the two benign and aggressive lesions here. And that is why there are two groups of symptoms. One is non-aggressive, like tinnitus, headache, all these other things. And when there is CVR, you have intracranial hemorrhage, non-neurological hemorrhage, the dementia and other kind of symptoms which are there. So these are the various symptoms. Intracranial hemorrhage can be present, focal neurological deficit because of the venous hypertension, global neurological deficit like dementia, pulsatile tinnitus, proptosis, ophthalmoplegia, visual loss, papilledema, and facial pain. CCF is also, indirect CCF is also a type of a dural AV malformation, but we're not discussing it here. So imaging in patients without CVR, almost normal. And you can have very little, when you have symptoms like tinnitus and stuff like that, you will not have any symptoms, you will just have some veins here and there, and you'll have to do an angiogram to go ahead and diagnose it. But when there is a CVR, you will have enlarged pile vessels, flow voids, diffuse white matter edema. So these are the various things. You have bleed when there is a CVR here, and you can have this kind of bleed which is caused by a dural AV fistula here. But you can also have white matter T2 hyperintensity because of tentorial dural AV fistula, where there is no other lesion, only a T2 hyperintensity of bilateral medial structures. And you can see all these venous kind of structures which are there, which is veins. This is a typical appearance of dural AV fistula with enlarged, engorged veins here. Angiography, of course, is the gold standard of treatment, diagnosis and treatment evaluation. What we see in angiography is what are the feeders. More importantly, where are the veins, whether there is any cortical venous efflux or not. The more important thing is whether the brain is utilizing that sinus in the venous drainage or not. So many a times the venous sinus where there is dural AV fistula is redundant, and there is rerouting of the venous drainage of all these things, and the venous sinus can be and should be sacrificed here. So this is the management paradigm. If there is asymptomatic or tolerable symptoms, you just observe, or if there is an intolerable symptoms, you just have a palliative treatment here. But if there are symptoms, then either you do surgery or endovascular treatment, where we will come to that here, and for both aggressive treatments here. So for DAVFs with CVR, the aim of treatment in these cases is elimination of CVR. Without CVR, you mainly do not require any symptoms, and mainly there are three types of treatment: surgery, endovascular, and stereotactic radiosurgery. We'll come to that. So embolization is the first, second, third, fourth line of treatment of the dural AV fistulas, and almost 85 to 90% of patients are treated with embolization. And this can be done by two routes. One is transarterial and transvenous. Transarterial, the goal is to occlude the fistula itself, and distal feeding artery, glue or onyx is pushed through the proximal venous outlet. And you should get the venous outlet and what we call as a foot of the vein to avoid any kind of recurrence here. Initially, we used to do transvenous. Even now, we do transvenous sometimes when there is little less access of artery, or there is a sequestered sinus where you cannot go to the artery, and you go to the vein, sacrifice the sinus, or disconnect the CVR and achieve cure here. So I'll give you some few examples. This is a patient with 42-year-old female with intractable vomitings. MRI showed multiple dilated veins in posterior fossa. And this is the angiogram, and I'll play a video so that how we look at it here. So this is the external carotid artery injection. You see this MMA feeder, you see this occipital artery feeder, and then you see all these blotches of veins which are coming and then draining into the straight sinus and this thing. So this is a very aggressive kind of a dural AV fistula, and which needs early treatment in these kind of patients. There will always be some feeders from the vertebral artery, also from the meningeal branches of the vertebral artery. So next we go ahead and see how the treatment is done. So this is a small video of how the treatment is done. So we take a triaxial system. We will go into this branch of the middle meningeal artery. We reach till the venous where the fistula is here. So we take this injection from the microcatheter here. So this is the microcatheter injection which is filling the vein. And then you start and put the glue cast here, achieving complete cure. So this is what we call as a glue cast or onyx cast here, and achieving complete cure here. And this is the glue cast that is present in the posterior fossa. You see even the draining veins have the entire glue cast in this. All this is glue here. This is another patient with torcular dural fistula with a 39-year-old lady who had headaches without any deficits, and this was the MR angiogram. So if you see this here, there is this torcular dural fistula with multiple dilated veins here. This patient also had some blood supply from the pile things. So this is a video of the the diagnostic angiogram. So there will be an occipital feeder here, but occipital feeders are not very tortuous and not very good to go to. So we always look for a straighter feeder, which is a middle meningeal artery feeder, and we will find it in one of these external carotid artery injections. So this is the meningeal branch of the vertebral artery, which is also feeding these arteries. But that is not, this is the pile feeders from the middle cerebral and posterior cerebral artery. And this is what we want. So if you see, there is from the left side external carotid artery, there is a very nice straight middle meningeal artery which is draining straight into the dural fistula here. So this is a good feeder, and that is what we want here. So this is how we do this. There is a short video here. So this is where we want to go. So we take a guide catheter in the external carotid artery. We take a road map. Now we will see this is called the road map, where we have to, this is the wire and the catheter which is also coming here. So this is how we go ahead and do these cannulations of this artery. So it is going right here. This dot is the catheter tip, and the catheter tip will reach right at the level of the fistula. So it has to go as deep as possible. And then this is the microcatheter injection, where we show that it is filling, the entire thing is filling. And then we take it under roadmap. All this thing is the onyx cast which is there, which we inject through these things. There is still some residual fistula coming from the pile branches here, but you can do it through the external carotid branches only, because it will reflux back into this thing. And this is how we do this. This is entire the glue cast which is there. And this is the entire glue cast with complete occlusion. If you don't completely occlude it, it will recur, and there is no other ways. These are other things. There is a left transverse sigmoid junction which presented with bleed. This patient had dural fistula here, which is shown in this video. So if you see this, there is a middle meningeal artery feeder here with a cortical venous reflux, and we take the microcatheter here, inject, and achieve cure. And this is the cured dural fistula. So the key is to go, most of the times, almost 90% of times these days, we are going through the transarterial route. This is left transverse sinus AV fistula, which is present, which causes proptosis, and this proptosis was because it was refluxing right into the eye here, causing these fistulas. So all you will see is a large amount of veins in this thing, but you have to find a good middle meningeal artery or some kind of feeder, go till the fistula and start injecting, and you will find a very good onyx cast here, and leading to complete cure of the fistula. So all of them, this is left transverse sinus fistula. Go inside, you take the microcatheter here and cure this. Superior sagittal sinus sidereal fistula. This was a patient who had a very large STA, which was feeding into this thing through intradiploic connection. So outside somebody went and disconnected this thing, but the main culprit was the dural fistula, which was being fed by the middle meningeal artery itself. So if you see, this is the post-surgery, the STA has been disconnected, but there is still the middle meningeal artery feeder which is feeding this superior sagittal sinus fistula, and this is post-embolization leading to complete cure of these fistulas. Torcular dural fistula, this is the torcular dural fistula. We go into this, inject onyx. There was some residual which we had to operate, and we'll tell you this thing later. This is a recurrent torcular transverse sinus fistula, which was cured with transatrial embolization here. This is a very interesting case. This is a left lesser sphenoid wing dural fistula. If you see here, there is ophthalmic branch and the middle meningeal artery. Both of them are giving rise to a fistula, and the vein is completely dilated and going into this superior sagittal sinus here. So same principles, go very close to the fistula, inject this dye, and go ahead and cure this fistula here. Superior sagittal sinus here, again, same way. We go ahead and treat these fistulas, find a good vein, and treat these fistulas. Tentorial fistula here, we go ahead and find a vein, some appropriate artery to go ahead and do this. Usually we don't prefer to go through ascending pharyngeal artery because this gives rise to this, and post-procedure we have this. This is an interesting case of dural sinus malformation. I'm very sorry. This is a 2-year-old boy who had a very large dural sinus malformation here. If you see this entire dura, the sinus is, all this is his sinus which is dilated here. We go ahead and find a suitable middle meningeal artery here. This is a 2-year-old boy, so there is a problem of anesthesia, there is a problem of contrast, and leading to complete cure of these fistula. Sometimes we do surgery, especially for cribriform plate, tentorial, foramen magnum, complex high-grade fistulas where rerouting has happened already, and recurrent and residual fistula. So this is a patient who has a tentorial fistula who bled, and we have from the meningeal branch of the internal carotid artery. This is the fistula here. So we could not do embolization here, and these patients are quite good for surgery itself, and we'll show it how. So we just went ahead with parietal occipital craniotomy, interhemispheric approach. Just below the vein of Galen, we find this dilated red vein, and this is the draining vein. You clip this vein, and the fistula is completely cured. So this is how the principle is there. Unlike the AVMs where you don't clip the vein initially, and so this is the fistula. Superior sagittal sinus, we treated these patients with 2 times embolization, but we could not get a cure in this because there was an occipital artery feeder which we just could not manage in these with embolization. This was early in my endovascular era. You see this, all this thing is being rerouted into the anterior venous sinus systems. So because the superior sagittal sinus was not utilized by the brain, we went ahead and ligated it, surgically ligated it, leading to complete cure of these ends. So this could have been done through transvenous approach as well, going into the superior sagittal sinus, but we did it surgically here. So this is the patient who had residual fistula where we went ahead and did this. Transverse sigmoid sinus fistula. This was a sequestered sinus. There was very little access here. At that time, we could not access either of these 2 middle meningeal arteries because of some reason. So we went ahead. This is the culprit vessel where there is where it is going ahead and refluxing. So we went ahead. 2 attempts at embolization could not be done. Combined infratentorial and supratentorial craniotomy. We went ahead and did this surgery. This is the vein which is dilated. We cut this. There is another vein. This is the occipital lobe. There is down below is the cerebellum, and then we went ahead and ligated this sinus as well. Cut this sinus at both ends, so that completely cured fistula. So this led to complete cure. Ethmoidal DAVFs are of course the surgical methods. You go ahead and this is the ethmoidal DAVF. Nowadays people are going into the ophthalmic artery and treating these fistulas here, or coming retrograde to this place through transvenous and going ahead and treating these. But we can easily do it with anterior interhemispheric craniotomy and interhemispheric approach, and you just ligate this vein and we go ahead and do this. So this is the surgery which was done. Foramen magnum, this is the last patient, I think. This is the foramen magnum. I don't have the angiogram, but there is hypodensities along the foramen magnum here. You see these things. All this is dilated veins. This is actually a C1 dural AV fistula. This is more of a spinal dural AV fistula, and I'll show it to you in this video. So this is how it was done. This is suboccipital craniotomy. All these are bunch of veins in this in the foramen magnum. What we need to find, just as a spinal dural AV fistula, we need to find the artery which is supplying this entire set of veins. So we go ahead on one side, you see this, and this is where the fistula is coming from. So you ligate this vessel which is coming from the dura, just as you ligate in a spinal dural AV fistula, and that is basically curative. But because we were young and happy, we went ahead and took out all these varix of veins as well, and that led to a cure of these fistulas. So this is the fourth ventricular floor. You find the distal end, and you take out all these varix of veins. Right. So these are acquired lesions, unlike the AVMs, which are mostly congenital lesions, often secondary to trauma, sinus thrombosis, or craniotomy. These are located at various locations. Presence or absence of cortical venous reflux is critical in the management of these lesions. We have to, initially when we do an angiogram, all we see is a lot of veins which are present inside the brain, and you need to really see these three things. What is the arterial feeder from the external and internal carotid artery? What is the venous phase? And how is the venous return rerouted inside the brain, and whether the sinus is redundant or it is functional. Once we see all these things, we can go ahead with transvenous and now very, very increasingly transarterial embolization of these vessels. Onyx squid embolizing agent has revolutionized the treatment of dural AV fistulas, and management has become increasingly transarterial unless there is a good, unless there is no arterial route when we go ahead and do a transvenous embolization. When there is a single leptomeningeal vein which is causing CVR, these are good candidates for surgery, and it can be sometimes much easier and much less expensive than the embolization itself. Often, and one thing that we didn't say in this is these are very high flow lesions. So once we reduce the flow, there is a propensity to have venous sinus thrombosis or venous thrombosis itself. So prolonged period of 1 to 2 weeks of anticoagulation is sometimes needed for all these fistulas, sometimes with lowering of blood pressure to avoid these complications, because suddenly from a very high flow state, these become a very low flow state, and there is propensity towards venous sinus thrombosis. So with these words, thank you very much for your attention. Thank you.
Thanks, Paritosh, for that great lecture, making it so simple. I learned from your lecture. Before I give it to Hari, he is working in Amrita Hospital doing this. A couple of comments, you couldn't talk much on spinal dural AV fistula, which also we see common, except for one case you showed high cervical. But for want of time, probably you couldn't touch. Great lecture and congratulations. Hari, for your comment.
Thank you, sir.
Thank you, sir, for the excellent elaboration of the topic. Actually, your protocol of following up dural fistulas, how frequently you follow up after the procedure? That's always a controversy. Some people do angiographic follow-up, some people use MRI because it's a costly affair for the lifetime.
Almost all of them, it is very unlike the AVMs. If you get a foot of vein or the venous sinus itself, the recurrences are very, very low for embolization of these procedures, except for in patients with superior sagittal sinus fistulas, where we can find other areas of superior sagittal sinus getting affected here. So if we do one follow-up angiogram, I don't think there is any need to do yearly follow-up with angiograms and MRI should suffice. But yes, in patients we don't treat, even in those patients an MRI follow-up can suffice, because you can see if they can develop into a higher aggressive grade fistula. So if suppose it's a grade 1 fistula and you've not treated them, very, very few of them go ahead and become an aggressive fistula. And if they will become an aggressive fistula, you will see it on the MRI. So the angiographic follow-up is really, really not needed, and we don't do it.
Thank you, sir. Any other questions?
Alternate venous channels opening up, but how does it recruit arterial feeders? Just out of ignorance.
Yeah, so they say that there are angiogenic factors which are formed in some patients which lead to opening up the dural vascular channels, and that leads to a fistula which is present. So there is either partial recanalization of the previously occluded venous sinus, or there is recruitment of the veins which causes the CVR. So this is
some of these arterial feeders are big ones, so that's
big
what I was
ones,
wondering. How alternate venous channels okay, but
as the fistula grows, it keeps recruiting bigger and bigger fistulas, and it can become very, very, very problematic. Yes.
And why is this predilection for this transverse sinus area? Superior cell sinus thrombosis, which we see quite often, CVTs.
Yeah.
We seldom see fistulas there. It is usually in this area. That's why.
We don't know actually, but it is predicted in the transverse sigmoid
region.
Most of them.
We had last conference in our Jagat's, we presented dural AF fistula. We encountered quite a few of it. Once we look for it, most of these spontaneous intracerebral hematomas in young patients may be dural AF fistulas. That is one observation we made. Then we traveled a bit with Naufal doing intervention. We were doing a bit of it. We had a patient, very interesting, just wanted to share with you. He was a 40-year-old man who was being treated as a dementia on young onset for the last 5-10 years. He finally had an intracerebral hematoma due to the cortical venous reflex. And then when we did the angiogram for the intracerebral, we found a dural AF fistula. It was treated, and in the post-op period itself, while in the hospital before discharge, his dementia started recovering.
Yeah, absolutely.
Very, very, very interesting. Yeah. So it's one of the causes unknown to most of the time as a treatable cause of dementia, just like our NPH.
Absolutely, absolutely. Bunch of them have been treated with dementia of young for ages, and you find these kind of dural fistulas which
the latest edition of Human gives, you read that chapter, that pathophysiology, I am not remembering it well now, because when it is giving you the mechanism, he actually told 2 things about it.
Thank you, Paritosh.
Thank you.
Please stay on board. For the memento. Professor Suresh Nair.
Moving on to our next speaker. Our second speaker today is Dr. Rupesh Kumar.
Rupesh is another great giant of neurosurgery. He studied at NIMHANS, Bangalore, and I think I was his examiner also for this MCH exam. And Rupesh after that was a faculty at the prestigious JIPMER for many years before moving out to Apollo Hospital at Chennai. Before that, he had worked for some time with Suresh Babu. and one of the brightest faces. He's an executive committee member of Neurological Society of India and into so many other committees, ION, whatnot, everything. Rupesh, stage is yours. He is going to talk to us on technical nuances on surgery and eloquent areas of the brain.
Introduction, sir, and you are my examiner. I still feel that I am part of the student standing in front of you. I thank the Malabar Association for inviting me for this August meeting, and I enjoy this place. Just want to touch upon technical nuances in eloquent cortex, which is a lot of debate whether we need to do a biopsy or we need to do surgical resection. So I'll just touch upon this topic briefly. What is the definition of eloquent? Now with the advent of fMRI and neurocognitive evaluation, INM, every part of the brain is eloquent. But age old, we know that there are some areas which are eloquent, some on the surface, like motor sensory, Broca's, and some in the deep, like thalamus, hypothalamus, the brainstem. The tumors in this location are always a challenge. So due to fear of creating a deficit, when the patient comes intact, especially low-grade lesions, we tend to play safe, do a biopsy, and then plan for surgical treatment. But are we doing the right practice? We always know that there is a risk of malignant transformation, high-grade, and tumor heterogeneity. We may miss the diagnosis if we do a biopsy. Surgery has its own advantages, various advantages we have, but at the same time, there's a risk of giving a deficit if you are operating on nuances. But the literature suggests that the more and more publications are now coming out favoring surgical resection rather than just biopsy, as you see in the evidence in this literature. I just want to pick up one article, which is a very landmark article in 2008 by Smith, and we found that there's a significant advantage of resection of more than 90%. There's a significant improvement in the overall survival, progression-free survival, and malignant progression-free survival. So this was quoted in many journals. After this 2016 IHC integrated into the pathology, we find that the IDH plays a significant role, and there are some studies now which has come out for a low-grade gliomas, IDH wild type. As you see here, there's a significant advantage of resection over gross-total over non-grossal, not much with ODG, oligodendroglioma or IDH mutant. Conversely, for high-grade glioma, it is the other way. The IDH mutant ones benefit much from a higher risk of advantage of resection rather than the IDH wild type, which are much more poor prognostic factors. So all these factors has to be considered when you are planning surgical resection in both low-grade as well as high-grade gliomas. As neurosurgeons, we need to take a balance, one on the oncological outcome, the other on neurosurgical outcome. So it's a very fine line which we need to walk. It's very risky, but then over experience and with gaining knowledge, we should aim for a safe maximal tumor decompression wherever it is, with better oncological outcome, at the same time preserving the neurological function of these patients. Today, we have everything in the gadgets to support surgical strategy, right from pre-op, good planning, like fMRI, tractography, and intra-op adjuncts like awake craniotomy, intra-op monitoring, which can play safe, and we can achieve this goal. The planning right starts with the mapping of the brain, with the functional MRI and tractography. Do not take up these cases without doing these adjuncts, because it's very important. I can show you some of the examples how it can change the outcome in these patients. Intraoperative neuromonitoring has come in a big way, and it is the future, and one needs to get into use of this very frequently, not just for eloquent, even for non-eloquent. So we get used to that so that we can apply when it is necessary. The first and foremost is the phase reversal. I did not explain. Phase reversal is very important to map and monitor the motor cortex and the sensory cortex. And once you identify the mapping of the motor cortex, then we have to map the most important is hand and face, which is the widest representation on the cortical surface. So as you twitch, you can identify the facial twitching, the patient is awake, you can always map, and then so avoid these regions because that is maximum representation. Once you're done the cortical mapping, then you come to the subcortical mapping, which is now good gadgets are available with the suction electrode tip, which can tell us how far we are from the corticospinal tracts as we go towards the depth of the lesion, and that is very, very useful information. It gives us confidence so that we don't damage, and the rule of 1 milliamp, we are 1 millimeter away from the CST, that can help us, so we can stop short when we are 4 milliamps stimulation, so that we are at a safe distance, so that we don't venture into the corticospinal tracts. So these are very, very important. Awake craniotomy is not a new technique, it has been there very age-old times, but there's a lot of resurgence of these techniques. As I showed you, it's very useful, it gives a lot of confidence, and we can go for supramaximal resection even when the patient is awake, and you know that you're not going to give any deficit, not just for adult, although for pediatric patients motivated. Tumor fluorescence and intraoperative ultrasound, we know it's going to be useful for a resection, but what I want to suggest here is that for a low-grade gliomas, do not do CT scan post-op. Many times we feel that we have done a good resection, and when we do MRI after 3 months, there is a residue, whether we have left behind or grown, always this dilemma is there. So now the practice is that we cannot afford to have an intraop MRI, but we can always do a perioperative if you have MRI in your setup. We have been doing that for the past 3 years. At least I remember 9 cases we had to go in and remove the tumor, which we thought we have removed it, and an example of this is, you can see that a small nodule there in the temporal pole, which we left it. We went ahead same time, explained the family, and then we removed it. It's very useful. It is in a grade, lowish grade. Again, you can see that it's a perioperative MRI. The posterior part, we missed it, and we went ahead and removed it. Again, it's a large insular glioma. We missed the temporal portion towards the opercula. We had to go in and remove. So doing a MRI is a good learning for us than just doing a CT scan. So one can try and do, if you have an MRI institute within your system, please block the MRI slot in your patient before the patient is wheeled out of the OR, get an MRI done, and then you have a lot of things to learn, which we are still learning. Coming to the tumor-specific locations. So this is a glioma of the motor cortex in a young girl, 9ish. She was a classical dancer, very passionate for a dance, and this is bang on the motor cortex. You can see that in the fMRI, the tumor has displayed the leg area anteriorly and the hand area posteriorly, and we have very, very narrow corridor to work. Very motivated girl, though she is young. We counseled her. We went ahead with an awake craniotomy. We gave her video games to play, and she was very cooperative, good anesthetic challenge, and anesthetist did a good job, and we can see the complete removal, and she could get back to her dance after 3 months without much deficits. As you see here, this is just sent by her father, and so with the help of awake, we are much more confident, and she's a grade 3, she finished her radiation, and she came for follow-up last year, 5 years follow-up. You can see the tumor is free, and she's doing really well as she's entered her college. So awake craniotomy is something which can be used even in children if you have a good motivated child and good counseling. Sensory cortex are not that challenging compared to motor, but then in the sensory cortex glioma, when you operate, you cannot enter into the motor cortex and then create a new problem. So here the phase reversal and the subcortical mapping is very, very important, so that you can do aggressive resections like this post-operative as you see here. So just an example of a video how everything can be incorporated. So you can see the central Rolandic vein, that's a motor mapping. You can see the phase reversal, and the whole thing is the sensory. Sensory deficits are invisible. Only patient can appreciate, not the attenders. So we can be a little bit more generous if it is a sensory, and we can see that the fluorescence can help you where to enter, and we can see that the surgical strategies here. So as I just fast forwarding it for the time, and we can see that. So once you go in at the depth, the problem is when you go towards the motor. So there is the one where your subcortical monitoring and mapping helps, so that you preserve the corticospinal tracts as you see here. So you can go ahead and remove this tumor. The fluorescence helps definitely, and I'll just convert into a regular, and you can see how you will not be able to make much difference in a low-grade gliomas, and you can see some switching out of the regular field. So the difference is actually, so with experience you know that you are not dealing with a regular brain white matter, it is a tumorous white matter, but for beginners this fluorescence can be of great use, so they can just go in. As you go at the depth, there is a one anteriorly is a motor cortex, you keep stimulating your subcortical, because suction is always anyway there. The suction electrodes from Enomed are very, very useful, and you can monitor and map your subcortical fibers like this, and you can, so that gives you extra confidence in removing these tumors. While this motor and sensory can be done with awake or GA, the motor involving the speech area has to be done only by awake, because there is no way, we don't have an ION modality to check this language function, so we are dependent on totally awake procedure for this. This is a typical example why you need to do an fMRI. You can see the MRI, which is a large left frontal glioma, so you don't know where the fMRI Broca's area is, and you can see there are now the motor speech area, and there is a coding also which is slightly above. So it's wide areas. After this IONM, we know that it's not just the inferior frontal gyrus, the motor cortex Broca's area can be anywhere. So when we did the fMRI, you can see that the tumor has pushed the Broca's area completely anteriorly, and there is a good amount of window we can go like this, as you see here. So this is your, I'm not able to see the, yeah. So you can see that the Broca's area shifted anteriorly in conventional to where it should be, and we can see that's a good word. So that is the advantage of doing fMRI in these cases, and you can see this patient underwent a complete awake procedure and continuously monitoring, mapping the Broca's area, and you can see that we could achieve a gross total resection even though it is in the frontal area, because patient awake is constantly talking to us. That extra confidence which is given by the patient to us, can go ahead and remove these lesions. This is another example. This is not in the real Broca's area, but I can just show you that this is the codec area and it is depth. Usually we expect the Broca's area here, but we wanted to do an awake and to a surprise. So this is a small lesion, so we did a small craniotomy. We exposed here. We are not sure where the Broca's area is to go into the tumor. So this is the mapping of the, sorry, the volume is not connected. So I'll just quickly show you. So this is the lesion here, and we were in doubt whether to go through the sulcus or go through the gyrus. And when we did the mapping, we can see when we stimulated here and this area, we got the speech arrest. So we thought that we should not be going through this, so instead we preferred to go transsulcally like this, and the depth of the tumor, we removed it and patient was quiet. So these are the critical nuances which we need to know when we are operating on these awake lesions to avoid deficits. I'm coming to the important other area is the thalamic glioma. The world over, we think that thalamic gliomas are inoperable. We just consult to a biopsy and then send the patient for adjuvant. But are we doing a right practice? But again, more and more now literature is available to suggest that even thalamic gliomas are amenable for a safe surgical resection. And now these are the publications which are coming out, and operative surgical removal is much better than biopsy alone. This is a patient, a 10-year-old boy, biopsied and elsewhere, large pilocytic astrocytoma. He had a left upper limb weakness, 3/5. And he came to us, and we can see that he sent for proton actually, but then we decided in our tumor board that this has to be removed. It's a grade 1. So we went ahead and removed a gross total excision safely. To a surprise, that grade 3 power also improved. So thalamic gliomas is a misnomer that we create more problems. In fact, we can reverse the deficit. And you can see at 1 year of follow-up, he's completely intact, the tumor is gone, he's almost cured of his disease. So we need to help these children, young children with the benign tumors, rather than playing a safe role by avoiding surgeries in this. Again, this young girl referred to us as a GBM of the left thalamus, poor prognosis, the family was devastated. But however, we thought that we should help her. So this is a surgical excision of a thalamic glioma. So we can choose the principles of thalamic glioma, choose the shortest distance away from the tracts and work along the long axis of the tract. So here the long axis is the sylvian fissure. So you do a wide sylvian fissure and you can remove this like an extraaxial tumor. So have a good pseudocapsule. I'll just show you. Can you stop the slides here? So we can see that. So this is a wide sylvian opening. You have to play with the vessel. So once we do that, you are making a deeper glioma into a surface glioma. So once you do ahead, you can see that's the central necrotic portion. So you decompress, something like a meningioma or how we operate. You do internal decompression, then you dissect it all around. The same way you can do these thalamic gliomas because they have a beautiful pseudocapsule. So you go ahead, remove these tumors, debulk it so that the pseudocapsule falls, then it's easy to dissect it from the anterior choroidal perforate at third node. These are typically called the thalamo-peduncular gliomas in children. Frederick Boop has done an extensive study, his paper is there, one can read that. So the fulcrum is the third node. So you follow the third node, it goes into the peduncle. So the same way you just remain above the third node, and that will be a good guide for you to go ahead and remove this tumor. And this is like this tumor is going into the interpeduncular cistern. So something like a skull base, you open the tent, go in and remove, try to remove that potule also. So this is an observation. It is perforatus here, PCOM, anterior choroidal. These are the challenging areas, and this is I see a trifurcation. In fact, MCA was duplicated, and you can see that. So this part of the tumor is looking suspicious, a little bit more higher grade, and that is the third node. So the whole tumor is above the third node, so that is your anatomical guide throughout. You need not have navigation to help us. So this is like the third node. You dissect it all around your pica. So the whole, once you decompress the tumor, the whole anatomy is in front of you. And how to identify the midbrain and brainstem? So I'll just show you in a brief time. So this tumor behaves like an extraaxial tumor. And you see here, so that is the capsule, pseudocapsule which is falling out, that is the midbrain. So you can see that you will be able to nicely tease out the white matter of the brainstem. Nicely you can see as a very good plane there. So this tumors behave like an extraxial tumor. You can see that the midbrain is nicely pushed. You can dissect it out well and then lift the pseudo capsule and go ahead and excise these tumors nicely. So this is the principles of removal of thalamic glioma. One need not be shy away from removing these tumors. You can see the whole tumor could be removed, leaving behind the small nodules adherent to the PCOM and the anterior choroidal arteries. And we can see there is the end of the receptor cavity. So perforators are the only tricky things here. Rest all can be safely protected. And we can see finally at the end, you can see that the whole interpeduncular system, the whole thalamic glioma, it gives us a good corridor to work on. And that is the post-op MRI as you see here. And it was after 3 months, you can see she also had a mild hemiparesis grade 4/5, and again she could improve well. We can reverse neurological deficits if we have a proper surgical plan, and we can see we initially did not give radiation, it was a pilocytic, it was not a GBM. So actually we can see that the whole thing changes once you give a good outcome, and because 15 months follow-up, she's doing really well. So we have to choose our cases properly. Again, multiple other examples I can tell you. This is thalamo-peduncular glioma. This is a youngish girl, 8-year-old. You can see this is a typical thalamo-peduncular glioma you see in pediatric patients. We can see Frederick Boo particles. So you can see the tracks are important. So you again, the long axis is along the ciliary fissure. You go in and remove this tumor. I'll skip the video for time, and we can see that. So this is the post-operative MRI. As you see here, through the transciliary corridor, we will be able to achieve a reasonably good decompression of this tumor, and again a pilocytic, they are reasonable tumors. Higher grade tumors, they come with hemiparesis, again little larger tumors. This is slightly posteriorly placed. So the tractography, so this is the corridor where you can go in, work the shortest distances here, and the long axis, both advantage, you're away from the tracks. So this gives you a good corridor with the navigation. You can choose the sulcus and gyrus where you want to go. With the help of IONM continuous recording, you can achieve a good total, almost a gross total excision, even though it is a deep and high grade gliomas. Multiple other examples as you see here. Again, it is not really thalamic. You can see it's a deep white matter along corona radiata. You can see that the MRI, the tracks alone again are splaying the tumor, and we can go ahead, work along the long axis of the tumor like this, and you can avoid deficits, and you can see that the patient can go. Sometimes you can do awake for thalamic glioma also. Example, this is a 50-year-old anesthetist himself, and he had a left lower limb weakness subtle, and then we realized that this is a deep-seated glioma, high grade, and with the edema. We did the tractography, and the tracks were split by the tumor, some anteriorly and some posteriorly like this. So we can see that. So there are some tracks here and some tracks here. The tumor was saddled in between. So we explained the doctor himself, and so he was willing for an awake procedure because the margin of error can be very less. So that can give us an example, a good approach, and we can see this is the ciliary fissure. So we thought we'll avoid entering the grave. We can use this corridor to go in, and so it's very little white matter to enter. And this is we positioned him laterally, awake, and maybe I should skip this video. This is the sulcus we want posterior part of the ciliary fissure. We went ahead and I don't know whether I'll be able to fast forward it. Not able to fast forward. So fine, I'll skip this video. So this is the perioperative MRI. As you see here, we can see that the gross total excision could be achieved. And again, he had weakness mild. You can see that the immediate post-op, he had still that weakness which slightly worsened. But then at the end of 3 months after his radiation, you can see that completely recovered. So that is the one which we should know, that thalamic gliomas never have the mind that they worsen. They in fact can improve. And 1 year follow-up of a GBM, you can see that the tumor is still preserved well. Optochiasmatic hypothalamic, I don't want to go into the depth. Again, it's part of an enlargement tumor, but it has its own dilemmas whether to go in or not. You can see again, it's just a small clipping of this. This is a hypothalamic glioma. You can see go through translaminar terminalis approach in a young girl. Again, tumor, think like the exophatic brainstem glioma. These type of hypothalamic gliomas are exophatic from the walls of third ventricle instead of a brainstem glioma, which is the fourth ventricle. So behave like that. So you can see that is a A1, and so you have a good wide laminar terminalis. So that is this is the most important step in these tumors. Identify that white line where it is getting attached. Never venture into that. That is where you create injury to the hypothalamus. So the cues are do not push the hypothalamus is not disturbed. So you work in beautifully like this. Keep the plane, and then you can work nicely, and you can do a good complete excision even in these tumors. This you can see the post-operative MRI and the child without any grade deficits. Multiple other examples of hypothalamic glioma. This again a large hypothalamic glioma referred to as for radiation. leaving behind a thin rib. This is an immediate perioperative MRI. We left a thin cuff around the floor of the third ventricle and we could achieve a gross total excision. So hypothalamic gliomas were think like exophatic brainstem glioma at the fourth ventricle, like same thing at third ventricle, and we can do a reasonably good job in them. The last is the brainstem glioma. So brainstem gliomas, again, just want to touch upon it. Ductal gliomas, there are some indications for surgery. If it is increasing, if there is an enhancement, the supracerebellar approach is a good corridor. Not much damage, you can do a complete excision without major issues. Again, multiple other. This is not a tectal, it is a tegmental glioma. As you see here, the whole midbrain was dissected by the tumor, and we can see that we could achieve a gross total excision, and the patient was reasonably intact. This is a patient we thought is an ependymoma. It was a laterally exophatic brainstem glioma. We did it in 2 stages, and we left behind initially. We went to CT angle, and they had a midline nodule. We which went through Midland Sub Hospital and completely excised this. He is now 7 years follow-up, no radiation. It's a pilocytic astrocytoma. A gross total. You can see his MRI disease.
Rupesh, can you conclude?
Yes. So this is the last. So this is the melanoma of the brainstem. It's pons. It's large. Here you can see that the tracks are anterior. So we have a good corridor through fourth ventricle, and we could see, I just skip this video. This is a neovocutaneous melanosis syndrome. You can see even arachnoid has multiple studies of melanoma. Very, very vascular lesion, and this is the postoperative MRI. You can see the tracks help us. The tracks are anterior. So again, he had 5th post-op day, and you can see how his children, they usually improve well, and 2 weeks he started already improving without much issues. So to conclude, literature suggests that the maximal resection can be done with the adjunct of using all these technologies, and there's a good survival advantage even if it is in eloquent region, and the extent of survival is very important. I have mentioned you about the IDH status, so you have to use judiciously your intra-op adjuncts so that you can reasonably give a good outcome in these children. Thank you very much.
Thanks Rupesh for that excellent informative teaching lecture. And a couple of comments. Your message is, in glioma, especially astrocytomas, one should be as radical as possible, especially IDH mutant one, because you can virtually cure that. And you have told that that intraoperative MR, if you have, that is the key. If not, you should keep your MRI suit ready to get immediate post-op MR, and if there is a residual, try to take it out. But my thing is, does it apply to oligo also? Oligo, you have multiple modes of adjuvant treatment which can kill the cells. So is it applied to oligo? If you have a good pathologist who tells, no, it is 100%, it is oligo. If you see a residual lesion in the post-op MR, are you very aggressive?
No, sir. I just showed you the three pictures. One oligodendroglioma, IDH mutant, IDH wild. So IDH wild has a maximum advantage of gross total in a low-grade glioma. Whereas even if it is IDH mutant, there is accept some residue. Whereas IDH wild, if it is a low-grade glioma, we need to be aggressive.
Aggressive, agree. Oligo?
Oligo, not much. Okay. We can leave because it's a good modality.
Your monitoring for left and right side is same, or how do you monitor SMA and frontal ascending tract, which you have shortage of time?
Yes.
SMA, how do you monitor?
SMA, even if the patient, we always prefer to do awake in these children. So even if the patient develops a deficit, so we are sure that he is going to recover after 2 weeks.
Yes. But frontal ascending tract, which connects SMA to speech area, do you monitor that with mapping? No, you don't.
Sir, we don't.
Okay. Any other questions or comments? I think if there are no comments, congratulations again. Thank you for coming over to this beautiful place. And what is that? Oh, okay, again another memento.
I invite Dr. Srihari to present the memento to Dr. Rupesh.
Our third speaker for today is Dr. Sachin Borkar. Trained in neurosurgery at AIIMS, Dr. Sachin is adding to the great legacy of spine surgery at All India Institute, New Delhi. He is now a professor of neurosurgery in the very institution he trained, and he also serves on the editorial board of the NSSA Journal of Spine Surgery.
And Sachin, he is a professor of neurosurgery at the prestigious All India Institute of Medical Sciences at New Delhi. I always, whenever I see him presenting for a meeting, if I am at the chair, I call him not Sachin Borkar, Sachin Tendulkar, of All India Institute of Medical Sciences. Sachin, stage is yours.
Yeah, thank you very much, sir, for the kind introduction, and thank you, the Kairali Neurosciences Society, for the invitation. I'll be talking about minimally invasive spine surgery and how we can migrate from open to MISs gradually. So it is not uncommon for us in OPD when the patient asks us, doctor, can this surgery be done via keyhole, be it a brain surgery or a spine surgery. So it is the buzzword, the keyhole, endoscopic, minimally invasive, and the patients want it. So however we deny, we will have to learn it, because this will be the future gradually. So the objective of this talk is to explain the philosophy behind the minimally invasive spine surgery and to provide an alternate option compared to a traditional open approach, the utility of which is already proven, and to explain some nuances of MISs. So for me, MISs is actually a philosophy. So any surgical procedure done with minimal collateral damage to surrounding structure is MISs. So it can be through tubes, it can be through endoscope. The hardware doesn't matter, the philosophy matters. So even if you do not have the instruments for this, you can even be minimally invasive in an open surgery. So what is meant by that is you can do a unilateral exposure whenever needed, rather than being bilateral. Try to preserve the facet joint, try to do as much bony exposure as is needed. The advantages are there, definitely. There is a smaller incision, less blood loss. It's a simple muscle splitting approach to reach the intended area where you want to work. It causes less post-operative pain, reduce hospital stay and cost, and obviously early return to work. Theoretically, obviously, it has less chances of adjacent segment degeneration, because you are not disturbing the adjacent facets and you are not exposing. By doing monopolar cautery, it is shown that if you unnecessarily fiddle the facet joint, then there is higher chances of degeneration. So this is what advantage. And in institute like us, where there is a long waiting list, this can be done as a daycare or extended daycare procedure. So even the hospital bed occupancy can be decreased. So this is what is true, that you have to embrace the future. The problem is that there is a lot of resistance to move from a conventional approach to a newer approach, but you have to do it whatever this is what is happening with skull base pituitary tumors, that everybody now has to learn endoscopy, and endoscopic pituitary surgery is now the standard of care rather than an open endonasal approach. So what many of us may be doing today is an open approach, a bilateral exposure, and there is some problem. The slides are not. No, it's not. Can you help? So this is what I was telling, the open approach, but MIS philosophy. I did just a unilateral exposure, preserving the muscle on the opposite side, and we are trying to do the decompression. I think there is a glitch. Apologies for the and this is what is being done through the MISs. No, it's not. Okay, we'll move to the next slide. I'll show the videos later on. So, which pathologies can be dealt with tubular minimally invasive surgery are unilateral disc herniation, the standard lumbar disc herniation, unilateral multi-level canal stenosis up to 2 levels can be safely decompressed, and you can do a bilateral decompression by a unilateral approach. Then you can do a transforaminal lumbar interbody fusion by MIS way, and even put screws by percutaneous technique, and then do the discectomy work by a minimally invasive tubular retractor, and even some selected intradural tumors can also be dealt with by tubular MIS. So there are various equipments which can be used for MIS. The tubes are there are fixed static tubes and expandable tubes. Then there are endoscopes. There are various companies which make them. Then you have an articulating arm, a C-arm, which is a must, and microscope for tubular surgery. So why I am more in favor of tubular surgery? Because all of us as neurosurgeons are trained in handling the microscope, and tubular surgery uses the microscope, and rather than an endoscope which give you a 2D vision. That tubular surgery is as close to microscopic surgery as possible. So it's a natural transition from an open to a minimally invasive way using tubes. So that is why I think tube is preferred. Endoscopy, if you wish to do, you can do that. The interlaminar endoscopy is preferred compared to a transforaminal endoscopy, because we are more accustomed to seeing the interlaminar space rather than seeing the root on the disc from the lateral aspect via transforaminal route. So if you are new to the MIS, then I think tubular MIS using microscope is a good way to start. So there are various instruments required for that. The dilators of different gradually increasing diameters, and then the tube. And now there are various good retractors available. This is the Medtronic quadrant system, which opens in both craniocaudal as well as mediolateral direction, and you get enough exposure for 2 levels. You can even fix it. You can do a T-leaf and everything, and it's quite versatile. So these are cases like this. A unilateral disc herniation, big extruded disc are one of the ideal cases to start with. And soft disc herniation obviously are better cases. And this is the setup which we should have. The microscope comes from the surgeon side, the articulating arm comes from the opposite side, as you can see here. The assistant stands here, and the C-arm comes from either above or below. And how the MIS works, I'll just show you a video which will be making it very clear. So this is, why it's not playing? Just apologies for the slight delay. So this is the way it is done. So this is a video. It's not playing the way it should. So the incision is paramedian, and it's a muscle splitting approach. So you reach the lamina facet junction, and by sequential dilatation you are increasing the space, and over these dilators, I'm really sorry for this, I think it's not, yeah, and over this dilator you put the tubes, and you can then use a microscope and do the bone work. This is what you will see, the cranial lamina, laterally the lamina facet junction, and here you drill this off, remove the flavum, and the thecal sac and the root is in picture. So the most important step is docking. You can even change the direction, can go a bit to the opposite side or cranially if you feel that there is a problem. So the next step and the important step is docking of the tubes. So this is a video to show, because this is the most important step. The incision for a simple discectomy is around 1.5 centimeter away from midline, and it is around 2 centimeter incision. Can we do something for this?
Projection, can we do something? Vinu, it is not playing from your computer. No, this is your computer.
Yeah, it's a separate file. These are all separate files. Hey, these are all separate files. Yeah, still it's not laying, it is frequently going. So, yeah, it's doing, yeah. So after the initial incision, you have to divide the fascia and then split the muscle, and the initial dilator goes to the no. Yeah, this is the initial dilator, and I'm palpating the lamina facet junction. Over this, the tubular retractor will be placed, the tubes, the sequential dilatation, and usually 20 mm internal diameter tube and a length depending on the thickness of the patient, maybe 4 centimeter, 5 centimeter or 6 centimeter. There are graduations on this tube, so this dilator, so you can know till what depth is the lamina facet junction. So this is how you reach, and over this put the this is the final dilator, and now we will put the tube and check it with C-arm whether we are at the correct level. So this is the tube. Once you put the tube, you do the bony work. Just remove the soft tissue and start drilling the bone. Unless it plays well, I think you won't get that feel of how it is done. Yeah, so this is the bony work. We are doing gradually eggshelling of the lamina, and the rest step remains the same. You have to identify the traversing nerve root and the shoulder and the axilla, and then do a discectomy. So I'll just run through the PPT, and so this is important. You have to depending on the area we want to target. If you want to do a simple discectomy, you have to be just around 1 centimeter lateral. If you want to do a T-leaf, you have to be at least 4 to 5 centimeter lateral. and for percutaneous screw around 3 centimeter lateral. And these are the steps which we seen, that initial targeting using a needle, then dividing the first dilator insertion and landing it at the lamina facet junction, and checking with C-arm whether you are collinear with the disc space. These are all important things. Otherwise, if you are like this, you will likely hit the body rather than the disc. So this collinear thing is important, and this is what we already discussed. And the internal diameter, you see that how docking is so important. If you are docking on the facet, you may drill a lot of facet and will cause iatrogenic instability. So avoid this. The docking should be perfect. And this is what you will look through the tubes, and this is how it will look on the C-arm. And then you have to work through this tube. It is all muscle splitting, and you can do your job of discectomy. The similar thing can be done for T-leaf. You can remove the bony cuts can be done through this tube. Around 20 to 25 centimeter tubes are enough, and you can even do a discectomy, put a cage and put screws by a percutaneous way. Multi-level canal stenosis, you can do a unilateral laminotomy, bilateral decompression. I have the video, but if we'll try again if it's working. And then select intradural tumors like IDMs can also be approached, some select cases. So what are those select cases? Are posterior or posterolaterally located tumors, preferably neurofibroma, in dorsolumbar spine, spanning 1 or 1.5 vertebral levels, and those who are not ventral and there is not much lateral extension as well. So posterior and posterolateral are good IDM, good cases. We'll show the video, and then sorry, yeah. So this is IDM at D12 L1 level, posteriorly located, and we are doing it through the tubes. Video is always a problem, I think, with this. Okay, I think we skipped the video. So I mean to say, a lot of things can be done through minimal invasive way. And does it mean that everything can be done through MIS, especially all IDMs can be managed by MIS? The answer is no. You should avoid ventrally located tumor. They are not good cases. You can damage the cord. And tumor with much lateral extension with foraminal component also, they are not very good, great cases for minimal invasive. So to conclude, MIS using tubular retractor is another less invasive way of dealing with various spinal pathology in carefully selected patients. Obviously, the good case to start with are simple unilateral disc herniation, and then migrate to multi-level canal decompression, then T-leaf, and lastly the intradural tumors. You should not attempt intramedullary tumors through MIS. It can be dangerous. So not all cases can be dealt with MIS. So, but obviously there is a huge subset which can be helped this way. The advantages are manifold: small incision, patient comfort, rapid return to work with reduced hospital stay and cost. And obviously, as we discussed, it can be a daycare procedure. Patient is absolutely comfortable rather than big exposures, 8 centimeter, 10 centimeters. This is just a 2 centimeter muscle splitting incision and just 2 stitches and patient goes home. Also to remember that it does not replace conventional open surgical approach, but it's another less invasive way of doing this thing. It is the future, I think, and we have to embrace the future. Thank you very much. And my apologies that the videos couldn't run well, but that's it, sir.
Thank you very much, Sachin, and we are extremely sorry for the glitches you had from the projection, and we are sorry, extremely sorry. I am sure many of the people here will be wanting to ask you so many questions, and the stage is open. Ajit, you want to ask something? And many people, yeah, please.
How much amount of disc that you can remove this unilateral approach? Percentage of disc?
We can do the same job as we can do with an open surgical approach. It's
From
not a
both
problem.
sides? You can
No, both sides no. It's you can go to the center till the center. That is why it's good to, you can do opposite side foraminotomy from a unilateral approach, but removing disc from the opposite side is difficult. That is why the bilateral disc, if you feel that it's a central disc with bilateral lateral recess stenosis, it's better to be open but minimally invasive. You can do unilateral exposure, do the bone work on both sides, and can remove from that.
So since you are
but
leaving,
since tubes, with tubes it is only possible, and you should only remove ipsilateral disc.
since you are leaving half of the disc material, there is a chance of recurrence of this case. In your study, what is the rate of recurrence?
There is usually with fragmentectomy and a complete discectomy, there is a lot of debate whether you should do just a fragmentectomy, the loose fragment, or a complete discectomy. The recurrence rates are almost similar. So either you are fusing or you are just removing a fragment, it doesn't make a difference.
Other questions? Ajit? Others who are doing, please.
In the near future, this become outdated, because the endoscope is coming in. All the procedures that can be done through the tube can be done through the endoscope. Because interlaminar procedures, you can do, there is a stenosis scope which you can do the over the top decompression. You can go very well into the opposite side foramen. Even the people are doing TLIF with the endoscope, putting the expandable cage.
That's right.
And another one thing you missed is the important surgery. Other you can do a posterior cervical foraminotomy.
Yeah.
That can
be done.
And another very important is you can put the pedicle screw through the tube without using the C-arm.
Yeah,
identifying the entry. That's a very good technique because you can avoid so many shots.
That's right.
But it's a good presentation. But my take on it is this technique will become as if the open laminectomy become now outdated. This everything will go into the endoscope because the technology, the newer endoscope, 3D, 4K, everything is changing.
I agree with you partially. Microscopic surgery won't become redundant. There are definite advantages of microscopic surgery. The thing is, we are decreasing the from microscope, we are doing the same work through tubes in a minimally invasive way. Endoscope is a different thing. What you are saying is endofusion via transforaminal approach. There are select indication. Again, the cases which we get with chronic calcified disc, they are not suitable for even endoscopy. So there will be role of open surgery, minimally invasive microscopic surgery.
If you think that calcified discs are not you can done with the endoscope, you are mistaken. There are equipments which can take the calcified disc, and there are
But the problem is long-term results are still not known.
Because what we think is
obviously, so you have to learn this.
Ask if channels are asked, can you do this through the scope tube? We are doing almost everything through the tube. We can take the whole disc out.
Yeah.
You can put a cage inside. You can go to the other side. You are taking 3-level laminectomy for lumbar canal. You can reach the 3 levels with a single incision because orienting the tube up and down.
So technology is evolving definitely, and endoscope is also is evolving.
The biggest thing is people will ask for what is the minimally invasive. Now it is coming. You are using a tube. Still, tube has got some pain. Patient has a pain. But when you use the endoscope, pain is very minimal. It comes to the score of 1 or 0. So
I agree.
So from the
So if a young neurosurgeon has to learn tube or endoscope, what should he learn?
I think for him the natural progression is first tubes and then endoscope.
Both they should learn.
Yeah. first. Yeah, that's
that is also a wrong notion. There is no need to do open surgery.
No need. Suppose if
Because in my place, my colleagues they never seen open surgery.
I think we have to stop discussion.
There is no need to convert. There is no need to convert. There is no conversion.
Thomas, I think we have to conclude the session. It's not that, I also won't agree with you. If you want to learn driving, start driving in a Mercedes rather than Ambassador. Okay. So, thank you very much, Sachin, and thank you, Ajit, for the discussion. And stay back for a memento, please. Yeah.
Professor Suresh Nair to hand over the memento to Dr. Sachin.
Well called.
Our fourth speaker is Dr. Harun M. Pillai, a very senior neurosurgeon from Kerala, trained at Sri Chitra Institute, served in multiple hospitals in Kerala. Calicut Neurological Society will include him too, since he was a neurosurgeon at Baby Memorial Hospital in Kozhikode. Apart from being head of neurosurgery at the Medical Trust Kochi, he actively tries to infuse traffic wisdom and common sense into the brains of Malayalis. We welcome you, sir.
And before you start, I have to tell a few lines about Harun Pillai, one of my very close friends in India, Indian neurosurgery. Virtually we talk with each other every day, and he has great humorous sense. He was the second resident from Chitranjanal Institute of Medical Sciences. He passed out in 1988. After that, he worked for some time with Dr. Subbarao, Dr. Sojan, before he went to United Kingdom, where he took his affairs. He has worked there for some time, went to Brunei, and for the last few years he's back in his parent state, Kerala. He is working in Medical Trust Hospital. And stage is yours, Harun M. Pillai.
Thank you, Professor Suresh Nair, for those kind words. I would first of all say thank you to the organizing committee, because I was quite late in putting forth my request to make a presentation. I contacted Dr. Shivakumar. He was kind enough to speak to the organizing committee, and they let me speak. This is a topic which had been very passionate to my heart ever since I had been doing my neurosurgery training. But those days, I didn't have the credentials or the confidence to speak. Now, after 35 years of being in this profession, I think I have some credentials to speak on this a bit controversial topic. I'm sure a lot of people agree, a lot of people will disagree, but that's the whole purpose of the presentation. Now, all progress has occurred only because of those who dared to think different. If somebody had not thought of matchsticks, we would still be rubbing stones. If somebody had not thought of wheels, we would still be pushing logs around. So always progress comes when you dare to think different, and always dare to think different. It may be right, it may be wrong, but dare to think different. Now, these are the giants of neurosurgery. We know that, of course. Harvey Cushing, the father of modern neurosurgery, Professor Jacob Chandy, the father of neurosurgery in India, and in alphabetical order, everybody is equally important. Professor Jacob Abraham, Professor Kalyan Raman, Professor K.V. Mathai, Professor Ramamurthy, Professor Sambashivan, Professor P.N. Tandon, Victor Horsley, Walter Dandy, William McKeown. They're all giants. They were all giants. They were all exceptionally gifted, brave surgeons who ventured into neurosurgery. But there is something more common among them. That is this. They were all general surgeons to begin with. They were all general surgeons practicing general surgery, and they were brave enough to venture into the central nervous system. Now, this is one place where I have to put forth my argument number one. Just because they were general surgeons practicing general surgery, even in neurosurgery, should it mean that we, at this era, should be general surgeons before going to neurosurgery? That's question number one. Let me tell an analogy. About 500 or 600 years ago, Christopher Columbus and his team of sailors set forth from Spain to discover the land of America. He landed in America, explored America. Subsequently, many sailors set forth from Spain and went to America. Now, all these sailors went from Spain to America. Does that mean that today, if we want to go to America, do we have to go to Spain and stay there for 3 years? No need. There are shortcuts, easier, faster routes to go to America. Now, question number 2, does post-MS general surgery offer any advantage in neurosurgical training? What is the quality of the magister of MCH or diplomate of the DNB that you expect as soon as he gets the license to practice? And many more topics which we'll discuss when we get time in the future. Now, advantages claimed to be of benefit by doing 3 years general surgery is that we are confident to open the peritoneum for VP shunt, basic skin suturing techniques, wound infection, antibiotics, etc., etc. Now, do you have to study all these books and spend 3 years of your valuable time just to learn these few things? If you look at general surgery training, when they join for general surgery training, they don't know how to open the peritoneum, how to do skin suturing, but they learn it during 3 years. Orthopedic surgeons learn in 3 years' time. Gynecologists learn in 3 years' time. Why can't a neurosurgeon learn it in 4 or 5 or 6 years' time during his training? Why does he have to do 3 years neurosurgery and read all these books after books and go for exams just to learn these some things which is applicable to neurosurgery? Now let me go briefly through my story. I did direct MCH from Sri Chitra Tirunal, post MBBS. I was the second batch. Obviously, the training process was in evolution at that time. So I have to say that I did not get much hands-on. First 2 years we were not allowed to enter the theater. Only the last 2 years, and we never got to assist major cases. In fact, I have not seen an aneurysm surgery during my training, even though it was the center for aneurysms, because it was the faculty who used to go to assist. And hands-on for most of the basic things I didn't get actually. So I was feeling very inadequate. So after my MCH, I thought I need further training. So I joined Medical Trust under Dr. Subbarao. Then I went to Dr. Svojanai. Then I went to Dr. Late K.M. John in Lisi Hospital. And then I got some hands-on, but still I felt inadequate. I thought maybe because I didn't do general surgery, maybe that's why. Then I went to Saudi Arabia, and lucky for me, the hospital, there was not enough work in the hospital, and there was another neurosurgeon there to help me out also. So I had a lot of free time. So I wanted to cover my deficiency of general surgery by working in general surgery. I went to the general surgery, operation theater, outpatient, ward rounds, assisted surgeries, thyroidectomies, breast, hemorrhoids, fistulae nano, anorectal abscess, varicose veins, sebaceous cyst. I studied Kushcheri, Robb and Smith operative neurosurgery, Schwartz, read Bailey and Love again, and went for my formal FRCS general surgery exam, which is something like MS general surgery exam, and I passed. So now I am a qualified general surgeon. I thought, okay, now let me do neurosurgical training again. Maybe this helps. So I went to UK and joined the residency program again. They took me as third year based on my past experience. It's a 6-year program. So I had to do third year, fourth year, fifth year, and sixth year. And I did FRCS neurosurgery again. Surgery, all the books, all the knowledge is of completely no use for my general surgery training. So I was convinced. So the conclusion I derived is that post-MS neurosurgical training carries no more advantage than post-BSc MBBS in the olden days. Now, what is happening now in India? The other aspect, too much emphasis on theory. I am a very strong proponent of theory. Anatomy, physiology, pathology, pathophysiology, all are absolutely important. You cannot just be a carpenter cutting on the blade without knowing theory. But too much is not good. Less emphasis on hands-on experience in neurosurgical training centers in many parts of India. Most licensed neurosurgeons with MCH or DNB have to work under someone to start learning how to do surgeries safe and effectively. This is unfortunately the situation in many parts of India now. Now look at this. I just got a question paper sample a couple of years ago for a second year direct MCH candidate. He has to pass this exam to continue his MCH program. The questions asked in the exam are Fournier's Grand Grade, counseling of family members of patients with medullary carcinoma thyroid, management of electric burns, management of varicose ulcers,
initial management of sulfuric acid injection, surgical management of fibrosis of the legs, etc., etc. Now, what is it got to do with neurosurgery? These questions are asked theory papers where you have to study and answer to continue your training in neurosurgery. So it doesn't make any sense to me even now. Now, a licensed neurosurgeon must be able to do, this is what I believe, to do most brain and spinal surgeries independently in a safe manner. He may not be the world-class expert. Obviously, nobody can be. You have a learning curve, experience curve. But basically, it's like a driving license. The moment you get a driving license, you are supposed to drive safe, independently, without somebody sitting by your side. That's when you get a driving license. So exactly that should be how you should get a neurosurgical license. Experience and perfection increases as the number of cases he does during his practice, obviously. Further learning must be only for specialized areas such as extended endoscopic approach, vascular bypass grafts, giant complex aneurysms, epilepsy surgery, endovascular techniques, radiosurgery, etc. So my recommendations is that neurosurgical training must be 6 years, whether he is post-MBBS or post-MS. Post-MS should not have any advantage over an MBBS because it's a completely different ballgame. First 4 years should be on general neurosurgery and the next 2 years on general or sub-branches of neurosurgery. At the end of 4 years, he can choose whether he wants to continue general neurosurgery or move on to skull base, vascular, whatever. Thesis during training is optional. I am not a great proponent of thesis because I have done my own thesis which was forced upon me and which is of no benefit to me, and I know even now most theses are done in most centers because it is forced upon them, they have to do it, which doesn't contribute much to the neurosurgical knowledge. Now during the neurosurgical training, this is my recommendation. In the first year, the student must know how to expose the brain and spinal cord at the end of first year. At the end of final year, he must be confident enough to excise convexity and parasagittal meningiomas, excise intrinsic brain tumors, not the complex thalamic and basal ganglia tumors which mentioned, but basically, frontal lobe and all that. Internal decompression of skull base tumors, external endoscopic third ventriculostomy. They should be able to keep simple anticirculation aneurysms, endoscopic pituitary, foot screws from C1 to sacrum and ilium, ACTF and lumbar disc. A person who completes his MCH or DND must be able to do these basic things. Otherwise, the training is inadequate according to me. Now, whenever I present this, some people ask me this question. Okay, if so, do you support neurosurgical training even without
MBBS? You say MS is not needed. How about MBBS? Why you want to study gynecology, ophthalmology and all that? I feel that MBBS is important because you're ultimately dealing with human being. This human being is not just a brain walking into the clinic. It's a human being. He has multiple problems. You should know what his problems are. You may not know how to manage it effectively. You need not know how to extract a fetus in a breech presentation. But you should know there's a breech presentation. You should know there's an ovarian cyst or a thyroid carcinoma. You should know everything. So MBBS level education is very important, no doubt about it. The other question people say is that, okay, in our hospital, we train our residents to be independent neurosurgeons by the time they complete their course. All I have to say is congratulations, proud of you, keep up that work. But my talk is not for them, my talk is for the hundreds of other institutions where such training is lacking. In India, we need neurosurgeons who do neurosurgery than talk neurosurgery because we have 1.3 billion population and around 2,000 neurosurgeons. We need people to do safely, effectively. Now, let me conclude with an analogy. This is like a painting school. At the end of 6 years of painting, you want your students to paint something like this, not something like that. So, in neurosurgery training, at the end of neurosurgical training, when you get your degree and pass out, when you operate on the brain, you expect the doctor to leave the brain looking like this, not looking like that. Now, I know that all truth passes through 3 phases. First, it is ridiculed, so I am sure it will be ridiculed. Second, it is violently opposed. And third, it is accepted as being self-evident. And I am very confident that I am telling the truth, but I leave it open for discussion. Thank you very much.
Thank you very much, Dr. Harun Pillai. I think the best comment should come from Professor Iqbal about this.
I think can have lesser mortals have a say on this
I'm Harun Pula sir. Good job. You have caught the bull by its horns about the training part. We need to have holistic neurosurgeons who know both the theory as well as the practice of neurosurgery. That's what we all aim at. But then, there can always be a different expectation from different people. So as when you are mentoring a student, you really don't know what his capabilities are. Some people learn it very fast, some people take more time. We don't have a program which fits in all sizes of people. That's definitely a problem with them. And I beg to disagree with your take on thesis. Thesis is mandatory because how do you measure the wealth of a society? Is it by the per capita income? Then Saudi Arabia should be the best country to live. It is measured by the intellectual wealth of a nation. Every resident who comes up with a thesis and publishes it adds to the intellectual wealth of that society. And the only way we can make ourselves relevant is to put our experience on paper through efforts such as dissertation, so that the future can always relate to our experience and learn from it. Thank you very much.
Professor Iqbal sir.
In fact, the whole medical science and surgery especially is changing very fast. So I will be talking about that tomorrow. So taking that into consideration, the whole training program, even medical training program will have to change. But I want to make an aside comment that actually Columbus did not go to America at all. He went to Hispaniola in the Caribbean island, which is now two countries. One is Haiti and Dominican Republic. And he thought that he discovered America. He never went to either the North or South America at all. So I will be talking about some of these details tomorrow. Not about training per se, but the way we are changing very fast.
Thank you, sir. Arun, I want to agree to disagree with many of the things you told. One, absolutely what Ishwar told. Thesis is something very important. I don't know, many of the institutes, at least at Chitra, it is, it is put in the website as one of that students' signature of his stay in that institute. It's absolute must. The few things I will put. It's a post-MS. I did like you, direct MCS. Doesn't mean post-MS should be ridiculed. Say you have that, maturity. And when you come after a post-MS, definitely it is there. But something, post-MS students, if they join for neurosurgery, they already have MS. So after the end of 6 months, they decide, is it a good branch or a bad branch? They always, it is not good for me, I will go to some other branch. That option is there for a post-MS fellow. He may not like, not all students who join for neurosurgery should like it. It usually is not there for a post-MBBS fellow. That fellow, he has to gulp that thing. He stays there, even though he doesn't like that locality. He is virtually bound to stay there and complete the post, which may not happen for a post-MS. He says, no, he will do some other branch. I have seen many people in Chitra dropping out after joining for post-MS neurosurgery. And other thing, always the maturity and those things. Let me ask you one question. Why MBBS you have to study for neurosurgery? Let him study Ayurveda. What is your response for that? Vijayani or Siddha? After that, let them study.
I think I presented in my slide, same question. People may ask why MBBS. I think MBBS is important because you are dealing with a person and you should know everything that is happening to him. He may have an ejection fraction of 20%. What do you understand an ejection fraction 20%? He may have an atrial fibrillation. The lady may be pregnant with a breech presentation. You can't go on checking Google every time. So MBBS is definitely important. There's no doubt about it.
Let me ask you, I will stop with one example. Say you require neurosurgery for MS. I am not a surgeon. I will tell an example at Chitradurga Institute while I was heading neurosurgery department. So we used to have consultants from medical college. Chitradurga Institute doesn't have a general surgery department there. So we used to call general surgeons from medical college, professors there that the consultants. It so happened that director, one consultation, the subjects used to come from medical college, they used to give peanuts of 100 rupees as consultation fee. It was so ridiculous. The professor that time in general surgery at medical college don't insult us by paying 100 rupees consultation. We will come and do it free. That is absolutely correct. That director, he took it on the thing, he said, no more consultation from medical college. And he made the RCC general surgery, somebody was there as the consultant. And I was heading neurosurgery there. One patient had an acute problem, bleeding for vagina after something like that. The patient was collapsing. And this general surgery consultant who was appointed by the director from RCC, he came and told, I don't know anything about this. You have to send to a proper general surgery. I think it will never happen if we have a general surgery backup training students there. It so happened Gopal, one of our residents, that point of time helped us by saving that patient.
Hang on. When I was there, when we were there, when we called general surgeons, the neurosurgeons were there, all post-members, Professor Rao, Professor Bhattacharya, Professor B.K. Misra, Rothaki, they were all post-members. Why couldn't they do it?
Medical legal issues. Understand? Medical legal issues are there. But my take is, you should not ridicule MS training, and it should be always another big degree which they struggle to get. And people can come join for the course and decide whether they like it or not. That have you looked at people who have, how many people are doing after 5 years post MCS very bad?
Hello, just a couple of comments. One thing about discontinuing the course, if you are joining for 5 years, 6 years, see the solution for it is what is being followed in CMC also. Because we always do 1 year non-postgraduate training. So during that non-postgraduate registrarship, you decide whether you want to do it or not. That is one way of doing it. You don't need to do be an MS or something like that. So if you do 1 year non-PG training, you are not committed. You are not joined in any course. That is one thing. Number two, regarding the wisdom. Wisdom doesn't necessarily come with age or this thing. For many people, what age brings is a lot of gas.
And Paritosh, and then after that,
India is one of the only countries where we have this post-chemistry. Everywhere in the world we have direct 6 year, US, Japan, UK, everywhere it is 6 years. I don't think practicing in India. Okay.
I think it's not a very revolutionary idea also. It's been proven all over the world that
change is always resisted upon. Change is ridiculed first, then opposed, then accepted. Now, one thing I have to do.
Okay, let's further.
Aaron was asking why MS. Myself and Aaron did neurosurgery. At the same time, I was in medical college. He was in Chitra. When he came out, they were not exposed to head injuries. While I started neurosurgery, there were only 3 neurosurgeons in Kerala. One in Trivandrum, Professor Sambashivan, Professor C.A. Rajan in Kottayam, and Professor K.M. John sir in Calicut. Initially. No, I was more aware of the government service. And both Calicut and Kottayam, there were no neurosurgeons while I was an MBBS student. There was only one board of Dr. C.A. Rajan. He was deputed to Iran. And why general surgery means only general surgeons used to start doing this. There was only one neurosurgeon, Professor Sambashivan and Srikumar sir in Cochin. So when I was a student, there will be a board in the surgeon's previous day's list, surgical list. Always we see burhole. All these were done by, all head injuries were being managed by general surgeons only. They take duty and operate. That is why MS was important. And we all did MS. And when we do MS, the surgery people, if I was a tutor in neurosurgery, they will fail every neurosurgery people. All neurosurgery, they don't want to do MS. So they used to fail us. Thus, he came out of that. And now I hope there are more than 200 neurosurgeons in Kerala. This has changed. While I was working 35 years back, when I started as a neurosurgeon in Calicut, we used to do all those sorts of cases. And there was another controversy, Kerala government.
Madam, running short of time.
Kerala government, Professor Marthanda Pillai, sir came with MS neurosurgery, but he was not given promotion.
Okay.
Yeah, because, no, that was a must. MS was a must. In the state, that is why everybody used to
one
do MS.
so sorry, with the permission of Chairman.
But in UK also, you have to do basic
Thank you very much, Dr. Harun and Dr. Pushkala. Let's go on to the memento presentation ceremony.
I request Dr. Shivkumar sir to please present a memento. Our final speaker for this session is Dr. Jayanand Sudhir.
And I will introduce him. Jayanand Sudhir is one of the brightest surgeons, technically one of the best surgeons in the country. And he was my resident. He is additional professor at Sri Chitra Tirunal Institute of Medical Sciences and Technology. In fact, he was my right hand while I was doing all acoustic surgeries. He used to open all the cases for me. He is a superb surgical hand in neurosurgery and stage is towards vascular surgical techniques in the vicinity of skull base. Jayanand Sudhir.
Thank you very much, sir. Very good afternoon to all the chairpersons and teachers of the dais and on the dais and my junior colleagues. The organizers should definitely be congratulated for this beautiful venue, and I also thank the organizers for having invited me to present my work. I was a little worried about the topic because it didn't touch skull base or vascular. The topic was given to me was very odd, vascular surgical techniques in the vicinity of the skull base. So I was wondering whether to talk on vascular or skull base, but I thought I will take it forward with vascular. So this is the schema from which I will be starting. This is the schematic diagram of the vasculature of the extracranial circulation as well as the intracranial circulation. So we have the skull base, the intracranial compartment above and the cervical compartment below. So this will be the schema for all the descriptions further. So I'll start with vascular techniques for lesions below the skull base. We encountered a couple of cases of cervical pseudoaneurysms. This was a young boy, a 12th standard student who came to us with severe dysphagia and a swelling in the throat, and he was diagnosed to have a pseudoaneurysm of the cervical ICA. You can see the flow. Can I have a pointer, please? Pointer, please. This one. So you can see the pseudoaneurysm, the filling component here, and the rest of the component is partially thrombosed. There's a huge mass in the pharynx, both the nasopharynx and the oropharynx. So this patient had severe dysphagia and he was due for his board exams too. So this is the schema is showing the cervical ICA is a partially thrombosed pseudoaneurysm. What we planned to do was a double barrel STMCA bypass because the cross circulation was reasonably good, and we also did went in for a trapping of the ICA. This was the intraoperative picture. We have the intradural exposure of the clinoid process, the internal carotid artery, the left optic nerve, and we drilled the clinoid, and you can see the cavity of the clinoidectomy here. The distal dual ring has been cut here, and further exposure you can see the origin of the ophthalmic artery taking off here below the optic nerve, and we managed to clip the internal carotid artery just below, proximal to the origin of the ophthalmic artery here. And the circulation was taken care of by a single STMCA bypass. We didn't have the frontal branch, so only the parietal branch was used in this case, and it was reasonably good caliber, so we did it with single barrel anastomosis. The neck was exposed for ICA ligation as well as decompression of the thrombus, and the patient did well. This is the STMCA bypass functioning, and the aneurysm has disappeared from circulation. Patient did well and did his board exams too. This was another cervical ICA pseudoaneurysm, and this patient had failed 4 attempts at flow diverter replacement, and in this case we went in for a double barrel STMCA bypass, and you can see both the conduits functioning well, and the ICA has disappeared from the circulation. The ICA was ligated in the neck, and the patient was cured for his aneurysm. And this was an elderly gentleman with uncontrolled diabetes. He had skull base osteomyelitis, and this osteomyelitis resulted in a pseudoaneurysm that extended from the petrous to the laceral segment of the ICA.
And we did a double barrel STMC bypass. Both the frontal and parietal branches have been introduced into the circulation. And we curiously did a perfusion study after the bypass, and we found that there is a deficit of perfusion in the parietal region, but still the patient was quite asymptomatic for that. So coming to lesions at the skull base, we had the fortune to do one skull base tumor for which we did a STMC bypass. You can see this as a lesion arising from the skull base. We thought it was a meningioma, and the entire ICA, the ICA bifurcation, perforators all were inside the lesion. And you can see the cavernous ICA here, and the distal circulation, all the vessels are inside the tumor, and the ICA, the ACA is narrowed. You can see the stretching of the supraclinical ICA segment. The cross circulation was not supportive here, and so we did a double barrel STMC bypass, one to the frontal side and one to the temporal side, and then went on for a tumor decompression. This turned out to be an invasive pituitary adenoma. Now we had another interesting case of a cavernous fistula. This was a cavernous IC aneurysm which had ruptured into the cavernous sinus. This patient was from Africa, from Sierra Leone, had contacted multiple centers for treatment, but they were not willing to take the risk of endovascularly ligating, occluding the internal carotid artery for want of that small risk of stroke that could occur. And so we did, this patient interestingly presented with paraplegia because of the severe edema and the T2 white matter changes you can see in the medulla and the spinal cord because of the venous reflex. We did an STMC bypass and ligated the ICA, but still didn't go well with that. We then had to open up cranially and occlude the ICA distally also to treat the aneurysm. You can see the thrombosed fistula here. This patient is on the way to recovery. Now, cavernous IC aneurysms we have been able to treat with multiple strategies. This is the usual protocol. There have been reports where you can just ligate the common carotid artery if the cross circulation is reasonable. The retrograde circulation from the external carotid artery will take care of the circulation, whereas the flow through the aneurysm will reduce down. You can also go in for a proximal ligation of the internal carotid artery if the cross circulation is reasonably very good, so that the cross circulation is adequate to support the other side. But in cases where cross circulation is insufficient, we may go in for strategies like double barrel STMC bypass, which in this case we have done for this cavernous IC aneurysm, or we can go in for a high flow bypass using a radial artery graft right from the external carotid artery into the MCA and then ligating the internal carotid artery. The distal ligation is optional. You can see the reconstructed CT angio showing the high flow bypass, and the IC aneurysm have been taken care of. This is another huge cavernous IC aneurysm. And in this case, what we planned was an internal maxillary artery to the middle cerebral artery anastomosis. We exposed the internal maxillary artery in the infratemporal fossa, and this was the first time we did this procedure. And we actually didn't get the main trunk. We actually anastomosed it to a branch of the internal maxillary artery, but it did well, and the patient was cured of this illness. And this was a giant ophthalmic segment aneurysm straddling the skull base. In this case, we used multiple strategies. We used a double barrel bypass, which worked as an insurance for the prolonged temporary clipping that was anticipated. This is the aneurysm exposed, and we had to do anterior clinoidectomy, and proximal neck control was also used, and suction decompression method. And large clips and multiple clips were used to finally occlude the aneurysm in toto, and the patient recovered very well. For lesions above the skull base in the vicinity, this is a large ICA bifurcation aneurysm. You can see that the flow component is minimal, whereas the large thrombosed aneurysm is actually extending beyond the posterior clinoid process, almost protruding into the posterior fossa, posterior cranial fossa. So in this case, if you were to go for a direct clipping, you would take proximal control and distal control and try to decompress the aneurysm. But when you decompress the aneurysm, since it is partially thrombosed, there is a huge risk that the perforators can be avulsed or get torn off or may get occluded with the clipping. So in order to overcome that, what we did was, this was the partially filling aneurysm. You can see only the flow component is seen in this angiogram. The thrombosed component is not visualized. So what we did was a double barrel STMC bypass and then a proximal ligation of the ICA. You can see the aneurysm having been, it has just gone down in its size. The patient is quite asymptomatic. Since it is partially thrombosed, we feel that the rupture potential has come down. Now this was another giant aneurysm of the ICA terminus, and the ICA terminus, because there is no ACA coming from there, the ICA is continuing straight into the MCA. You can see this is the distal end of the aneurysm, and you can see the MCA coming up like this. So in this case, again, the same thoughts came up. There is the possibility of damaging the perforators, and there is no support from the other side. So what we did was an internal maxillary artery to MC a bypass. This is the exposure of the skull base, and on the top right panel you can see the radial artery being harvested. Here we have also used image guidance to see the extent of drilling that is required. You can see the internal maxillary artery having been delineated in the infratemporal fossa between the pterygoid muscles, so that the skull base is drilled between the foramen rotundum and ovale. So this IMAX or internal maxillary artery usually is seen around 1 to 1.5 centimeters running parallel to the line joining between the foramen rotundum and the foramen ovale. So the skull base is drilled adequately to expose the infratemporal fossa, and we then go on to dissect the fat in the infratemporal fossa. The fat is all removed. While there we are going, we are exposing the radial artery from distal to proximal. The radial artery has been identified, and in infratemporal fossa you can see the fat being dissected off. Now, despite using image guidance, we had encountered a lot of difficulty in isolating the artery because it is between the muscle planes. We can get an idea about how much the skull base has been drilled, but even though the pointer does point to the location of the internal maxillary artery, it is very difficult to identify the artery because between the muscle planes. So here we are ligating the branches of the internal maxillary artery using liga clips, and there is the artery that has been isolated here and dissected free of the surrounding tissues. So you pass a loop around it so that the vessel is isolated, and then the perivascular tissues are dissected off. Now between the temporary clips, the internal maxillary artery is cut to a stump. And the vessel perivascular tissue is again cleared off here. You can see the lumen clearly. An elderly patient, so you can see the intima having just dissected off. So we have to be careful while taking sutures, because if you miss the intima there, while you take the suture, it can be a dissecting flap. You can see the intima separate there. While there, we are exposing the radial artery. Around 10 centimeters of radial artery is harvested there and is pressure insufflated with heparin saline. Now here we are taking the sutures from the stump of the internal maxillary artery. We have the free graft of the radial artery in place. Now since we are working at a depth, I take multiple sutures around and then try to parachute the radial artery into the depth so that the sutures need not be placed at a depth in the graft. So here is the middle cerebral artery. So the sutures having been passed there are again passed here to keep track of which suture is passed where, so that the orientation of vessel is not lost, and then the vessel is brought down to the depth and sutured. So 10 no sutures are being placed here. This is end-to-end anastomosis. So we follow the 180-degree rule, that is one suture on this end, 180-degree opposite the other suture, and then divide it into quadrants and suture. So all the time we flush the lumen with heparin saline and see that the sutures pick the intima during, especially in the internal maxillary artery where we saw the dissecting intima there. That's irrigating with heparin saline so that thrombus doesn't form there. This clip is placed to hold the suture in place, so that if you want to turn the vessel around, you just hold by the clip and turn it around, flip it around, so that you can work on the other side. Since the MCA, the radial artery graft is free, you can turn it around easily. So these are the sutures being placed on the other side of the vessel. Now this is the end of the radial artery graft, where we do a fish mounting technique to widen the lumen. And then we run the sutures, the toe and the heel stitches are in place before we take the vessel down into the site of anastomosis. So there is the recipient middle cerebral artery. So there we place the temporary clips. You can see the aneurysm and the vessel emanating from the aneurysm there. The vessel is all having atherosclerotic plaques there. So this is the vessel being marked, and the arteriotomy will be done here. I don't excise a part of the vessel, just make a slit on it. So we already passed the toe and the heel sutures, so we use those to anchor the vessel in place before we play around with the side sutures. So once the toe and the heel are placed, you can see there is no looping of the suture or anything there, so that the sutures are in place and taut. This was worked with 80 proline because the vessel was much thicker, so even the recipient and the donor vessel were almost the same caliber, and the vessel was quite thick enough, so we could use 80 proline here. Note that we don't deal with the aneurysm at all. We are just passively dealing with the aneurysm by doing an anastomosis here and then doing an ICL ligation. So what happens is the flow is reversed into the aneurysm. What was a very hyperdynamic circulation running into the internal carotid artery is now replaced by a totally different reversal of direction of flow from the internal maxillary artery into the ICA. So this preserves the flow into the perforators as well. So these are the placement of the sutures on the sides of the anastomosis. So these are, we start from the toe end and then reach the proximal heel end. So here is the heel suture already in place here. There is no systemic heparin used during this procedure, only local heparin, only for irrigation. It's the way we handle the vessels with not much damage to the intima, and always irrigating the lumen with heparin saline so that preserves the intima as well as dissolves any microthrombi that have been formed there. Yes, yes. It's almost done, sir. This is the final stages of the video. This is the other side sutures being placed. And now we have just removed the clips off the proximal internal maxillary artery stump there, and there is some leak there at the anastomotic site, but that will usually settle with irrigation. And the next clip also being released, you can see the flow being established into the circulation, into the cranial circulation there. So you can see the pulsations of the vessel here. The clip that is placed on the MCA between the anastomosis and the aneurysm is still retained in place while the distal one is released. So flow is going into this, into the distal circulation, and finally the last clip to be removed is the proximal clip on the MCA. So flow is now from here to into the ICA, and then we ligate the ICA. So nothing done with the aneurysm, just reverse the flow into the aneurysm. And this is the result: the internal maxillary artery, radial artery graft in place and flowing into the middle cerebral artery. The distal circulation is well served, and the aneurysm, the giant aneurysm, has been shrunken down to a very small aneurysm, thus reducing the risk. The flow into the aneurysm is now obliterated in the sense that it has become thrombosed. So all perforators are all preserved. There is no tampering with the aneurysm or any circulation around that. You can also see that despite the ligation of the internal carotid artery in the neck, the flow has filled the entire ICA. So what has occurred is a total flow reversal. That's it. This is the team that we are working with, and thank you very much.
Thanks, Jayanand, for that technically super lecture. Really, just before I pass on to Paritosh for his comments, because he is a great vascular graft surgeon. So your first case you showed pseudoaneurysm. If that patient has very good cross circulation, pseudoaneurysm, you could have trapped it. No, why you went for a bypass? If patient has withstood hypotensive challenge, very good cross circulation, was there any need for? You showed very good cross circulation.
The cross circulation was not so good. It was
No, you showed very good cross circulation. The first case.
The first case. The boy with the.
Yeah, the first case. And second thing, you showed you thought it was a large meningioma with the vessel inside. Ultimately turned out to be pituitary, and obviously there was no good cross circulation. But you could have exposed everything, kept ready for bypass in the event you damage it during.
This was done in two-stage procedure. So we planned for the vascular bypass first, and then
what was it required? My thing is, ultimately what happened to the tumor? You could remove totally, or
no,
it is a pituitary.
since the frozen came out as
pituitary,
we did only a subtotal decompression.
So was it required then graft? That is what in the
anticipating safety.
Anticipating. Okay, Paritosh, please. Girish, Paritosh. Yeah.
Absolutely great surgeries.
Thank you.
It's fine, especially the final one. Would you, if the aneurysm still remains in the post-operative angiogram, in the last case, there was some bleb, would you consider doing a proximal or distal ligation of these things so that it doesn't fill?
Distal ligation, you saw the status of the vessels. It was all atherosclerotic.
Because the MC is already filling and the ICA will be filled by great
I think
things.
it would still damage the perforators behind the ICA aneurysm if we go and damage it further.
It's just a surgical tragedy that all of this many of these will be replaced by endovascular techniques and flow diverters and stuff like that. But till we are alive, probably India is not going to be that rich a country that everybody affords that.
Sorry to interrupt, but most of these cases have been referred to us by endovascular people who have not been able to offer a solution.
Yeah, of course. I mean, not saying that. I'm saying the technology is improving so fast that there are more and more things that are coming up, and things which we did not do 2 years back are being done. But that being said, of course, every surgery will always have its role, and it's great, absolutely fantastic.
Girish, for your comments.
Exquisite, Jayanand, always. A couple of doubts, out of ignorance. Generally, when we do a high flow, earlier we used to do the the cranial anastomosis first, and then we go to the neck. But in this, I saw you do here and then go back. I never knew the reason why we do that. I always felt, why don't we do the cervical and then do the cranial? But here, you understood my question. Usually we used to do, when we do a high flow, when we take a saphenous, we used to do saphenous there. We put the cranial M2 anastomosis first, and then we do it here. I never knew the logic. That is how it was. So Dr. Suzuki taught us, we did that. And I always felt, why don't we do it the other way around? Because I felt the doubt, because my cardiac surgeon who is in the next OT, he comes sometimes, and he was asking, why don't you do it? The second was, one thing which I learned from him was the M2, because the vessel is bigger. He said, why do you want to do interrupted? Why don't you do continuous sutures there? So, because we don't do continuous because apparently to continuous the chances of stenosing the vessels are higher. But he says coronary they do that, and the last 1 or 2 cases I tried continuous in the M2. STMC it is difficult. So this was, why did you do the other way? Is there any logic, or is it?
I think as you said, for the high flow bypass, we always tunnel it deep to the mandible. So that gives us the minimum length for connection between the MCA and the ECA. So when we tunnel it, maybe from above to below is probably easier than from below to above, pushing it from below. So, and the other thing is we are more comfortable.
Conventionally we do the cranial first and then the cervical. So was there any reason?
We have more play in the cranial when we do the.
So that
that is also right.
And this one we can stretch it.
Okay, probably. But here I saw you did the internal maxillary first and then went cranial. So
and
that's
the other thing about tunneling is that we are not sure whether it is twisted or kinked or anything under the mandible. We have no vision there. But this internal maxillary to MCA, we have everything to in vision. So we know whether it is kinking or anything is happening.
Thank you, Jayanand, for that excellent
Thank you
talk.
very much.
I think we have to wind up, and we had 5 excellent lectures today afternoon, morning. 4 technically super lectures, and of course Arun's was not a technical lecture, more of his thoughts on training. And thank you all the presenters. Oh, memento. One memento.
Jayanand, please come. Jayanand, please come back on stage for the mementos. Dr. Srihari presenting the memento to Dr. Jayanand Sudhir. Thank you very much.
Thank you. Once again, thank you to all our chairpersons. With this, we come to the end of our second session. We will now be taking a break and commencing post-lunch at 2:15 p.m. A couple more announcements. The general body will be at 4:30 p.m. There's a venue change. It will be at Oriental Hall, that is Hall A, post which at 5:30 in the same hall we will have an inauguration. Thank you. Our first speaker is Dr. Ajit, one of the most accomplished and admired neurosurgeons of the state. He has pushed and helped and inspired many or most of the younger guys to pursue excellence. He has helped change the practice of spine surgery in our state, greatly interested in vascular neurosurgery, and now with his colleagues at KIMS Health is redefining endoscopic skull-based surgery.
Thank you for the nice words. First, I must thank my dear friends Rajiv, Shivakumar, and Alapar sir for inviting me to this nice meeting. We are going to a newer, it is not a new field. Already the technology is maturing, but there are a lot of glitches, and we don't know whether this technology is right or wrong. It's a time only say what is good. But these approaches are gaining momentum time by time because of the straightforwardness in this techniques. So we are all know why endoscopy, because these two pictures, you can see these two pictures here. This is a cella, this is a LOCR, this is a MOCR, that is a optocarotid recess, and in between you can see the carotid. This picture you can never get from a microscopic view. The illumination, the clarity, and so many other things prompted us to do this endoscopy more than other difficult skull-based approaches what my dear friend Ishwar has shown in the morning. Because these are other techniques, we are looking from the skull base, other thing we are opening the skull and looking into that. So both are complementary in the sense that I will come to that later. And this is the basic anatomy everybody should know, because this is a cellular floor. You can see the carotid prominences here.
you can see the paraclavial carotid here. This is the tuberculum sellae. This is the optic impression. And you can see the LOCR and MOCR here. So when you advance the endoscope and when you look more, this become more clear, unlike in a microscope. When you zoom more, the clarity will be likely to lost in a microscope because the illumination is from something 400 200 millimeter. So pituitary gland is seen very well. Paraclavial ICA is seen very well. This is the paraclavial carotid, and this is the foramen lacerum, which is a key point in understanding the skull base. Then you again zoom, you come to the VDNR where it enters the horizontal part of the internal carotid artery. And you see, this is a very beautiful picture. If you can remove all the bone, this is the picture you see in the skull base. It's not a practical thing. You can see the sella very well. Yeah, you can see the pituitary stalk here, basilar artery, cavernous carotid, paraclavial carotid, lacerum, everything you can very well. It's a direct approach, unlike our Kawase or drilling are the triangles. Now come to the techniques. These are known to endoscopic skull base surgeons. It's a definitely bimanual dissection. 4 hands will be in the field. And gone are the days of uninostril technique. We always go for a binostril. And the reconstructive flaps like a Haddad Desagate flap made our life easier. Then we will make a working space doing the maxillary androstomy, drilling the bone, making the space for the endoscope to work. How it is improved endoscopic endovascular approaches from sagittal to coronal plane. You see, when we started with a single chip camera. Now there is 4K and 3D, which have improved our visualization. And one of the major drawbacks of the endoscopy is two-dimensional view, which is gradually being rectified by the 3D approaches, customized instruments. Definitely, so many people like Cairo, these people are making a customized instruments. Newer hemostatic agents like Surgiflow. Without the flow seal or Surgiflow, we cannot enter the cavernous sinus. That is these newer techniques, these techniques of revascularization. Other than the Haddad flap, there is a pericranial flap, temporal flap, so many free flaps are there. The 3 pillars of safety are the navigation, Doppler and IOM, and not the least, the most important thing is intervention neurology backup. That is the essential thing when you make a hole in the carotid. That is what I am telling, the multidisciplinary approach, neurosurgeon, ENT surgeon, skull base surgeon, neuroanesthetist, neurointerventionalist, then our sisters who are neuro-nurses, technicians. It is only a teamwork. It is not a single man's the whole credit goes to a single person. It is a teamwork. And the modular nature of approaches also make these things easy. That is the coronal plane, sagittal plane, transplant and transcript from these approaches. And this is some advice for my junior colleagues. That is what happened in ENT surgery is the ENT surgeon is very familiar with the endoscope because they do a lot of functional endoscopic surgery. Their experience is translated into skull base surgery, which is very essential thing when you do a skull base surgery. The same thing we can acquire by doing a lot of spine endoscopy, because the experience you gain with endoscopy in a spine can very easily translated into when you do a skull base surgery. The first level is the sinus surgery, which is at the highest level you go for a coronal plane and clipping the aneurysm, which is something you don't think it is very feasible right now, but I have seen so many videos. These people garner clipping the basilar aneurysm through the endoscope. It's a famous dialogue: in the world deluged with tons of information, clarity is the power. I don't know whether it takes how many years to achieve the clarity, but in the pursuit of clarity, we should always go behind the clarity. That will take 5 years, 10 years, lot of cadaveric workshop. Only after that you can have a thorough knowledge of the skull base. It's a different area, different terrain. And these 4 things, that is understanding the skull base carotid, very important. The skull base carotid and its from the horizontal part into the clinoid and the supraclinoid part is very important. Anatomy of the pterygopalatine fossa, both in the 2-dimension and also in the 3-dimension. Unlocking the abducens nerve, understanding the pterygoid fossa, sphenoid bone, and unlocking the abducens. And the most important is the foramen lacerum, which is a crossroad where there is a confluence of sphenoid bone, clival bone, and petrous bone. And about the carotid, there are certain landmarks. These are all the many slides I have taken from the talks of Garner, Caro, and other people. And this is the paraclinoid, the medial OCR is the important area. For the anterior genu and foramen lacerum is the medial pterygoid verge. For a horizontal segment, the median nerve, which is one of the very important structure, you have to be familiar. Eustachian tube is the landmark for the ascending parapharyngeal part of the carotid. You see, in this picture, I will say what is the deficiency with the endoscope. You can see this is the ascending part, and you can see this is the horizontal part. Then this is the laceral and paraclival part. Then it goes as a posterior vertical, and then it comes anterior horizontal. Then it comes anterior genu. So when you look at the endoscope, this anterior genu you see in the same plane, but actually it is almost 2 centimeters in front of the posterior vertical. Like this, there are a lot of glitches that you have to overcome before you understanding the anatomy. And this is something called transcavernous approach, and this is called by the famous endoscopic surgeons are the madness methods to madness, because area which once thought never to be conquered is now we are doing surgery in the cavernous, and it's very easily and with a very dexterity. And the most important steps is understanding the dural layers, 2 dural layers of the pituitary, then understanding the paracellular ligaments. And the most important thing is the medial cavernous wall dissection. And another thing, if one who is going to do a cavernous approach or upper clival approach, he should be very familiar with the transcavernous posterior clinoidectomy, which is the equivalent to Dolan's approach in approaching the basilar apex aneurysm and its relation to the foramen lacerum. And this is a classification, and this classification is based on the position of the carotid. This is a horizontal segment, and depending on horizontal area, venous space superior to the horizontal segment is the superior compartment. Area posterior to the horizontal short vertical is the posterior compartment. That is inferior is the inferior compartment, and lateral is the lateral compartment. This is a new anatomy in comparison with the other 12 triangle anatomy of the inside cavernous sinus. And we have the Knopf's classification, but for a neurosurgeon this classification is more important because the structures grow in line with these superior, inferior and posterior triangle. Now come to what are the structures in this compartment. In the superior compartment you can see the anterior clinoid triangle and the clinoidal ICA. Then the interclinoidal ligament. Interclinoidal ligament is a connection between the posterior clinoid and anterior clinoid, and the posterior oculomotor triangle, which is the confluence of the oculomotor triangle into which the interdural part of the third nerve enters. And we are also familiar where exactly is the tumor, because this is the inferior compartment and this is the superior compartment. And like that in the sagittal plane, this is the inferior compartment and this is the superior compartment. So when you come to the posterior compartment, the main is the interdural portion of the abducent nerve, which after the cistern segment enters the posterior compartment as an interdural compartment, and you have to you know the relationship of the carotid artery in the posterior triangle. In the inferior compartment, there is a short vertical ICU, sympathetic nerve, sixth nerve, and distal cavernous segments. And then the lateral compartment, there are a lot of nerves there. That is the inferior lateral arterial trunk, carotid oculomotor membrane, or otherwise called the proximal dural ring, and the third, fourth, and V1 nerves that going into the superior orbital fissure. So next thing is the medial cavernous wall. Is a very important because dissection of the medial cavernous wall cutting the ligaments, identifying the inferior hypophyseal artery, medializing the pituitary. These are all important in many steps. One for entering the cavernous sinus, another for doing upper clival approach. Another thing, the inferior hypophyseal artery, when you if it tears from the base of the carotid, it can cause a troublesome oozing. So early identification of the inferior hypophyseal artery, these are all important in when you do a medial cavernous wall resection. And this is a cavernous artery surgery. You can see here is the carotid artery, and these are all the paracellular ligaments. And you see, this is a case where there is a inferior extension, and also in the MRI you can see an inferior extension there. This tumor can be totally removed with this approach, transcavernous approach. And another area we are very familiar is a transpterygoid approach. Pterygoid fossa is a cavity that is between the posterior, superior and medial wall of the posterior maxillary wall. So entering it, you have to first do a maxillary androstomy, then identifying the sphenopalatine artery and removal of the posterior wall of the maxillary sinus, and then transection of the sphenopalatine vessel, identification of VDN. VDN nerve is the key nerve identification in a transpterygoid approach, extended sphenotomy and drilling the pterygoid base to expose the laceral segment and the horizontal segment, and through the approach you can reach up to the jugular fossa. And this is a very important anatomy. You see, this is a sphenoid sinus. You can see the medial pterygoid plate here. This is a lateral pterygoid plate, and this forms the boundary of the choana. And here you can see the VDN canal, and this is the foramen rotundum. For any transpterygoid approach, this knowledge of this anatomy is the essential thing. And the next is understanding the palatine bone. Palatine bone is a bone in between the posterior part of the maxillary sinus and anterior to the pterygoid plates. So this covers the pterygoid fossa, medial wall of the pterygoid fossa. So you have to understand the orbital process of the palatine bone as well as the sphenoid process of the palatine bone in between the sphenopalatine foramen. This is the sphenopalatine foramen. So removing these two processes can only expose the medial part of the pterygoid fossa. And if you want a more lateral extension, another important knowledge in the anatomy is always the arteries are anterior. So when you expose the pterygoid fossa, you first endown the arteries, so you get enough time to preserve nerves and understanding the clear anatomy. And if you want to more lateral, actually you have to do a Denger's extension, and you can go more laterally with your endoscope. So when you go laterally, these pterygoid, wedge and other bony structures will be a hindrance to the shaft of the endoscope, which will prevent your further visualization. And this is the pictures of the maxillary artery with so many branches. This is the maxillary nerve with the VDN nerve and inferior orbital nerve, and these are areas where you look in the navigation for the pterygoid plates and pterygoid area. And this is a V2 schwannoma we have operated, and this is in the lateral wall of the sphenoid sinus, and this is the video. And you can see here is the area where the tumor is being taken, and you can identify the then you can come to the anterior cranial fossa, which is a much controversial area, because neurosurgeons are very familiar with the anterior cranial fossa surgery safely. But then what is the role of endoscopy? So first is very identify the key anatomical structures, then pituitary stalk, knowing the superior hypophyseal artery, and devascularization of the ethmoidal arteries, which is an important fact, because when we reach the anterior cranial fossa, we first devascularize the tumor. So the whole surgery will be a bloodless surgery. And you see, this is the most important structure. This is the planum here, sphenoid, limbus both sides, and the prechiasmatic sulcus. These are the things you should understand. Then the tuberculum cellae and the MOCR. MOCR is the important area where you have to drill the expose these all areas. And this is the impression for the optic nerve. And you can see LOCR and MOCR here. And this is the cella. And this is something we are looking from inside. And this is the MOCR where you make a good drilling and removing it to see the supracellular area. And understanding the pituitary stalk is a very important factor and in preserving the pituitary stalk. You can see the superior hypophyseal artery from the supraclinode ICA that is going in the inferior branch, superior branch and a lateral branch. And this is the diaphragmacellar area through which it comes, and it goes into the optic recess. And this anatomy is one of the key anatomy in preserving and identifying the pituitary stalk during your surgery. Video is not playing. This is the area of the tumor. After cutting, we are removing the tumor, and this is the area. This is the suprasellar meningioma we have operated through the endoscope. And you can see here the optic nerve here. This is the optic nerve. This is the optic nerve. This is the both A1 here. You can see the A-comb, A2 and the frontal lobes here. And these are all the arguments in and against, but it gives a direct access to the base of the tumor, is less likelihood of loss of vision in endoscopic approach, but smell is more preserved in an open approach, and because of less frontal lobe retraction, lesser chance of epilepsy and lesser chance of neurocognitive decline. And next, one of important thing you should understand in skull base is how you tackle the sixth nerve. Because sixth nerve, in the preponderant cistern, it has got a cisternal segment, then it comes an interdural segment, and the interdural segment continues as a cavernous segment here. So these three areas are important in understanding the sixth nerve. And the important structure we should drill is the petrosal process of the sphenoid bone. Drilling underneath the petrosal process is the sixth nerve. This is the lateral limitation in doing a transclavial approach. And this is another thing. This is the petrous apex. You can compare it with the outside with the endoscopic view. This is the petrous process, and anterior to the petrous process is the petrosal process of the sphenoid bone, which forms a boundary of the paraclavial carotid. And this is the area where we drill to expose this. After removing the petrosal process of the sphenoid bone, you will be easily able to identify the sixth nerve, and the chances of preservation of the sixth nerve is more there. And next is one of the difficult thing, transclavial approach. Already I have talked about the pituitary transposition, posterior clinodectomy, paracellular ligaments, inferior hypophyseal artery, and the sixth nerve interdural and transcavernous course. And it's a rule of three by Albert Rotten, the upper area, middle area and the lower area. And the upper area is otherwise called cellar clivus. It has got a dorsum cella plus pterygoid fossa sphenoid bone. Because all these things has to be removed, and pituitary has to be transposed, because if you want a direct approach, you should remove it. Then middle clivus is the sphenoidal clivus, Dorolus canal to the jugular fossa. It includes both petrous apex. Foramen magnum, inferior clivus includes foramen magnum, C1, foramen magnum, jugular tubercle, jugular foramen, etc. And this is how we do a pituitary transposition. And this is the final view. The important structures in the clival region is a basilar artery, sixth nerve, and the pons, preponderant cistern and pons. And this is a case of brainstem glioma. It's a brainstem glioma. You can see the brainstem glioma here. We have operated, and this is a direct approach. We are not retracting any structures. We are directly landing on the this region. This is another petroclavial meningioma, and this is the anatomy of the lower clivus. You can see the foramen magnum here. You are able to see the jugular tubercle, jugular fossa, and this is the parapharyngeal carotid. And its anatomy is the next important anatomy, understanding the foramen lacerum at the crossroads. Here you can see the foramen lacerum and the laceral segment of the carotid artery, which from the horizontal segment which turns into the paraclavial
after understanding this area, you can go up to into the cavernous sinus. You can go medially into the petrous apex and the upper petroclival fissure, laterally into the middle fossa and Meckel's cave, inferiorly into the inferior petroclival fissure and jugular foramen, medially into the jugular tubercle and lower clivus. And this is one more anatomy. You see, this is the pterygosphenoidal fissure. Is a very important in identifying the pterygosphenoid fissure, and a 45-degree with it gives the median nerve. And in between is the pterygoid tubercle. Drilling the pterygoid tubercle and exposing the foramen lacerum and the horizontal segment is important after identifying the median nerve. And this is again the anatomy. The first thing you encounter is the median nerve, and the median nerve goes into the pterygosphenoidal fissure here, and you have to drill above and below the median nerve, and then understand the pterygosphenoid fissure. Again, drilling the pterygosphenoid fissure will expose the horizontal segment of the carotid artery. The key anatomical technical nuances are transcavernous posterior clinodectomy. These are the points we will familiarize. Petroclival process of the sphenoid and abducent nerve, transpterygoid approach and palato-sphenoidal artery, foramen lacerum, translacerum approach, jugular tubercle and medial condyle for the lower clival lesion. Another is a contralateral transmaxillary approach, which is coined by Carl Schneiderman. This is used for a more lateral lesion, and you can see the trajectory. You can go more laterally from the posterior petrous area through the forming the, after removing the bone in the petrous apex, identifying the Garner triangle. Garner triangle is something sixth nerve medially, clival carotid laterally, and petroclival syndrome chondrus inferiorly. With that, you can approach till the internal auditory meatus. And this is a case we have done through transclival approach. You can see we are navigating. We have done a cardiac maxillectomy, then navigating through the maxillary sinus. Here you can see the this is the paraclival carotid, and inside you can see the sixth nerve, fifth nerve, and you can go much laterally, as I said, up to the internal auditory meatus. And complications, definitely you are ready to deal with the carotid injury, CSF leak, we can manage with our flap, infection, hormonal problems. And this is one carotid injury I have, which we have managed with a stenting, but it is very stressful to any surgeon who met with a carotid injury. And the alternatives are inferior turbinate, lateral wall flap, temporoparietal flap, pericranial flap, and free flap. And I must say that I don't like this order, but I have never been lost, but I admit to be confused for several years, and still confusion prevails. I don't think when it ends. Thank you.
A very nice presentation. Any questions from the floor?
Thank you, sir. Sir, CSF leak is a real problem, but for a fresh case or a first case, we had a lot of methods. We will put a nasoseptal flap, Haddad, Besagatier flap. Recurrent cases, we will put pericranial flap, temporal flap, and we use a lumbar drain. And there is a three-layered construction. First we put a collagen, then this either dural substitute or fascia from the here. Then we put over that we will put a fat, and then we will put a vascularized flap. And usually the CSF leak is not a problem if you do all these things.
How do you manage that glioma erosion, brainstem glioma erosion?
It's the same way. First you put a collagen, then you put the fascia lata, then over that you put a fat, then over this you put a vascularized nasoseptal flap.
Do you use a glue for each leg?
There are a lot of controversies. Some now the doyens like Paul Garner, they never use glue, but you can use the glue around the periphery.
I will tell you how I manage last carotid surgery, because it is because of this anterior disposition of the anterior vertical. We have because of, this endoscope won't give a 3-dimensional view. We are using some newer instrument, and this created an injury. What we have done is we put a muscle, then surgical, control the bleeding, put a pack, and call the neurointerventionist. They came and they took him to the theater angiosuite next to theater. They have put a stent, and almost I am out of danger, but there are a lot of problems. Later the patient developed a pseudoaneurysm because the stent it's a real problem. Carotid injury is a real problem, and all in the game we have to be more and careful. That is why the most important, if you I am not that stage. If you understand how to isolate the carotid, half of the skull base work is over.
Sir, excellent talk. Yeah, just for the lateral skull base, any experience with transorbital work? A lot of publications. Transorbital.
I don't have any experience, but it's as you said, it is a coming up thing, and many papers I have a less knowledge, but I think it is a coming up thing.
Yeah.
Ajit, have you come across any long-term complications after extensive skull base drilling, bone drilling?
Long-term crusting is the one complication, that because we work in a team approach. That part will be always managed by Vinod, our ENT skull base partner. The main problem that can come is the one, sometimes this pericranial flap will get necrosed, and there can occur meningitis. Another thing is crusting. Then you have a bad smell.
Any herniation?
Herniation is never happens. Redo cases are little difficult because many people send cases are 3-4 times operation. So my advice is, if you go for one thing regarding the flap, because if you do a endonasal transseptal microscopic approach, all the flaps are gone. So we have to depend on a free flap. Or other options, one is the pericranial flap. We bring it through the frontal sinus. Another is a temporal flap. So there are alternatives, but we can manage without much problem.
As an early neurosurgeon, I had been watching the growth of Dr. Ajit. He had been working with me for the last so many years, and he's a very meticulous surgeon. With all these things, I would like to ask one question. If there is a bleeding, how do you stop? Because one of the complications that can occur, what they say is the bleeding, and that is a bit difficult to tackle the bleeding.
Sir, it is a team approach, because I have one ENT surgeon with me. He will hold the scope, give a continuous suction, then just like, because it is something of just like a microsurgery. Whatever you can do in a microsurgery with a forehand technique, you can do in an endoscopic surgery. With he holding the endoscope, giving a suction, then identifying the point, putting the muscle or a surgical, then control the bleeding, then wait for the, you have managed the contingency, then you go for other things like lateral management. So, and the second thing, we are doing a microscopic surgery. Even if you put a hole in the carotid, it will be a small one because of the microsurgical nature.
Yeah. Excellent talk, Dr. Ajit. About the CSF leak part, what we have observed is that the CSF leak is higher in the transclavial approaches than in any other approach. Even for the extensive anterior skull base approach, we don't get so many leak. I think the reason is that when we pack the clivus at multi-levels, when the patient is mobilized, there is some kind of subsidence that must be happening in the reconstruct. Yes. That must be the reason why there is so much leak happening when it's transclavial approach. Yeah, good talk. Good talk.
It is something they call a Japanese technique. We put the collagen, then we put the fascia lata, then we tuck it to the deeper part, and then over it you put a fat, then put the nasoseptal flap. But I am not in a position to say that I don't have that experience, but for clival lesion it's never happened. Usually happens with the redo cases.
Issue is because it's more of a vertical construct.
Yes,
There's
yes.
some
What you said
subsidence
is
that is
absolutely
happening,
correct. And flap won't sometimes don't reach
Yes,
there, edges
that's
won't reach
also
there. Flap is the key thing,
Yeah.
nasoseptal flap.
Thank you, sir. I request the chairpersons to please hand over a memento and certificate to Dr. Ajit. Thank you. Our next talk is by Dr. Girish Menon, a name which needs no introduction, be it at Sri Chitra Institute or KMC Manipal. With huge skills, higher knowledge, and a great personality, adding on to his accomplishments in vascular neurosurgery is epilepsy surgery at present. We welcome you, sir.
Thank you. And thank you, Calicut Neuro Society, for this invitation and the generous hospitality. And I was told Murli is the one who wrote the introduction for all. I've been listening to all the introductions from morning. And that all, I think, very generous introduction. Thanks so much, Murli. But I'm not too sure whether I should thank you for the topic you gave me, because Murli asked me, sir, brainstem is something which has not been covered. Can you talk something about brainstem? And I had to accept it, but then that I have to expose a lot of skeletons in my cupboard while doing that. So, how do you assess outcome following any procedure? You have patient-related factors, we talk about the disease pathology-related factors, and then of course the surgeon-related factors, but a lot of times we don't talk about some other factors. In fact, outcome depends on a lot of others, including the theatre scrub nurse who scrubs with you, the assistant who scrubs with you, the technician who helps you that day, and not the least, the mood of your spouse that day morning, that can upset you and that can also hamper your outcome with the surgery that day. But as far as brainstem cavernomas are concerned, there's no confusion. There are only two possible outcomes. You are either between the devil and the deep sea. You have a choice of having morbidities due to the pathology, that is because of the cavernoma, or pathologies due to the devil, that is the surgeon, the knife-wielding surgeon, who unfortunately resembles all of us here. So, this is what I would like to discuss about in the next 20 minutes or so. So, let me start off with this index case. This is a 32-year-old young, very hearty young male, in fact a steward in a private airline. And he came to me with very vague symptoms, vestibular, tinnitus, vertigo and so forth, and he got as somebody had recommended a scan, and this was picked up on the scan. And to date I am not still sure whether his symptoms can be correlated to this particular lesion. He was an educated guy, and when you talk to these people and they Google all, and you talk that there is a percentage, so many percentage of, even if you say it's a 0.001% of risk, they're all scared, because how are you sure that you do not belong to that 0.001%? So I operated upon him 5 years back, and mind you, with the neuronavigation, intraoperative monitoring, I lost my way. Because the surface was clean, there was nothing pointing on the surface. I did a myelotomy, I went inside, and I lost my way, and some good fortune, I backed out. I got some kind of blood and I sent that was negative, and I knew I had done a half-hearted job. And as expected, few years later, the scan shows the same. Touch wood, fortunately, the patient is intact. No further deficits, although his pre-op symptoms persist. This gentleman, a 46-year-old male, he in fact presented with hydrocephalus initially. I was not too sure about the pathology. I did an ETV and asked him to wait. Then his predominant symptoms were upgaze, paresis and so forth. Because that was increasing, then I thought I will just chase the lesion. I went did a supracerebellar approach, and this is the outcome. I mean, outcome-wise, scan-wise, an excellent outcome. But to date, the patient has not completely woken up after the surgery. He's still bed-bound, up-gaze, he's got bilateral ptosis, just beginning to obey, and as I'm speaking yesterday, he got readmitted with CSF leak from the wound. So this makes you introspect, and this is the cupboard, the skeletons which I was talking about, and this makes you introspect, and was it a wise decision to operate on all these patients, and how do you kind of overcome this challenge called brainstem cavernomas? So to do or not to do, when to do, how to do, and of course when you talk about how to do, the role of monitoring, role of DTI, and some other correlated factors like venous anomalies and gamma knife. So I'll just try to briefly cover upon them all so far. So before that, no disclosures, except that I have a very modest series of 15 patients, 12 of operated, 3 non-operated, but this includes many of the cases which I had personally done or has been closely associated with in this publication, which was published way back in 2010 from Sri Chitra. So first question, to do or not to do, and to answer that we should know when not to do, and when not to do, the best answer is given by knowing the natural history of these pathologies. Multiple number of studies, meta-analysis, systematic reviews, and have all come out. Almost, as you can see, more than 5,000 patients have been analyzed in different studies which have been published over the years, and the verdict is quite clear. Brainstem cavernomas have a higher risk compared to supratentorial cavernomas. The highest risk is in the first 8 months, but it can persist up to 2 years, and thereafter it declines, but definitely a definite risk. An incidental or so-called asymptomatic, I will come to that shortly, has a risk of 4 to 8%, but a symptomatic one, once it has bled, essentially if it has bled once, or if there is a focal neurological deficit, the risk jumps proportionately, or it's a quantum leap actually, it's almost 30.8%. And within 10 years, almost 60% of them rebleed. Now here there is a catch. How do you define rebleed in a brainstem cavernoma? It is not the classical sudden onset bolt from the blue or that kind of headache which a patient has. Even a subtle deficit the patient has, a new deficit, is described as a rebleed. So the rebleeds can be either it can be radiological or clinical. Now that brings to this question. Suppose I have for some reason I get an MRI done and I find this particular lesion in my MRI. A hemosiderin rim is a classical characteristic MRI imaging of a cavernoma. Now does that mean I have had a bleed? For that matter, what I am trying to convince is that whenever a cavernoma diagnosis is made, practically I guess it invariably implies that there has been a bleed, because usually all these lesions are associated with a hemosiderin rim, which indirectly implies that there has been a bleed. So whenever we see a patient, first time diagnosed patient has already had a bleed. The implication is because that plays an important role in decision making. Whether the patient has bled or not is an important factor in deciding whether to intervene or not. So the dilemma, conservative management, again studies have been there, but I won't go into that because we have number of studies of late. In fact, it is in the early 2000s when there has been a paradigm shift. Earlier it was a little conservative approach for brainstem cavernomas, but multiple studies, some of which I am showing. The first one in fact by Hunt Badger in early 2000, and then in fact this one, the systematic review in 2019 has conclusively sealed actually the fact that you can operate upon brainstem cavernomas with acceptable mortality and morbidity. Now I am not too sure whether you can call a morbidity of 35% as an acceptable morbidity. Now this is the dilemma. This is the literature, meta-analysis literature of multiple studies all over, and they say a morbidity of 34 or 35% is acceptable. So that's what I was discussing today morning. I mean, our perspective of good outcome is quite different from the patient's perspective of good outcome, and this I am sure is the surgeon's perspective of good outcome, because all these patients invariably are left with some amount of deficit. So the question, to answer the question when to do. So the first question, evidence-wise, brainstem cavernomas have surgically are operable with reasonable outcome. Now timing of surgery, here are two implications. One, timing relates to the bleed, whether the patient has bled up before or not, and the actual time, how many weeks after, so when to operate. So this again, there is enough evidence that if a patient has had multiple bleeds, the outcome is definitely going to be not good. So if you want to operate, you might as well do the surgery after the first bleed. Don't wait for the second bleed. Now, second question about timing of bleed. After a bleed, when do we operate? That's a very important parameter. If you look at all the recent studies, that is a very important parameter. Pros and cons. Now, let us not go into the most of these studies do not wait for more than 8 weeks. So the question, the dilemma is between whether we operate acute, that is within first 3 weeks, or within 3 to 8 weeks. Now, the pros and cons for early surgery is that within 3 weeks, that is acute bleed, is that recovery is better. You immediately take out the clot, the insult can recover faster and so forth. But the damage that caused by acute hemorrhages, acute surgery is much worse. So in general, the philosophy is to operate within 3 weeks to 8 weeks, but not later than that, because once a hemosiderin or a thick clot forms, that becomes a problem. Operating after a thick clot is formed is a challenge. So it is 3 to 8 weeks, that is the time when ideally you should operate. Now, so to answer the question, when to do, within 3 to 8 weeks, and if it has to be done, after the first bleed. And now how do you decide if it has to be done? How do you answer that question if it has to be done? Now to answer that question, we have grading and scores which have been proposed. This was a little earlier by the group from Barrow, Lawton et al. And as they did for AVMs, they have come out with a grading scoring system, a maximum score of 7. But this was later modified by, in this article, which has come out as late as 2022, where the scores have come up to 12. And we have, based on the scores, you grade 0 to 3 is no need for surgery, 4 to 6 is a gray area, 7 to 10 is surgery, 11 to 12, nobody knows. Again, it's a gray area because it carries a higher risk. Now, this is a dilemma which I feel that this kind of mathematical modeling, bringing out or proposing mathematical models to solve biological problems just does not work out in real life. I mean, it is not 2 plus 2 is not 4 in medicine. So, but there's only way forward. Let us look at these parameters. If age is the first parameter. If it's a younger patient, the plasticity is better. The chances that the patient recovers after a deficit is better. But left to me, I would rather be happy giving a deficit to a 60 or 70-year-old rather than giving a deficit to a 40-year-old, because his life gets crippled. Now size, the smaller the size, the better the outcome. That is the general principle. But again, the larger the size, the more chance that the lesion surfaces, and a surfacing brainstem cavernoma is easier to operate than a smaller, deeply located cavernoma. Location-wise, of course, there isn't much difference between pons, midbrain and medulla, but pons is generally better because slightly larger than the rest, and if it is surfacing, it is easy. Crossing midline is a big no-no. So lesions which cross the midline, both sides, because you just can't afford to give bilateral deficits. Time after hemorrhage I've already discussed, and the preoperative status. So what the later classification which I proposed has, they are just, the other first 5 parameters were proposed by the Barrow group, and the latter classification brought out the preoperative Rankin score of the patient as well into the picture. So obviously you wouldn't like to operate on a bad pre-op status patient. So just to summarize, if it has to be done, we still do not have an answer if it has to be done. Although literature, scientific evidence suggests it has to be done, and most of the publications you see are patients done in different grades. Now how to do? Again, I would say brainstem safe entry zone is an oxymoron. You just do not have a safe entry zone in the brainstem. Wherever you touch, you are likely to produce. Of course, theoretically, for exam purpose, you can write, and this is all the pictures and photographs that you have. But let us just remember the fact that there is no safe zone inside the brainstem. What we need to know, if at all we decide to operate, is the goal of the surgery is to prevent further bleeds, not to improve neurological deficits. It has to be a fine balance between hemorrhagic morbidities and surgery related. We should not be adding to the patient's deficits. So my principles are simple. Just broadly divide into ventral and dorsal. If it is ventral, if it is in the midbrain, either you go transylvian or subtemporal. If it is in the pons, I prefer retromastoid. If in the medulla, I still do retromastoid if required, far lateral. For the dorsal ones, if it is in the midbrain, I go supracerebellar. If it is in the pons and midline, you go through the fourth ventricle. So just picture description of some of the approaches which we have approached, which I just want, it's a standard approach, nothing much to describe about that, but this is something which is, this is again proposed, the 2-point approach, which is to decide on how to enter the brainstem, which is again proposed by the Barrow Institute. I wouldn't go into the detail, but essentially what it tells us is that there are these 2 points when you have to draw a line and then decide which is the shortest from the pile surface and go through that. This picture particularly shows that this was ideally planned for a suboccipital approach, but then the far lateral approach would have been better for this lesion in the medulla. Again, multiple theories, but in practical, these are the important things which I like to convey or share. Rather than looking for a particular entry zone and the classical description, look for, as Dr. Suresh, we were discussing yesterday, Professor Suresh, I was telling, if the lesion is surfacing, you are seeing a discoloration of the surface, that is the safest zone to enter, rather than go by the other landmarks. And you try to go for an en bloc removal. Leaving a small bit of cavernoma is dangerous, because in the earlier series which I showed, 58% of rebleeds were because of residual lesions. And unlike in the cavernoma in the supratentorial, when you take out a temporal or a frontal cavernoma, we are advised to take out the gliotic rim as well, because that is those are seizurogenic. Just let us not do that in the brainstem. Leave the gliotic area, just come out taking out the cavernoma, not to touch the fiddle around the gliotic area. It may not be functional, but not to touch that gliotic area, because studies have shown that that in fact contains more vital cells than what is suggested. Now, role of DTI introp monitoring. Again, I would like to comment that it is little overrated. Yes, it helps us to decide on your entry point. Mark the DTI and it will tell you, okay, where to enter or not, where not to enter. But again, if the DTI kind of passes, like you have opened up and you see that there's a surface discoloration and your DTI picture suggests that that is a track going through that, what do? You just have to enter through that area. Introp monitoring, same. Unlike when you do a cerebellopontine angle or acoustic, you see seventh nerve is getting irritated, you leave some tumor. Like morning what Rupesh was telling, the monitoring suggests that you are causing deficits, the waves are coming down, you can leave a bit of tumor there. But in a brainstem cavernoma, once you are in, you cannot stop it halfway through. You have to come out, whatever the waves suggest or not, you have to come out taking out the cavernoma. So I'm not too sure about the evoked responses which you elicit. Once you are done a myelotomy, we are in the cavity, we are doing the surgery, you just can't stop about halfway through. Developmental venous anomaly, the classical teaching is we should preserve them, not to tamper with that. Yeah, but the catch in this is 7 out of 10 times, at least in my series, we never find a DVA on a preoperative MRI. In fact, there have been studies based on these images which I am showing are 7 Tesla MRI images. So, the importance of knowing where the DVA is, again, it helps you to decide on the entry point, so that you don't want the venous anomaly in your trajectory, in your line of approach. But to find out the DVA before that is difficult. Now, one of the last contentious topics, if it is so challenging, why not just subject the patients to gamma knife radiosurgery? Proponents of radiosurgery do advocate gamma knife, but unfortunately literature evidence is against gamma knife, and this is the 2022, in fact last year's meta-analysis which has come, which has shown that gamma knife is not inferior, not superior. That's just what the conclusion essentially says is in all parameters it is kind of equivalent to radiosurgery, equivalent to surgery in terms of deficits, in terms of long-term outcome. But the outcome of surgery, of course, the advantage of surgery is the lesion, you take it out and you are sure the lesion has come out. With gamma knife for the next 2 years, you are not sure whether the risk of rebleeding is there for 2 years. So, all in all, not a very favorable verdict in favor of gamma knife radiosurgery. So, just to summarize, A subset of brainstem cavernomas do not require intervention, but unfortunately, there's no way to identify which is that subset which does not need to be intervened. There are some guidelines, small ones, deep-seated ones, but it is not foolproof. DTI and intra-op monitoring, they help you, you need them just to plan your entry point, but after them, that not too sure it is helpful. Safest way to approach is to look for staining on the surface. If the lesion is surfacing, those are the best ones you try to attack. The other ones will be a little guarded. Lesions crossing the midline, especially in the pontine region, those are probably the ones which you should not venture into. And once you are in, attempt to take it out completely. Residual cavernomas are prone to rebleed, and not to attempt taking out the gliotic rim as you would do that in a supratentorial cavernoma. So, not all is gloom and doom. There is this interesting article which, in fact, we always hesitate. You find a cavernoma, you're scared to give them antiplatelets and anticoagulants. There is this study which has come in Lancet Neurology, in fact, which says that they had two groups, one which got antithrombotic platelets or anticoagulants. In fact, there is a risk of rebleed was much lesser in the group which got antithrombotic therapy rather than in the other group. Not that it is a treatment, but definitely you don't have to worry prescribing antiplatelets or anticoagulants to patients with cavernous malformations. So to summarize, there is a good group of cavernoma which probably do not bleed, but we do not know which of them. There are the bad ones where you have the deficits caused by the cavernoma, and the ugly ones for us where we cause the deficits. So you have the good, the bad, and the ugly. Thank you so much.
Excellent talk, Dr. Krish, as usual.
Can I ask? He did the first case at airline staff. And that patient that you told just hemosiderin around, it should be told as patient as blood.
I'm not sure, sir. I'm assuming.
Because
but that is an integral part of.
My thing is, unless you see T2 hyper or T1 hyper, that is extracellular met, which will be hyper on both T1, T2 sequence. If it is there, only those only we should consider as blood cavernomas. Other things, hemosiderin is part and parcel of small microbleeds. Small.
So whether we consider this microbleeds as bleeds is my question. So
because I think
the moment you diagnose, you see a cavernoma on MR.
No, it is still, I don't know, unless the patient has had a bleed. I think that is what I have taught residents. You should not touch it. Bleed means T1, T2 hyper. Just hemosiderin around, that is a characteristic of cavernoma, signature. But to consider for aggressive treatment, they should have T1, T2 hyper.
Defining bleed in cavernoma is the challenge.
Yeah. I agree.
Very
grey area.
Medical or radiological is the challenge.
Very grey area.
So that be the thing. See, how would you diagnose a cavernoma without that hemosiderin? Yeah, incidental, no, without bleeding. I mean, you see that hemosiderin deposit.
Clinically, but radiologically, if you find, invariably you will find some amount of bleed radiologically to make a diagnosis of cavernoma. So then that means it is blood. It is a radiological bleed.
So what do you do in that?
No, that is the dilemma. Because as per this decision, if it is not blood, you don't touch. Fine. But radiological, there's no clinical evidence, there's a radiological evidence of bleed. So does that mean that you go and touch?
Girish, initially you said caught between the C and the deep C and the double, and you said you are confused. But listening to your lecture, I think you have the highest clarity of thought. Congratulations. No, I think so. You are very clear that, it's confusing. Some people are confused and they don't know they are confused. That's dangerous. Thank you.
I have clarity in that I am confused.
To me here, bad is good, good is bad.
That is my actually that is my next slide, sir.
To me, because that one looks very innocuous to me. That you are the good desire. That if you touch, it will become bad.
So I think a lot of this large percentage of rebleeds is because they bleed in clusters. So some of them bleed in clusters, they keep bleeding again and again. And some of them remain quiescent for a very, very long time. And we don't know which one is which. That is the whole problem. But that is why the rebleed rates become much higher, because they are much higher in some of them rebleed for 3-4 times. Some of them don't rebleed at all.
The familial ones are the ones which occur in clusters.
Yeah.
The sporadic ones are usually solitary.
Yeah.
The solitary ones are the one, that's the contradiction again. The DVAs, the venous anomalies are more associated with the solitary ones. And but the risk of bleed is more in the familial ones, which are multiple.
And as you said, even in the best of the series, there is perioperative morbidity in 1/3 of the patient, which is actually being derived by the surgeons. Like surgeon is saying that there is morbidity. You should just double it, that it is 66%, because we tend to underestimate our own deficits. So as far as possible, I have learned to be very conservative with this, despite everybody saying that this is the next aneurysm and you should take out all these things. Because brainstem cavernous was invariably, even if you make a very, very small incision on the pons, by the time you take out the pons, the incision becomes this big. You'll have to do it. I mean, there is no other way.
That's what, once you're in, you have to forget, you have to stop the monitoring, because then you can't proceed.
Girish, just to put you in a little difficult situation here, that airline fellow, if he had 3 cavernomas with same symptom, everything looking same, what will that done?
Dr. Thomas. Dr. Thomas.
Does a cavernoma produce a catastrophic bleed?
Supratentorial, no. Brainstem, yes. The large one, like the other one.
What is the incidence then? Do you really have to operate on those?
No, there are acute surgeries described. Acute surgery in cavernomas have been described. Such instances, catastrophic instances.
Thank you, sir. I would like to request our chairpersons to hand over memento and certificate to Dr. Girish. Thank you to our chairpersons. With this, we come to the end of our third session. There is no official tea break. However, tea is being served in the exhibition hall for those who wish. We will be commencing with our last session for today. I request our chairpersons, Dr. Biju Bhadran, Dr. Ramesh CV, and Dr. Tinu Ravi Abraham to please come on stage.
Good evening to all. With this, we are moving to I think the most sought after session in any conference is how I do it session, especially the young neurosurgeons, and for the young or old. We have a bunch of young neurosurgeons who want to share the experience with videos. The first speaker is Dr.
Our first speaker is Dr. Shijoy, trained in AIMS New Delhi, currently at Aster Kochi, and surging ahead in functional neurosurgery at present.
I thank the delegates for this opportunity. It is a beautiful venue, and I'm sure everyone have loved and enjoyed all the work, the hard work the committee has done, and thank you so much. Going on to the talk, my talk is on the transchoroidal approach. Slide. Yeah, transchoroidal approaches to a third ventricular tumor. It's a two-dimensional video. This is basically looking at the younger, like how the chairperson said, at the younger crowd. Most of the senior people have been doing this for ages. The case is an 11-year-old male patient who presented to another center with headache and vomiting. He was evaluated and an MRI showed a posterior third ventricular lesion. He underwent endoscopic third ventriculostomy and a biopsy. The histopathology was an immature teratoma. He underwent 2 cycles of chemotherapy with ifosfamide, mesna, carboplatin and etoposide. Unfortunately for him, in 2 months' time, the lesion grew significantly in size and had worsening of clinical deficits. That's when he presented to us with the chief complaints of diplopia and poor balance. Neurological exam, he was awake, alert, oriented, but however he had horizontal diplopia in all directions, up gaze and down gaze restriction. The fundus was normal, he had a wide-gazed gait. So this is the lesion to which he presented at the other center, but this is what it became in 2 months' time, soon after chemotherapy was given. The lesion is heterogeneously enhancing, honeycombed in appearance, has dilated the left lateral ventricle disproportionately as compared to the right. Okay. I need a pointer. The coronal cuts showing compression of the brainstem. So what was the rationale for surgery? He had hydrocephalus which had to be relieved. The compression on the brainstem needed to be decompressed. We wanted to remove the threat of symptomatic progression and avoid recurrence by offering a gross total excision. Now, how does the lateral ventricle look like? There is a foramen Monro, there is the antiseptal vein, the septum pellucidum, the choroidal plexus, thalamus, and the fornix. This is a magnified view. The roof of the third ventricle is formed by 5 layers. The fornix followed by the 2 layers of the tela choroidea, with interposed by the velum interpositum, and the most inferior layer, the choroid plexus. The transchoroidal approach goes through the telea fornicea and enters the velum interpositum and then goes through the inferior layer and then enters the third ventricle. Once the superficial layer of the tela is taken out, the velum interpositum, the structures, the internal cerebral vein and the medial posterior choroidal arteries are seen, and once the inferior layer of the tela is taken out, the entire third ventricle is widely open to address any tumor from there. So most importantly, the venous anatomy is extremely important in these cases. Then we need navigation is helpful, ultrasonic aspirator, microscope. Going on to the operative video, the patient is placed in a lateral position. We decided to go from left side down. The falx is seen up superior. Inferiorly, it's the cingulate gyrus, the pericallosal vessels coming into view. Sharp and blunt dissection is being done to open up the fissure, and then the corpus callosum comes into view. Using navigation at this point to know exactly where the corpus callosotomy needs to be done, we make a 1.5 to 2 centimeter corpus callosotomy, and once this is done, the left lateral ventricle is entered, and once that is, the choroid plexus comes into view, which is followed anteriorly to the foramen Monro, which is obstructed by the tumor, and here you can see the antiseptal vein, the thalamostriate vein, which join together the venous angle to form which is hidden here, the internal cerebral vein. Again, navigation is being used to open up, to know the location of the opening of the tela. The tela is being opened up, preserving the venous the thalamus striate vein and the internal cerebral vein, and the tumor begins to be seen in this point. I'm unable to move it faster. Sorry. Okay, I guess we'll have to go through the entire video.
You can take the video separate. You have the video separate for then you can do it.
Okay. We'll do that. Give me a second. In the thought of time, I was thinking. Play the entire video. Okay, great. This is the video. Yeah. Sorry for that. Yeah, so we saw that. How do I play it? Okay. Okay, got it. How do I play it? I guess I need to. Mirroring audio play full video. I'll just play the whole thing again. That's okay. I'm not getting the bar. Sorry for that. We'll have to go through those steps again. So we chose a lateral position because the gravity helps in retracting the lobe on itself. This is anterior, this is posterior, this is medial, and this is lateral. The falx has been dissected superiorly here. The lobe has fallen off because of the gravity. And then here's the corpus callosum. We were just seeing corpus callosum is opened by gradual opening of a forceps or a bipolar, 1.5 to 2 centimeter. The left lateral ventricle is opened. And this was, we had seen the choroid plexus, the internal cerebral being formed at the venous angle. The corpus callosum, the foramen magnum being obstructed by the tumor completely. And the choroid plexus is displaced laterally completely by the tumor. The tumor is a 4 centimeter. We had seen the MR, quite a large tumor. And then the tila is opened up and it opens a highway into the third ventricle. The advantage of this approach is there is no neural structure which is damaged. The thalamus is clear, the vessels are clear on this side, and the entire, once this is completely opened up, which you'll be seeing very soon, the tumor can be easily taken out without any kind of retraction. Gravity is forming the only retraction here. There is no retractor placed on any part of the brain. So this is the thalamus striate vein going on to form the internal cerebral vein. The antiseptal is here, it's hidden under this. And this was where the foramen Munro was. We had seen that there. Yeah, once we are within the tumor, the routine microscopic techniques of internal decompression using a CUSA. Once the capsule is opened up, internal decompression, you can see that the tumor is very fibrous. And once a significant amount of internal decompression happens, then the lesion can be rolled into the third ventricle. This is the foramen Munro, which is now opened up. That was where the antiseptal was. Now again, working posterior to these venous structures. This is the venous structure. This was the Munro. This is the place where we had opened up the tila and rolling the lesion into the space created. This is the posterior wall of the third ventricle which is being dissected. That was the only point where the attachment was. So once that is dissected off completely, even a little bit from the opposite, the right lateral wall of the third ventricle, the tumor is completely rolled in and the third ventricular floor comes into view. Now, and there you see the aqueduct with the gush of CSF. So the goal achieved. The CSF pathways are open and then we get the pedicle of the tumor where it is attached, where the vascular supply is probably coming, buzz that, and the entire thing comes off. So here we are seeing the entire third ventricular flow, the anterior commissure, the optic recess, the infundibular recess, the mammary bodies. This was the vessel, the thalamus striate vein, and this was where we had opened up the tila. This is a mesenchymal. And posteriorly we had seen the aqueduct of Sylvius, which is open. Yeah, this is the immediate post-op image, which shows a complete excision with no residual through a small corpus callosotomy with no other neurovascular structures being damaged. Yeah, so he had a remarkable recovery of his diplopia, gaze paresis and gait, also improved. He had he had complete neurocognitive improvement in all domains. His histopathology came out as mature teratoma. If you remember, it was initially started as an immature teratoma. So we went in again and saw why this was absent, and the pathologist gave us this growing teratoma syndrome. This has been published way back in 1982 by this group. On follow-up, the patient had no recurrence at 1 year and at 2 years. And the benefits of this procedure is it's a natural corridor. There is no damage to any neurovascular structure. No cortisectomies are needed. Cognition is not affected. It opens up the CSF pathways. And however, there are risks involved, but with proper towards the fornix, the thalamus, and the vascular injury. But this can be avoided by meticulous surgical techniques. Thank you.
Thank you, Shijoy. The topic is open for discussion.
Yeah, so we had looked at it. What is the distance from the dura posteriorly to reach the anterior part of the tumor was around 10.5 centimeters, and this was shorter, around 8 centimeters. So 2 centimeters short, completely third ventricular. And the veins, which you've seen the MRV, which showed the veins were not the bestest to go through from behind. So shortest corridor, no damage. We can, in case of large tumors, it is allowed and the patient, it is forgiving, but if we can preserve it, best.
Also, have you got any experience with transfornicial transchoroidal approach?
So, towards the third ventricle, there are 3 approaches which are being published. One is the interfornicial approach. The interfornicial is for lesions which are in the anterior third ventricle, because beyond 2 centimeters from the posterior margin of the foramen Monro starts the hippocampal commissure, which connects both the fornices. Once we enter into that, the patient has significant memory deficits. So once a callosotomy, then you're going through the septum and going towards the fornix, but we have to restrict ourselves up to 2 centimeters posterior. So any lesion anterior to this, it is takeable. But in this case, it was quite a large posterior lesion, so a transchoroidal approach was easier.
For the anterior lesions?
For anterior lesions, it is described.
Excellent presentation. I have one doubt. Is it needed to have a third ventriculostomy? We are not sure about the aqueduct opening.
Yeah, so
we are looking right onto that floor.
No, we didn't do the patient underwent a third ventriculostomy in another institute, and when we had operated, we saw that the third ventriculostomy was closed.
Because you are seeing the aqueduct very well.
Yeah, here it was not done. We didn't do
and the size of the tumor also decides whether you can go entirely with this intimispheric because.
Yeah, correct.
And what side, medial or lateral to the, I think you're shown the medial side in the tila choroidal opening
Yeah, so the typical transchoroidal is when we are going, the tila divides into two. Towards the fornix called the tila fornicia and tila thalami. So if we can open up the tila fornicia, that is the typical transchoroidal approach. When you go lateral, it is called the subchoroidal, or when either side both can be used. So all doesn't match one. It is to take out the tumor, that was the goal. Sorry. Thank you.
For the next person, for the
I would like to request the chairpersons to please present a memento and certificate. Our next speaker is Dr. Vinu V. Gopal, an academician, researcher, and a skilled spine surgeon. At a young age, it's difficult to count the degrees he is pursuing and achieved, including law, believing to change the spine surgery practice in India, and pushing to improve the academic curriculum of neurosurgery.
Good afternoon and happy New Year. Thank you so much for the kind words of introduction, respected chairpersons. So I will present here my limited experience with the right-sided anterior retropharyngeal approach for fixation of bilateral atlantoaxial joints. Posterior approach of fixation of atlantoaxial joints are considered as the gold standard, which is popularized by Professor Atul Goyal, sir. So there are certain problems associated with the posterior approach. One is the risk of vertebral artery injury. The vertebral artery is in close proximity to the C1 and C2 joint, and because of the complex anatomy, the vertebral artery can be high riding. It can come in front of the C1, C2 joint, so it can get inadvertently injured during the procedure. And also disruption of the posterior ligamentous complex and C2 root denervation also leads to paraspinal muscle atrophy, which further worsens the instability. And also bleeding from the suboccipital venous sinuses are very messy, and it will be very difficult to control by an inexperienced surgeon. And also there are complications of prone position, and which lead to spinal cord ischemia and all these hemodynamic instabilities during surgery. So we had thought of a varied technique of anterior approach to the bilateral atlantoaxial joints. It has many advantages because the approach is through the right side. We can reach both sides of the atlantoaxial joints, and the approach is retropharyngeal and intermuscular, and there is no risk for vertebral artery injury, paravertebral venous plexus, or C2 ganglion. Also, supine position is more physiological. And we can itself use this procedure for irreducible AAD and basilar invagination. You can use a customized wedge-shaped lordotic titanium cages which can distract the axis with the odontoid and reduce the basilar invagination. Also, the screws are self-tapping, and once you tighten the screws, it will engage in the next further slot of this dynamic compression plate, which can give more compression and fixation. And also this approach is useful for odontoid fractures. You can even give an odontoid decompression. Also you can address other subaxial cervical spine pathologies too. So coming to the preoperative evaluation, a dynamic lateral X-ray will help us a lot, because this approach can be used only if there are a lot of technical difficulties, and we can use this anterior approach only if the angle of mandible is at or above the level of the C2 body. And you can also use virtual reality axial and sagittal three-dimensional computerized tomography images, where we can even place the person in the supine position with extension, and you can also look for the irregularity of the C1, C2 joint and the C2 body. That will help you a lot during the surgical procedure. And we usually use a nasotracheal intubation with the patient in with the supine position, and you can even strap the mandible so as to open up the corridor of the neck and the head. And it's preferable to use a radiolucent table. And I also use a Mayfield clamp to fix the head so that it should also be away from the table for easy maneuverability of the C-arm. And this is the operating room setup. The surgeon can comfortably sit on the right side of the patient with the assistant on the other side. The scrub nurse with the trolley on the left side caudal part of the patient, and the anesthesia and the machine on the right side caudal part. And you can easily use the microscope along with the C-arm. It is preferable to use biplanar C-arm, or you can adjust with one C-arm in the AP as well as in the lateral view. So coming to the operative steps, we will use a curved incision 2 centimeter below the mandible, safeguarding the marginal mandibular lobe. And the approach is same as that for an anterior cervical discectomy. You will raise a subplatysmal flap, and after that you will see the submandibular gland. Once you release the fascia of the submandibular gland, you can easily see the anterior belly of the digastric. And just beneath the anterior belly of digastric is the hypoglossal nerve. And I also used to tack up the hyoid bone to the opposite side so as to open up the corridor. And also you can even suture the submandibular gland to the cephalic region to open up the corridor. And you can the main thing is you can use these Langenbeck retractors for retracting. Dynamic retraction is more important so as to prevent injury to the hypoglossal nerve. And once you reach the C2 body, the longus colli, there will be longus colli on both sides. And we will have to retract the longus colli from the C2 body to expose the C1 and C2 joint. This is the operative video. Let me orient. This is the right side. You can see the hyoid bone, thyroid ligament along with the pharyngeal constrictors, and the carotid and the sternomastoid on the other side. And now I am using the Langenbeck retractor. Now we will be reaching the C2 body. Once you dissect out the loose areolar tissue between the superior constrictor and the carotid, you will reach the C2 body. And after that, you can use the bipolar in low current to dissect out the longus colli on both sides. And we will have to dissect it out from the C2 body. You will have to look after the irregularities of the C2 body in the preoperative computerized images. So that will help you a lot in dissection. And I also used to, preferably I used to dissect the 12th nerve also, because it will avoid traction injury while dissecting. It's very difficult to dissect the longus colli at the cephalic end of the patient because it is converging towards the C2 body. So once in a while you will have to cut the longus colli also to reach the joint. This can be later sutured after the procedure. This is the C2 body after retracting the longus colli. You can see the right C1 and C2 joint, midline, and the opposite C1. It's better to manipulate the opposite C1 and C2 joint through the right side. So we will have to remove the soft tissues from the joint, and you will have to curate it till the end plate bleeds. And in irreducible cases also, you can manipulate the C1 and C2 joint. And you can also use the drill to contour the joint for cage insertion. This is the left side. The joint is being curated. You can see the atlas moving. This is the interior aspect of the joint. Here I am using a trimline retractor. You can also use a dynamic thing with the help of a Langenbeck. Once in a while you remove the fixed retraction. to prevent injury to the hypoglossal nerve. So we'll have to, this is the left side, we will have to expose the left lateral mass and use a trial, and if it is difficult to use the trial, just drill out the joint and further proceed. And introduce a cage studded with bone pieces or G-bone so that a good fusion occurs. You can, in case of basilar invagination, you can use a cage along with anterior plate and screw. This is the polyslotted plate. Already a screw is being done on the C2, and you will have to drill out the lateral mass and put the self-tapping screws on the C1 lateral mass. You can also do an anterior transarticular. The anterior transarticular screw is easy to put on the left side compared to the right side. And you will have to expose the lateral mass along with the C2 and use a drill to tap the C1 and C2. Then put the screws so that we can prevent the misplacing of the screws. You should see the lateral mass clearly. You can clearly see and then put. You can make sure that the screw is not too lateral because it can enter the foramen transitory. And you can also do an intraoperative manipulation with the while doing the transarticular screws. This is how you put the screw. You can see the joint as well as the C1 and C2. These are our experiences, a limited experience of 8 cases where the patients had mild hypoglossal paresis or mild dysphagia, which and mild hoarseness also in some cases of superior laryngeal nerve paresis along with 12th nerve paresis. That will improve in, if you are not injured. There is anatomical continuity, it will improve after some time. These are our results of 8 cases. Just going through some cases of bilateral transarticular screws. Extrapharyngeal odontoidectomy. The patient came to the OP walking. There was good fusion also in this case. You can even use a postoperative virtual images to see for your fixation. Even though it has some limitations of a steeper learning curve, technical difficulty, and further research on biomechanical feasibility, still can be considered as a good option when compared to a posterior approach of C1 and C2 fixation. Please go through my editorial in Journal of Spinal Surgery about this. Thank you so much.
Good presentation. For want of time, we will limit the discussion to 1 or 2 questions.
In what cases do you prefer this over the posterior? Is this your go-to approach?
This is only the posterior approach is the gold standard. You can use it. The anterior approach can be used in selected cases only. If you have any associated subaxial pathologies, or you have to do an odontoidectomy along with the procedure, or if you have to deal with infections of the C1 and C2 joint, so that along with this fixation, you can concomitantly do all these. I am not telling it is superior to a posterior approach. It is a good option compared to a posterior. Still, posterior approach is the gold standard.
In cases which requires transoral procedures, this may be a better option.
This is retropharyngeal. We are not violating any mucosa also.
Mucosa.
So,
odontoidectomy also you can do.
You can. I have done 1 case of odontoidectomy. Patient is doing well. Hope once we do more cases.
Good presentation, sir.
Thank you so much.
You told it is limited to cases where this pathology is C2 variable has to be below above C2, no? But in certain situation we can dislocate TN joint, and can we do short neck cases like that?
It's very difficult, technically very difficult. Hope we can improve it further.
Excellent surgeons.
Once you learn, do more cases, you will be able to do.
One more thing is regarding the biomechanical stability of the fusion. unlike posterior procedure, in the anterior space we cannot fill with a bone graft or G-bone or whatever it is. In the posterior there is a lot of muscle left, so we can fill.
Yeah.
So I think the posterior fusion, apart from the instrumental fusion, the bony fusion is going to be a bit less compared to the posterior.
We have not done any research on that. Biomechanical stability
you
need
can
to be
put this
researched.
bone graft into the joint space. The problem is when you use this cage, you cannot put a screw actually.
No. If you put a cage, you can put a plate only.
Plate only. Another thing is this hypoglossal and marginal mandibular injury is relatively is there. And you have shown that it's actually in extended posture. No?
Yeah.
And after that, you will be changing the.
Actually, in the extended position, the joint can get reduced.
While fixing, it will change the position.
No, I am not using any
Same
traction,
thing.
only in the same position. You can even do a manipulation, if at all possible.
Thank you, Vinay, for that wonderful
Thank you so
presentation.
much.
We'll go to the next speaker.
I request sir to please accept a memento and certificate from our chairperson. Thank you. Our next speaker is Dr. Binoy T. Damodar, with innovative ideas, multiple publications, and an associate professor in GMC Kozhikode. He is currently a big name to watch out for.
Thank you, sir. My topic is extraventricular intracranial endoscopic surgery. This name is used to represent the all the intracranial endoscopic surgeries except the intraventricular surgeries. The method of using the endoscope along with the surgical instruments passing along the sides of the endoscope is called endoscope controlled microsurgery. Microscope is something like this. You can see a mountain by standing from far away, but endoscope is like you can go on the mountain and stand on this and see this. Endoscopic surgery can be done as a pure endoscopic surgery or endoscopic assisted microscopic surgery. We are using the transsphenoidal endoscope for these surgeries and not the ventriculoscopes. So I will be showing few cases. This is a pineal tumor, large pineal tumor. We operated by supracerebellar infratentorial approach in 3/4 prone position. Where cerebellum is retracted down, and this is the inferior surface of the tentorium. We can see the pineal tumor here. Compared to the microscope, endoscopic view is far superior. We can go nearer to the tumor and see the tumor. In microscope, we always had a very struggle to operate the pineal tumors. Whether we operate it in a 3/4 prone, sitting position, any position we use, we always had a difficulties. We have to outstretch our hand to reach the tumor in the microscope, but in the endoscope you can reach to any extent in the endoscope to the pineal tumor. And in the microscopic surgery, most of the times the illumination is lost in the superficial structures, and it is very less illumination we get here. But in endoscope, we can totally use its complete illumination. This surgery is done using the 0-degree scope. Only problem with the endoscope is it comes sometimes it gets blood stained, but that can be avoided by you can keep it a little away, or you can irrigate it from outside without removing the endoscope outside. Even the inferior part of the tumor can be removed using this. If still down, if you want to use, you can use the 30-degree, 45-degree, or some of the newer endoscopes have come where you can the endoscope can angulate from 0-degree to 90-degree, which is called chameleon, some chameleon in the stores. So you can go here and you can look down. It was a pineal parenchyma tumor of intermediate differentiation. Coming to the second case, it is a case of left-sided trigeminal neuralgia with severe symptoms. We had a small vessel here, but there was no severe compression of this vessel on the nerve radiologically. But since the patient was very symptomatic, we planned for surgery. Small craniectomy of 2 into 2.5 centimeter was done. This is a pure endoscopic surgery. MVDs we are doing either endoscopic or microscopic assisted endoscopic surgery. This is left side, cerebellum is retracted. This is arachnoid, we are opening the arachnoid. This is choroid plexus. We can see the ICA loop here. This is 7th nerve. And these are the lower cranial nerves. So we have to reorient to the 5th nerve. So this is the 5th nerve, this is 7th nerve. There was no clear, prominent vessel, but there were small strands of the vessels which was compressing the nerve. This is a microscopic view of the same case. We can just compare the difference of the view between the endoscope and a microscope. Endoscope, you can go to any extent, mainly for the deep-seated lesions, deep-seated area with the narrow corridors. Endoscope is very superior compared to microscope. We used Teflon in this case. Previously we were using the pericranium, but now we are using Teflon. The patient was symptom-free after the procedure. Coming to the next case, this is a right side CP angle epidermoid. Epidermoid was reaching very high up. So surgery was done using the microscope, and at the end of the surgery, we used the endoscope to remove some part of the epidermoid, which were not accessible with the microscope. This is 7-8 complex. This epidermoid, this can be removed with microscope also. This part. This is the microscopic view. We can see the difference between the microscope and the endoscope. So coming to this area, this is the 5th nerve, and the epidermoid going above this was difficult to access using the microscope. But the endoscope, you can go to that extent. This is a 0-degree scope. If you still want, you can use a 30-degree scope. You can go inside there and see the lesion. Microscopic assistance in the endoscopic assistance in microscopic surgery will definitely add to the benefit in the surgery. This epidermoid which has gone beyond the 5th nerve, it can be removed. Coming to last case, this is left CP angle, white epidermoid cyst. This is called white epidermoid because it is a T1 hyperintense and there was no diffusion restriction. And it has actually eroded the petrous bone. It has gone till this level and it is arising at the petrous region, and this dura was pushed into CP angle cistern. And then we opened the this capsule. And yellowish fluid with the gelatinous material were aspirated. You can put the cannula and aspirate the fluid. Once it is decompressed, we can open the capsule of the epidermoid cyst. Then we can put our endoscope inside this epidermoid cyst in the petrous area. This all is the eroded part of petrous with a capsule. And remaining part of the superficial part of the capsule is excised. So I want to conclude that endoscope is highly useful while operating in the deep-seated location with narrow corridor. Endoscopic assistance in microscopic surgery will enhance the surgical result of the microscopic surgery. Endoscope should be used more liberally in extraventricular intracranial surgeries. Thank you.
Thank you, Binoy, for that wonderful presentation. Very good videos and for being on time. Any questions from the audience? Do you use any holder during this pineal tumor?
Holder.
Oh, yeah.
So we have used a holder, but we felt it is a dynamically forehand technique is more useful so that we can navigate it.
But you should have a good assistant also.
Assistant. Both should be endoscope. Both of them should be trained in the endoscope. Transpenoidal surgery, if you are trained, then it is very easy to operate. Holder, there are some dynamic holders like endo arms are available, but we don't have that. That can be done easily, but if you use a fixed holder, it is a little difficult.
With the infratendoral supracerebral approach, some of the veins will be there in the bridging veins. Which are the veins we can sacrifice and which are we should not sacrifice?
Usually these cases we saw in that area small
There was
small
no need
strands
for any-
only. So, and if it is a midline, if you have difficulty, you need not go in the midline. You can go to either from the right or left
right.
side. Craniectomy can be done on the either side, paramedian side rather than the midline. You can go from the paramedian region to the lesion.
Okay, if no other questions, we'll move to the next speaker. Thank you, Binoy.
Thank you.
Call upon the next speaker.
Our next speaker is Dr. Sayuj Krishnan, who is trained in Amrita Kochi and has grown ahead of his age and times in endoscopic spine surgery.
I'll be going straight in the case. This is a 34-year-old male working as a somato delivery boy, present with complaints of radiating pain, with radiating pain of the right side. On motor examination, he has grade 5 power node formations, right eye S1 hypoesthesia with a straight leg positive on the right side. This is the MRI showing the L5S1 disc. So this is the interlaminar approach. So we place the CM guidance interlaminar and place the incision till the fascia. This is done under epidural. This is the dilator, initial dilator, and then this is the trocar which is going inside. Patient is completely awake, and through which we enter with the endoscope. This is the initial forceps, the muscle dissection, and this is the flavum ligament. So we start cutting the flavum from the midline and towards the lateral. So initial flavotomy. The epidural, the dura is visible, means root is visible, the inflamed root, and we go till the lateralmost part of the flavum is cut, and then we retract the root, and then this is the disc fragment, and then we slightly rotate the scope, and the disc fragment is extracted out. This was this is the only initial fragmentectomy. that was the initial fragmentectomy, but this was a further calcified disc inside. So again, today morning, Dr. Ajit sir was talking about the removal of the calcified fragment through the endoscope. So this is a knife which we can use to cut further the calcified portion with the knife, and then it was a calcified portion in the upper end plate. And that is being extracted using a forceps. Coming to second case, this is a 62-year-old male with again pain radiating to right thigh and grade 5 power non-fall limbs with THL and dorsiflexion weakness. So this is a L4-5 inferior migrated disc. For a L4-5 disc, usually there is a transfemoral approach also can be done. So this is the initial needle placement, and this is the incision. We insert a needle into the disc space, guiding into the disc space through the Cabin's triangle, and then the dilator. This is done using a rectus spinal block either or using a epidural also. And then we put the trocar again. So initially, after entering the with the trocar, we just rotate the trocar in order to see the epidural, the inferior part of the facet. Sometimes we may need to drill the inferior part of the facet, but again, initial discectomy is done. Intradiscal debulking is done, but the inferior part, after the initial intradiscal debulking, we again this is the bipolar we use to shrink the tissue, and the disc fragment is being extracted. After this, again there was an inferiorly displaced fragment. This is the posterior longitudinal ligament, which is again cut, and then sometimes the disc fragment is in the epidural space, so we may have to remove this posterior longitudinal ligament and then get into the space. So here there was a disc going into the inferior fragment, and then using this bipolar forceps as a dissector, this fragment was removed. So that was the inferiorly displaced fragment. Here you can see the above is the epidural fat. This is the upper and lower end plate, and that disc is being removed. Coming to third case, it's an IT professional with a neurogenic claudication, L4-5 disc with in the axial section. You can see that there is a stenosis, L4-5 stenosis. So here is this is a stenosis scope. Which previously it was an interlaminar and transforaminal scope. We are used the root is visualized on the other side, and then the opposite. This is the opposite flavum, and then this is the opposite root, which is after the stenosis work. The bilateral both sides over the roof decompression is done. The facet part of the facet is removed, and then the opposite root you can see the epidural fat, the dura, and then this is a ipsilateral root, and both sides is free of no instrumentation was done in that. This is a 38-year. This is a 52-year-old lady with low back pain, again with the instability pain, with bilateral EHL weakness. This is L4-5 grade 2 lysosis, and this was the initial planning using navigation. And using an endoscopic trajectory, we put a cage inside, and then using this thing, navigation guided, we have placed the. This is a discitis, again endoscopic removal of the disc, and then starting the antibiotic, and in epidurally, endoscopically we were able to deliver the drug also. So that's the. So that was the case. So the this is the we can do this spine surgery looking up, and that is more ergonomically feasible for the surgeon also in terms of ergonomics. Thank you.
Good presentation, relevant topic 2. Any discussion from the audience?
Cases you said that the calcified fragment you cut with something. What knife you used?
There's a knife with a three-sided knife that comes with the endoscopic instruments, which that can be. There is a sharp instrument.
Okay.
But
So
on one side the root is protected on the one side. So through the tube, if we use that sharp instrument, there is no risk of duraling.
So it cuts much sharper than the conventional number 11 blade.
It's very, very sharp.
The second thing, when you do intradiscal removal of the disc, what's your end point?
In a transforaminal approach, I do the intradiscal decompression just to access the epidural space. That is the only approach, because if the disc protrusion in the epidural space, there is not much point in the intradiscal decompression. If I can get the fragment from the epidural space, I am happy with it.
Good presentation, Dr. Sahaj, Dr. Mahesh from Kannur. The two questions. First thing is, what is the time duration that you generally take for interlaminar as well as for the transforaminal approach?
1.5 hours.
Both the same around?
Around the same, yeah.
And the second question was the second case that you showed, L4-5 migrated disc.
Yeah.
Why did you opt for a transforaminal rather than a interlaminar? Because especially, with a transforaminal, there is a risk of leaving something behind there, because, migrated disc.
Yeah.
So, was there any specific reason? Because I would have opted for interlaminar rather than a transforaminal approach.
Sometimes if the disc is so much lateral, then if you go interlaminar, then to get to the lateral most portion is difficult, which will be more easy if we go subarticular disc, and everything will be more easily accessible to the transforaminal approach. In interlaminar approach, you will directly land into the disc, but this fragment under the facet especially, it may be difficult.
Yeah, we may have to drill some part of inferior lamina. Lamina, it may take a little bit,
more drilling,
more time.
Drilling.
But I felt that, inferior migrated, probably it would have better.
Yeah, both are.
If there is some foraminal stenosis,
yeah.
how will you address?
Foraminal stenosis also, I usually drill I use a drill to drill the lateral part of the facet and go into the foraminal lateral recess part, and then the drill I am not sure. There is an endoscopic as to drilling. Thank you.
Thank you, Saish, for that. There are two concepts which are highlighted, I think. The awake spine surgery and the day case spine surgery, which are coming up now. Yes. So you are able to admit and discharge the patient on the same day?
Same day, yeah.
Very good.
I request our chairpersons to please hand over a memento and certificate. Thank you. We will be moving on to our final speaker for today, Dr. Vythiri. Belonging to a young breed of spine surgeons, he is bringing his knowledge in scoliosis into the neurosurgical sector. We welcome you.
Thank you. Thank you for kind introduction. Very good afternoon to respected teachers, colleagues, and young neurosurgeon. when we discuss the heading, when we discuss about the deformity surgery, this heading is very important because that we is very important because it is not a one-man show. It includes a group of the surgeons, anesthetists, physiotherapists, and neurophysiologists for this particular procedure. The usual steps what we do are first we will identify the patient who need the surgical correction according to the AO spine guidelines, and we do the preoperative workup and full immunology workup. CT and MRI will be taken for all the cases, and PFT echo is done. Then after planning the levels of arthrodesis and osteotomy, we will proceed with surgery. Some patient may need some physiotherapy and postural modification, and patient will be followed at regular intervals. Most of the cases when we see, most of the cases will be idiopathic cases, and our patients will be young teenage girls. So their major concern will be cosmetic issues. But when we give the preoperative counseling, we have to make them clear that we have some scientific goals. We are trying to improve the spinal curvature, not to make it a picture perfect or perfect spine. But if we get a perfect correction, it is good. But our intention is to correct at least up to less than 20-degree corpse angles, and to get a good orthodosis to prevent the progression of the curve, and so as to prevent the long-term complications like pain, restricted lung disease and cardiomyopathy, and restricted cardiomyopathy and neurological issues. She is our representative case. She is a 12-year-old girl. Her complaint is deformity and occasional back pain. On X-ray evaluation, she found to have type Lenge classification we are using regularly, and this is a type 1 A Lenge curve, which means only the main thoracic curve is the structural curve, and another significant curve in the neutral X-ray is the proximal thoracic curve, but it completely reduces on the dynamic X-rays, and the residual curve present in the main thoracic curve was of 45 degree. And we will measure the pedicle dimensions, and we will formulate a plan. In this particular case, I could have gone for a selective fusion as per the new guidelines, but I am not that much confident about the left pedicle dimension. It was only 3.1 into 37 millimeter. The lower instrumental vertebra, that lower screws are very important in during the correction maneuver. So I opted for a regular conventional technique, so that I fix the lower instrumental vertebrae as the lowest stable vertebrae. And after induction and intubation, patient will be positioned to prone. The recommendation is you have to keep the mean arterial pressure between 70 to 80, preferably 80, somewhere near 80, because that will prevent the cord hypoxia during manipulation. And keep the CVP around 10 to 12. All the procedure is done under by using intra monitoring. Temperature probes are kept that because hypothermia can intervene our IOM results. BIS leads are kept, and all is advised to keep the bispectral interest above 40. After this, patient will be positioned to prone. Then we will mark the incision. First, we will mark the spinous processes, then the midline. If you are very confident that we can completely correct the spinal cord, the vertebra, then you can opt the incision over the spinous processes. But as it is a stiff curve, I will go a lazy incision. That is advised in rigid deformities. Exposure is done as the usual superiosteal manner to expose all the vertebrae from to visualize the transverse processes. So we have already formulated a screw plan, and we will be putting the screw in the by the freehand technique. There you can see the facectomy is already done. We regularly do the facectomy along with the screw placement itself. Otherwise, this profile of the screw may interrupt the facectomy. This is not the same patient. This is another patient just to demonstrate the osteotomy. In this case, we have the residual curve of around 45 degrees. So per level it comes only around 5 to 6 degrees. So up to 12 degree we can correct it with a Pondis osteotomy or a SPO, posterior column osteotomy. So we will do a inverted L-shaped incision to remove the inferior facet of the cranial vertebra. That will expose the facets of the caudal vertebra that we can cure it out. You do a liberal facectomy the side, the convex side, so that when we correct that foramen get shorter in that area. So to accommodate the roots, it's always better to do a bigger osteotomy in the convex side. Then we will use a template to check the rods, the dimensions of the rod, and we will mark the thoracolumbar junction and we will bend the rods. This amount to be bent depends on the rigidity of the curve as well as the previous thoracic kyphosis. Then once we fix the rod, now the rod is arranged in a coronal plane. Our next intention is to convert that coronal curve to the sagittal curve. So for that we have to rotate to 90 degree. This is the way we do the rod rotation. And by these techniques, what we are achieving, we have corrected the apical vertebral translation. Now we can see in that diagram the vertebrae are aligned in a straight line, but still it has got some rotation. So two components are for a three-dimensional deformity. One is the translation and the rotation. Now the translation is corrected. Sometimes we need multiple rod rotation to get a satisfactory correction. Actually, I had one more minimal 30 degree rotation, then after this one. Now it's corrected almost. Now next step we have to correct the rotation. So it's a derotation procedure. First we can do it as a segment. Or as a short segment. This derotation is complete. We will put the next rod. That will be a hyperkyphotic curve. Then this is the instrument that we do to use the final derotation. Then after that we can do some compression or distraction if needed. They will do the cortisectomy. Then epidural catheters will be kept and bone graft will be placed. This is the immediate post-op result, and we got adequate global balance. Almost 80% cases will be AIS, adults and idiopathic scoliosis. Sometimes we may encounter with the different cases like this one. This is a neuromuscular scoliosis. We can see a cervical tethering. So before doing the curvature correction, we have to detether the patient, detether that tethering. Otherwise, it may induce focal neurological deficit during the correction maneuver. Another one is it's a congenital scoliosis. We can see a block vertebra at the D11, 12, 11. Here we have to fix the priorities. The maximum amount that can be corrected is 7 degree per level, but we won't be able to do the proper correction won't be achieved by doing a posterior column osteotomy. So, but we have to prioritize it. The patient complaint is to do complaints are cosmetic issues only. Though there was no focal neurological deficit. So I didn't done a VCR for this patient and proceeded with the usual thing. and reinforced with the additional rods and all. But we have done a concave side rib excision and a convex thoraxoplasty. The post-op PFT also shows no much issue with the PFT functions. But this is a little more difficult case. Actually, patient was able to walk 6 months before we meet her. After that, we had a history, some minor accident, and she was severely, powers were severely reduced. So we can see there is a horizontal segment in the deformity. So in this case, we had done a VCR. And patient improved post-operatively, and her LFT functions were improved by 12% in 6 months follow-up. This is another post-infectious sequelae.
Then can you conclude?
Final. It's the final case. It's a sequelae of the childhood TB. Actually, patient presented with severe antalgic gait and postural balance. He was having features suggestive of conus medullary syndrome, and we can see a block vertebrae which it is includes the 12 L1 and L2 level. So he had done an excision, total posterior VCR again done, and we can see the roots. These are the D12 L1 and L2 roots. In this side I sacrificed the D12 roots through which I excised all the vertebral body, and we have kept a spacer there. Actually, his long X-ray is not available because this case done last week only, and he is still in the ward, but he mobilized no much deficit person, and catheters everything removed. Thank you.
It's an excellent work. It is very heartening to see that more and more neurosurgeons are taking up the field of scoliosis, and maybe in the future we may be snatching it from the orthopedic surgeons. So any comments from the audience? Then how do you decide on the lower instrumental vertebrae with reference to the LEV? Because inclusion of more and more lower vertebrae will lead on to excess stress on the lower vertebrae.
Actually, there are recommendations are there for type A curve or lumbar modifier type A. There is a classification there, Lenga classification that we follow. It has got a, not only the classification, some modifiers are there depending on the rotation and the deviation of the pedicule. For A curves, we can keep the we can do a selective or a hyperselective fixation. For that purpose, we can select the end vertebra. End vertebra is the edge vertebra of that particular curve that can be selected as a lower inversion. But in other cases where some other criteria is there, for example, that rotation ratios are, we have to apical rotation ratio and apical translation ratio, and one more thing is the Cox angle ratio. That will be, if the ratio is more than 1.2 in when thoracic is to lumbar, we can go for a conventional stable zone fixation.
Like to add one more just highlight is that this is done totally free of cost. We have around 20 cases now. In the actual cost will be around lakhs. More than at least 8 to 10 lakhs. It is totally free for the patient by the government schemes.
Highly appreciable.
Congratulations for that thing, because this field is actually dominated by the orthospine surgeons.
Actually, our plan is to do at least one case per month, so that we 3 PGs are there. Our kids will be familiarized that this is not pure orthopedistry. At least in the neurogenic and complicated.
Regarding this pubescent girls, it is shown one case. Will it affect their growth?
Which one is that?
Early, when you do it at the age of 12 years.
That is why there are grading is there. Bone age is graded with the research grading. Actually, it is advised not to means is always we prefer to do after research 3, 4 or 5. We will avoid to do 0 or 1. But I had witnessed one case with a research 0 that can do a minimal fixation. It will act as an internal support only.
One more thing is that you don't use routinely this CM imaging guidance.
CM will we will use the CM to check the levels and all. Sir, actually government is contracted with Jayon, so we are now all the implants are for Jayon only. Actually it's not bad implant, it's a good one actually.
Thank you. I would like.
I think I want to say the foreign implants are much better actually. Thank you.
I would like to request the chairpersons to please hand over the memento and certificate. Thank you, chairpersons. With this, we wind up our sessions for today. A few announcements, please. At 4:30 p.m., we will have the general body, and at 5:30 p.m., we will have the inauguration. This will be followed by the banquet at 7 p.m. Certificates for the presenters of today's free paper and posters will be available at the Torrent Pharma stall. Please note, tomorrow the free paper session will start at 8 a.m. sharp. I would like to thank all of you for attending day 1 of our conference. Thank you.